We'll be talking about few questions that has been asked in the past. So I'll be talking about three questions, 3 to 4 questions, and then the other people will pitch in there. We'll wait till 5 minutes past the time, like 4:05, and then we can start after that so that people don't miss out. You are welcome to ask questions in between the presentation. If you want anything to be clarified, I'm happy to do. You can interrupt, or you can keep the questions to the end, or you can post it in the chat box. All right, let's wait till 5 past 4, and then we'll start then. Thrombosis, bit of neuromonitoring, ICP monitoring, followed by Dr. Darshan, and followed by my other colleagues. They'll be talking about a lot of things there. To kick off, I will start. Hopefully you guys can see my screen there. All right. So the first question that I'm going to discuss about is it is a question that was asked in the past in one of the specialty exams.
Sir, sorry, sir. Your screen is not visible, sir.
Oh, okay. Sorry. Give me 1 sec. Can you guys see now?
Yeah, sir. It's visible, sir.
All right, excellent. Okay, so the first question that I was going to discuss about is a question that was asked in the past. It is like a question, if you know about it, you can write it, but I don't think you can fluff around it, because if you don't know about it, then it is very difficult to extract an answer of a very specific pathology or specific management type of question. So this one is talking about cerebral venous sinus thrombosis. So the question asks for outline the neuroanatomy of cerebral venous drainage and give the etiology, clinical features, management of cavernous sinus thrombosis. So very specific about cavernous venous sinus thrombosis. But I'll talk about in general the whole venous sinus thrombosis picture. You can have a different presentation of the question, like most commonly in a pregnant woman with some sort of thrombophilia in the background, presented with altered consciousness, and then what are your differential diagnosis, and then talk about cerebral venous sinus thrombosis, and then questions after that. So that can be one way of asking the question, or they can straight away ask about what do you mean by cerebral venous sinus thrombosis. So let's talk about a little bit of anatomy, which is relevant to your exam, and then we'll talk about the disease per se. All right, so the discussion will happen in the 6 domains. So I'll talk about the anatomy, as I said, bit of pathogenesis and etiology of cerebral venous sinus thrombosis, clinical feature, diagnosis and treatment. That's the straightforward question. Now going to the anatomy, we know that the brain has an extensive both arterial and venous drainage system, which can be divided. The venous drainage can be divided into a superficial venous plexus and a deep venous plexus. That's for more of a way to remember the things. It is easier to classify them in 2 different layers. So first of all, superficial venous system, and then deep venous system. Now, the superficial venous system is called as are called as the cortical veins, which are the major veins that we know by their name. So superior, and that can be divided into 3 zones, like superior, middle, and inferior. The major venous channel that we know in the brain is the superior sagittal sinus. So that's the main part of the cortical venous system, which forms the superficial venous system. The deep venous system is extensive. It comprises of the subependymal veins and medullary vein. They all combine together to form either they form the transverse sinus, sigmoid sinus, or the straight sinus. So the four major sinuses, one of them is in the superficial venous system, superior, middle, and inferior cerebral vein combine to form the superior or drain into the superior sagittal sinus there. And the subependymal and medullary veins combine and form three venous sinuses, which is transverse sinus, sigmoid, and straight sinus. Again, all these sinuses join together and they ultimately drain into the internal jugular vein. Now, infrasagittal sinus join the great cerebral vein to form the straight sinus. So, straight sinus is not as such is a tributary draining directly from the cerebral vein that is formed by the combination of great cerebral vein along with the infrasagittal sinus. Again, the occipital sinus meets the straight sinus at the confluence of the sinuses and from these, blood is drained into bilateral internal jugular vein through the sigmoid sinus. So basically, all these sinuses join together and they drain through the sigmoid sinus into the internal jugular vein. The cavernous sinus, which we are talking about, the question asks about, are drained into internal jugular vein by the superior and inferior petrosal sinuses. So there is another plexus of sinus in the petrosal bone, which superior and inferior petrosal sinus combine together to drain the cavernous sinus, or cavernous sinus drain into those superior and inferior petrosal sinus. The reason why I'm talking about is any infection that is draining from or into the cavernous sinus can spread through these veins directly, causing infection or a thrombosis of these venous system of the brain. Because they are so extensively interconnected, the spread of infection is pretty rampant. That once the cerebral venous sinus, one of them is infected and clotted, then spread of thrombosis or spread of infection can happen very rampantly. Okay. To know about few other things is the arachnoid granulation, which secretes the CSF back to the venous sinus. So whatever CSF you make go through the arachnoid granulation, and they secrete the CSF is secreted through those granulations into these sinuses, or the return of CSF happens through these sinuses. The reason why I'm talking about this is if the sinus is blocked, then the arachnoid granulation will not be able to secrete the CSF back into the systemic circulation. Thereby, there will be more accumulation of CSF in the brain, causing again raised intracranial pressure, raised intracranial tension. So one of the outcome of a cerebral venous sinus thrombus or infection is if the block of the arachnoid granulation, then the CSF will not be drained into the systemic circulation. It will accumulate in the brain, causing raised intracranial pressure or hydrocephalus. Now, a little bit detail on that. So the dural venous sinuses lies between the layer of outer and inner dura mater. So they lie in between the outer and inner, the periosteal layer and the meningeal layer. In between those two layers of the dura mater, these venous channel stay there. Okay. These sinuses do not have valves. That's one of the reason why there is bidirectional flow in there, not a unidirectional flow. And pressure changes on one side of that venous channel can communicate to the other side through the patent venous sinus. If it is patent, because there is no valves, blood can flow from either side, from high pressure to low pressure. Wherever the pressure is high, the blood will flow away from that side. Now, if there is an increase in back pressure, that can lead to cerebral edema due to elevated capillary pressure, because suppose you have blocked off the territory of a supraparietal sinus and the collaterals are also blocked off, then there will be more cerebral edema because the capillaries that is draining into the sinuses become more and more engorged because the blood cannot go further past the thrombosis. In that case, it can cause further edema or brain
So
edema.
sorry to interrupt, sir. Some students are telling, hello, sir.
Yeah, go ahead. Sorry,
Yes,
what is it?
sir, I'm Dr. Bhuvana, sir,
Yeah, yeah.
top member. The thing is, your voice is not audible, sir. It is breaking frequently.
Really? Okay. Is it okay now?
Yes,
Yes,
sir.
sir, you're audible. Yeah.
And now
Okay.
it is okay. Yes.
Okay. So basically, the if you don't want to remember all these things, the line that you need to write in the exam and talk in the exam is any loss of patency to these venous sinuses due to thrombus or infection can lead to three things. One is a cerebral edema. The other is a ischemic infarction because the venous drainage is cut off, and which all of them can cause communicating hydrocephalus. So there are three major pathology that can happen in cerebral venous sinus thrombosis. One is a cerebral edema, second is a ischemic infarction, and communicating hydrocephalus. So these are three major things that can be the outcome of cerebral venous sinus thrombosis. The pathology you can write down straight away, saying that these venous channels are not having any valves. So the pressure changes can directly come from one side to the other side, and if it is blocked, then the tributaries don't drain into that, causing capillary edema, and all these things can happen. All the three pathology that can happen. Am I audible still or not?
Yes, sir, you're audible,
Okay.
but sound is a little bit low, sir.
Okay, right. Not sure
Actually,
why.
voice is low, sir. It's can be.
Voice is low.
Yeah, yeah.
Okay. I don't know. I'm speaking. Okay. I'll try to speak a bit louder. Anyways, so again, going into a little bit more detail of the pathogenesis. So this is a slide from up to date, which is, I think I cannot modify further. It gives you a clear picture what is the major pathologic things that can happen in a cerebral venous sinus thrombosis. I'm not going into detail of the flow chart because nobody will remember that. I would appreciate if you guys can look at these four outcome of the cerebral venous sinus thrombosis that can happen. Okay. This can lead to cytotoxic edema, again, because of decreased capillary perfusion, decreased cerebral perfusion, decreased cerebral blood flow, and failure of energetic metabolism. There is no ATP generation, and because of hypoxia and low blood supply, this can cause cytotoxic edema. This is one of the pathology, or one of the pathological feature. The second one is parenchymal hemorrhage. As I said earlier, if there is increased venular and capillary pressure because of the obstruction in the venous sinus, this can cause venous and capillary rupture and cause parenchymal hemorrhage. This is one of the presentation of cerebral venous sinus thrombosis. When you do a CT scan, you may find a venous hemorrhage in this patient because of capillary engorgement. Okay. The third thing is a vasogenic edema. Again, this is because of disruption of the blood-brain barrier. We'll talk about this edema thing in another question. And the fourth thing that can happen, outcome of all this combinedly can cause an increase in intracranial pressure. As I said, because of CSF impairment of CSF reabsorption through the arachnoid granulation, which get blocked. So there are major four pathologic features that you have to write down in the answer. Okay. There's no sequence of things that you have to remember. This happens after that, but you need to know few important things that happens, right? So these are the few important things. These are the four things that you have to mention in your answer. Now, etiology of cerebral venous sinus thrombosis. Again, classification of the reasons or of the causes is important. There should be a structure to that. So first of all is acquired thrombophilia. This is one of the major cause for cerebral venous sinus thrombosis. That can happen due to use of oral contraceptive. It increases the chances of cerebral venous sinus thrombosis 6 times, and also obesity and people who are on hormone replacement therapy. You may see that people who have migraine and they usually, if they have or they present to the hospital with a very severe headache compared to what the real or usual headache, and if they are on oral contraceptive pill or oral combined contraceptive pill, then this is a very high risk thing. So people who have migraine or present with migrainous headache on oral contraceptive pill coming to the hospital with some sort of focal neurological deficit, your alarm bell cells should ring to do a CT venogram to see whether there is a cerebral venous sinus thrombosis. As you can see, the chances of increased thrombosis is up to 6 times with people on oral contraceptive pill. Pregnancy, again, this is a common, not a common presentation per se, but pregnant women with acute unconsciousness, focal neurological deficit, again, this is a big differential to look at, okay? Antiphospholipid antibody syndrome, sickle cell disease, autoimmune disorders such as lupus or any other autoimmune disease, nephrotic syndrome, dehydration per se, malignancy, all this can cause increased chance. All this can cause as a sole reason to have a cerebral venous sinus thrombosis. Also, heparin-induced thrombocytopenia is one of the cause for cerebral venous sinus thrombosis. The second group of cause is a inherited thrombophilia. So basically thrombophilia, acquired and inherited. Inherited, you know the list of inherited thrombophilia: antithrombin 3 deficiency, protein C and S deficiency, factor 5 Leiden, and hyperhomocystinemia. All this can cause cerebral venous sinus thrombosis. Raised intracranial hypotension, if there is hypoperfusion to the brain due to whether it is hypotension due to a septic shock patient who is actively, or patient who is actively bleeding, or patient who have a raised intracranial pressure, thereby decreasing the cerebral perfusion pressure and low level of intracranial perfusion. In those cases, it can cause thrombosis due to stasis. Head and neck infection, this is a major part which we are talking about, where we are talking about cavernous venous sinus thrombosis. So cavernous sinus thrombosis is usually infection driven in the danger area of the face that we know, which commonly drain to the cavernous sinus. If there is an infection in the danger area of the face, then that can retrogradely spread into the cavernous sinus, causing cerebral venous sinus thrombosis. So mastoiditis, sinusitis, otitis media, even meningitis can cause irritation of the veins, or end arteritis, or end vasculitis. Those can cause, all of them can cause thrombosis of the cerebral venous sinus, including abscess and empyema. Local inflammation can cause those things. COVID-19, we have seen that there is increased chance of cerebral venous sinus thrombosis. By literature, you can search that there is up to 0.1% increase, 0.1% incidence of cerebral venous sinus thrombosis in patients who present after COVID vaccination. Then other mechanical causes: traumatic brain injury, base of skull, important, because if the patient has a base of skull injury, then also with the fracture line going through your cavernous sinus or sigmoid sinus, then that is a high risk for having cerebral venous sinus thrombosis. Other neurosurgical procedures, jugular vein catheterization causing extension of the thrombus can cause cerebral venous sinus thrombosis also. Epidemiology, it is more common in female up to 3 times, with the age range of 20 to 50 years, and accounts for up to 1% of all stroke presentation to the hospital. Now, clinical features, specifically, the most common clinical feature is headache. You can see up to 80% of the cases. So that's why, as I said, migraine, middle-aged women on combined oral contraceptive pill, the headache is not consistent with her usual headache, then it rings a bell that the patient might be having cerebral venous sinus thrombosis. The other findings can be focal neurological deficit, seizure, and encephalopathy. Now, the associated symptoms depend on which part of the brain is involved. But basically, if the patient has a headache, then it will be exacerbated by lying down or Valsalva. Again, this is another clinical sign that you can elicit in these cases. Patient can have nausea, vomiting, diplopia, cranial nerve palsy, particularly cranial nerve 6, and also can have neck pain and occipital pain if there is involvement of sigmoid sinus. Also, if the lateral sinus is involved, then it can resemble ear infection, and earache can be one of the presenting feature for this. Seizures, as I said, usually patient get focal seizure that can be later generalized with worsening of the disease state. Encephalopathy, because of the communicating hydrocephalus, you can have mutism, amnesia. Patient can present with features of cerebral edema like unconsciousness, and then breathing issue, bradypnea, etc., if there is an impending herniation. Now, specific to cavernous sinus, because the question asks for the cavernous sinus thrombosis, so usually cranial nerve 3, 4, and 6 are involved. Along with, you will have facial numbness along the ophthalmic and maxillary division of the cranial nerve 5. You will have periorbital pain and headache. Patient may present with proptosis and ocular arrhythmia because even the blood return from the eye is compromised, and patient can have fever if they have septic thrombophlebitis of the cavernous sinus, specific to the cavernous sinus thrombosis. There's a list of presenting symptoms based on where or which part of the brain is involved and which sinus is involved. This is very, uh, what do you say, clinical expertise based. So if you have sagittal sinus thrombus, you'll have features of elevated intracranial pressure with more of a headache, and there will be papilloedema. Patient may present with seizures. Focal symptoms like you will have, because of the venous infarct, the patient can have aphasia. We talked about that, hemianopsia, hemisensory loss, etc. In transverse sinus, you will have again seizure, headache, but there are multiple overlapping features. But the thing to look for is if you have more sigmoid sinus involvement, you will have cranial nerve 6th, 7th, and 8th palsy because of the adjacentness to the nerves or cranial nerves. And if you have sagittal sinus thrombosis, then you will have a more generalized type of encephalopathy, seizure type of presentation. Of course, this question asks about the cavernous sinus. So in that case, you will have eye pain or ocular pain, redness, and proptosis as one of the symptoms associated with any of those combination of symptoms. But for the cavernous sinus, you will have some eye symptoms with that and oculomotor paralysis. Now, diagnosis. Usually the laboratory diagnoses are not helpful. You may have a high D dimer, which is not here and not there, but sometimes we do it. You may need to do a CSF lumbar puncture because of to rule out other causes of similar presentation. But again, that should be very cautiously done. If the patient have occult signs of raised ICP, it's better to get a scan done before attempting any lumbar puncture. Also, if there is suspicion of cerebral venous sinus thrombosis, you need to look at his history or her history regarding if there is a associated thrombophilia in the past, and also we can see and send a thrombophilia screen in these patients. Imaging, again, this is the most important thing to do. There's some specific signs that you may see in a CT angio. So something called as a cord sign, as you can see. So in this case, the hyperdensity in the superior sagittal sinus, as you can see there, and adjacent superficial cortical vein, this one on the um, cortical vein there. So because of hyperdensity, it looks like a cord. Because of a stasis of venous blood there, you'll see like a cord-like structure, which is called as a cord sign. Again, in a coronal CT scan, you may see the dense triangle sign. As you can see this, there is a dense triangle sign because of stasis of contrast or blood there, which can happen in a suprasagittal sinus thrombus. And again, in a sagittal CT venogram, you may see a filling defect along the sagittal sinus. As you can see, there is filling up to middle of the skull there, and then there is significant filling defect representing there's a thrombus there. And something called as the empty delta sign, where there is confluence of the sinuses. You can see there is a clot there in the center, which is called as empty delta sign, which is enlarged here. So these are the few pathognomic signs on CT angio that you can see. One is a cord sign, then empty delta sign, then loss of the venous marking or filling defect, and you can see a dense triangle. Again, MR plus MR venography is most sensitive, but again, time consuming. In addition to the above, may be helpful to delineate brain edema and infarction if there is an associated early edema, early infarction there. And also, if you have clinical suspicion, but the MR and CT are not very helpful in your diagnosis, then in that case, you can think of a DSA. Treatment, again, this is a tricky part of the disease process itself, because the patient may present with different type of features like hydrocephalus, bleeding, edema, loss of gray white differentiation, all those things. Even if there is some sort of bleeding as a result of the lack of venous drainage, the treatment is still anticoagulation. You have to toss the ball to see which is risk benefit wise, but anticoagulation is the treatment of choice. So immediate therapeutic anticoagulation, irrespective of hemorrhagic venous infarct, intracranial hemorrhage, or associated subarachnoid hemorrhage. Low molecular weight heparin is found to be more effective and safer. That's according to the guideline. Um, the presence of minor hemorrhage in the brain should not preclude you from starting anticoagulation or therapeutic anticoagulation, because it can progress, and further delay in anticoagulation can cause irreversible brain damage. Endovascular thrombolysis or mechanical thrombectomy. If the patient has progressive neurologic worsening despite adequate anticoagulation, that can be considered. Again, this is a very specialized treatment. Not many centers can do it because of the expertise, and there is also high failure rate to the treatment also. Even if you evacuate the thrombus, it would have caused irreversible damage to the brain and may not be helpful. So there is mixed outcome about it, mixed feeling about it going ahead with this procedure. But if it is done, it should be done early rather than waiting for things to be in the irreversible phase and then attempting this. Long-term anticoagulation, again compared to the warfarin, oral anticoagulants, similar risk of recurrent venous thrombosis, death and recanalization, and have shown lower risk of major hemorrhage. So initially heparin or low molecular weight heparin, and then that can be converted into oral anticoagulant. But again, for pregnancy and malignancy, low molecular weight heparin long-term treatment is recommended, and warfarin is the agent of choice if the patient has CKD or has antiphospholipid antibody syndrome. So that's the complete package of the treatment part of cerebral venous sinus thrombosis. That completes that question. The second one will talk about the physiologic factor that determines the intracranial pressure, and explain briefly how intracranial pressure is regulated, and discuss intracranial pressure dynamics in patients with brain trauma. Um, Basically, it is we will be looking or quickly looking at the factors that drives the intracranial pressure in the brain, or any pathology that can change the CSF or the pressure. How do they work out, and what will be the outcome? Later on in the presentation, I think one of my co-speakers is going to talk about management of brain trauma, and in that most of the tear therapy will come. But we'll talk about some physiological aspect of intracranial pressure and how it is regulated. So first of all, again, if they are talking about intracranial pressure, one thing you need to remember is a Monro-Kelly doctrine. So this is a long-standing hypothesis that has been proposed and proven. So the usual intracranial pressure is 5 to 15 millimeter of mercury. And the physiological determinants for intracranial pressures, according to the Monro-Kelly doctrine, is the whole skull is a rigid and closed space, and it consists of three major parts. One is a brain parenchyma, CSF, and cerebral blood and vessels. Brain parenchyma accounts for 1400 gram or 80% of the whole volume. CSF accounts for 10%, and blood and vessels account for 10%. So major part is the parenchymal mass. So any change in the volume of any of these three components, or one of these three component, can alter and can be accommodated or can be compensated up to a physiological limit, beyond which there will be no compensation and the intracranial pressure will rise. So within some physiological limit, if one of them increases, suppose the brain parenchyma volume increases because of the tumor, then the CSF in the whole cranium will decrease, the amount of CSF will decrease to reduce the intracranial pressure, but within a particular limit of physiology. Beyond that, the CSF volume may not be decreased further, and there will be an exponential rise in pressure or intracranial pressure. So going into a little bit more detail, as I said, blood volume, CSF, and brain volume. These are the three determinants of ICP. Any question that asks about ICP, they expect you to write about Monro-Kelly doctrine. Even if you don't mention the name of that, but you have to talk about that the brain pressure is regulated by these three things. Okay. Now going into the first component, the brain volume. Again, the brain volume can be due to the mass, that is the whole brain matter. can be due to the blood, which is outside the blood vessel, or can be due to edema because of extravasation or because of leaky capillaries in the brain. So all this thing can account for the brain volume. As you can see in the graph next to the brain there, the normal thing, you have brain, arterial blood, venous blood, and CSF. These are the compartment we talked about. But if there is an increase because of mass due to edema, then the CSF and venous part will be decreased because they are more compliant. The veins will be compressed and the CSF will be drained from the ventricles to accommodate this much of mass. But as the mass increases, so this is the physiological limit as you can see on the x-axis, but as the mass increases from this part to this part, it crosses or the compensation is lost and there is an exponential rise in the pressure, where you can see there has increase in mass due to the edema and the CSF and venous volume has decreased and also the pressure has increased up to beyond 50. So basically it is a very simple principle, but that's how it works in the brain. We talked about the brain mass, then CSF. Again, the CSF volume is not constant. It is a dynamic process. It is based on how much CSF is produced and how much is absorbed. There is a physiological limit to that, beyond which different pathology can cause increase in CSF production or decrease in the absorption, which can cause accumulation of CSF in the brain, causing increase in pressure. As I said, the production, again, the production is increased beyond a CPP of 70 if it is um, more than 70. So CPP is an important thing. See, what happens is our body aims to maintain a CPP or cerebral perfusion pressure of around 55 to 65 in that range. That's the physiological limit, okay? But when the CPP is less than 70, the production will be decreased, okay? But when the CPP is more than 70, there will be no effect. Saying that because the CSF pressure or the ICP or the cerebral perfusion pressure is more than 70, we don't need further increase in the CSF volume that can again push the CPP higher. So that's why, ICP higher, that's why there is no effect. So if the CPP increase beyond 70 to 80 to 90, suppose you push your blood pressure to 190 systolic or 200 systolic, in those cases, the production will not be affected. It will be a flat line. The production will decrease if the CPP is less. Suppose you need a cerebral perfusion pressure, as I said, of 60 to 65 or 55 to 65. If the cerebral perfusion pressure is less than 50, the number here says 70, but ideally it is 60, around 60. If the CPP is less than 60, then your CSF production also decreases because of low blood volume going to the brain. So in increase in CPP, there is no change in CSF production. But if the CPP becomes less beyond a critical level, which is 70 here, but ideally 60. If it is less than 60, then your CSF production also decreases. All right. Absorption, again, if the ICP is low, the absorption is normal. But if the ICP is high, the intracranial pressure is high, your absorption will be high to reduce the intracranial pressure, because as you decongest or as you take more CSF out of the brain, your ICP will be less. So this is, I mean, to remember this way of what you call the effect of CPP and ICP on the production and absorption of the CSF is very simple. You think of what is beneficial of the body and try to write it down in the way. Suppose if you have a high blood pressure or high CPP, you know that you don't want your CSF volume to increase in the brain. That means even if you have a high CPP, the body has a compensatory mechanism not to increase the CSF volume. So the production remains the same. But if you have a low CPP because of the shock or something, then your CSF production will decrease because it is a pressure dependent phenomena up to 70, right? If it is less than 70 or less than 60, that's the critical number. In that case, the CSF production will be decreased beyond that. If it is lesser and lesser, there is less and less CSF will be produced. Similarly, for the absorption, again, absorption is based on ICP. If the ICP is high, your absorption has to be high, otherwise there will be more accumulation of CSF. But if the ICP is low, there is no change in the absorption. That's how you remember that. Now, blood volume, again, cerebral blood flow and cerebral blood volume. This is a class on itself actually, because cerebral blood flow is managed in a complicated feedback mechanism in the body, which can be a potential question in the exam also. But basically, there are three determinants of cerebral blood flow, which is a cerebral perfusion pressure or CPP, cerebral vascular resistance, and temperature. So cerebral blood flow will increase with increased CPP, with decreased cerebral venous vascular resistance, and also will increase with increase in temperature. Now, if you break it down, CPP again is the determinant for CPP is a MAP and a CVP. So if the MAP is high, your CPP will be high. If the CVP or ICP, whichever is greater, is high, then your CPP will be less, because the CPP is MAP minus this number, MAP minus CVP or ICP, whichever is a greater number. All right. So the CPP is determinant on the or is dependent on the MAP. Now again, your CVP and ICP can raise transiently, or it can be raised sustainedly. First of all, transient rise can happen due to cough, sneeze, vomit. So all this can cause a raise in ICP. If you have a brain trauma patient who has a pressure monitor placed in, you can see there is a transient rise, like every 1 minute or 2 minutes you'll get. So you'll get a transient rise for 1 or 2 minutes. The ICP can go up to 25, 26 with some sort of coughing. If you do endotracheal suction in those patients, the ICP will go up, but again it will come down, right? It's a normal response, because with coughing there is raised intracranial pressure. So in that case, ICP will increase. So going to the determinants for cerebral vascular resistance, PaCO2 and PaO2. Again, you know that PaCO2, higher PaCO2 will cause more cerebral blood flow. More cerebral blood flow increases CPP, increases blood volume in the brain, increases CSF volume in the brain, can cause raised ICP. PaO2 doesn't have much of an effect on the cerebral blood flow unless it is very low. If the PaO2 in the brain becomes less than 50 in the arterial blood, then there is decreased production of CSF, because there will be what you call reflex vasodilatation for that to maintain some sort of blood flow into the brain. But PaO2 less than 50 will be detrimental for the brain. This is a graph which shows your ICP along with the volume of mass according to the Monro-Kelly doctrine. So there is a physiological limit beyond which, if the mass increases, then there will be raised ICP, and there will be an exponential increase in the ICP, which can cause herniation. Now, what happens as a head injury? Initially, there is a change in CSF distribution as the pressure increases. As I said, there will be more CSF distributed, there is less CSF in the brain, more going into the drainage system. CSF is displaced to the spinal subarachnoid space, and there is increased reabsorption rate. We talked about that. Because of raised ICP, the CSF absorption will increase. But later on, there is decrease in cerebral blood volume secondary to decreased cerebral blood flow. Because of the pressure, there will be no blood coming to the brain. Initially, there will be compensation, but later on, if the pressure is beyond a particular level, then there will be no blood supply or less blood supply, which can cause further ischemia and cerebral edema. At the very late stage, where decompensation point, where all the possible structural displacement is exhausted, the cerebral tissue volume is very high, which cannot be contained within the cranium. That can lead to further herniation. Again, herniation is a question in the exam, type of herniation, and what is the outcome of herniation that is being asked in the exam. So you need to look at it also. That can be asked, the type of herniation, how do you classify brain herniation? So this question was asking about the physiology of ICP in the brain first, and the second is what effect can happen if there is progressive increase in pressure in the brain after a brain trauma. Now the third question is we'll talk about cerebral edema, types of cerebral edema, and some ICP measurement device that can be asked as a part of theory, or it can be asked as a part of OSCE. So cerebral edema, again, etiology to start with. So there are different conditions which can be neurological, which can be non-neurological. Again, you should make a habit of classifying any etiology into which is directly related. So cerebral edema, we talk about it is a edema in the brain. So all the causes should be in the brain, but it is not like that. There are some indirect causes that can cause brain edema. So you have to mention in the exam that non-neurological conditions. Neurological conditions are easy to remember. Non-neurological conditions are not easy to remember. You can easily fill the names or fill the diagnosis here, but the main thing is you should not forget that there is a domain which are non-neurological causes that can cause cerebral edema. So neurological causes: ischemic stroke, intracranial hemorrhage, brain tumor, meningitis, encephalitis, cysticercosis, TB, toxoplasmosis, all this can cause cerebral edema as a direct cause of the brain. But non-neurological causes such as diabetic ketoacidosis, lactic acidosis, malignant hypertension, hypertensive encephalopathy, Press syndrome, fulminant viral hepatitis, hepatic encephalopathy, Reese syndrome, some sort of poisoning like carbon monoxide, hyponatremia induced edema, SIADH, opioid abuse and dependence, bites of certain reptiles and marine animals, and high altitude cerebral edema. So these are the indirect cause that can cause cerebral edema in a person. Now types, this is again important, that can be asked in the exam. What are the types of cerebral edema? That has been asked earlier. So basically there are two main types, but you can classify them into three. This will be a complete description of the types of cerebral edema if you go by these three different headings. First of all is vasogenic, second is cellular or cytotoxic, and third is interstitial. So vasogenic is happens due to increased permeability of the capillary endothelial cells, which is mainly due to an incompetent blood-brain barrier. There is more influx of protein from the intravascular space through the capillary wall into the extracellular space. It majorly affects the white matter of the brain. So in this case, you'll have an incompetent blood-brain barrier. So vasogenic edema, incompetent blood-brain barrier. That's the most important thing to remember. Second thing is the cellular or cytotoxic edema, which is seen majorly in a head injury and hypoxic brain injury. This happens due to the swelling of glia, neuron, or endothelial cells due to increase of the toxic factors from neutrophils and bacteria. Cytotoxic edema affects predominantly the gray matter, right? But one can lead to the other. But for your understanding, vasogenic edema is the white matter, cellular or cytotoxic edema is the gray matter. Now, the third type is the interstitial edema, which is seen or as an outcome of hydrocephalus, which causes CSF outflow obstruction, which causes again increased intraventricular pressure, which can cause movement of sodium and water across the ventricular valve into the periventricular space. Mostly seen in meningitis due to obstruction of normal CSF pathway flow. There will be increase in the resistance of CSF outflow also. So three major types: vasogenic, incompetent blood-brain barrier; cellular, more due to the injury of the cells that can cause edema of the cells per se; and interstitial, more of a CSF outflow obstruction that can cause hydrocephalus and consequences of that, right? Three types of cerebral edema. A little bit of pathophysiology. Sorry for an odd looking slide, but so any sort of primary injury can cause a osmolar or contusional swelling, like you hit the brain, that can cause swelling of the tissue directly because of the impact, which sets in very, very quickly, 1 to 3 hours. But there is a secondary injury that can happen from there because of a cascade of different inflammatory things that can happen, which can occur in the following time, right? So this is secondary injury cascade that can cause cerebral edema. Now, this cascade later leads to the cytotoxic edema, as we talked about, right? So in this case, it takes some more time compared to this one. The second part of that, 1 hour to 7 days, which is exacerbated by secondary brain injuries such as hypoxia and hypotension. And this can also lead to the third type of edema we talked about, is the vasogenic edema, which is again bimodal. Initially, it happens in the first 24 hours, and then that can recur at 5 days of the injury. This is more of a pathology or how it happens. You don't have to remember that, but mainly it is the impairment of the membrane that allows more water to sink into the cell, which can cause oncotic death of the cell because of high pressure or high water content in the cells. That can cause oncotic death of the cells. Again, it's an inflammatory cascade. Once the cell is dead, more inflammatory material are released that can cause further worsening of the edema. Again, the interesting thing is this cytotoxic edema and the vasogenic edema are a interchangeable thing. One leads to the other, right? So cellular edema contributes to the vasogenic edema. Oncotic cell death of endothelial cells and some astrocytes cause blood-brain disruption. So you have a cytotoxic edema because of the which can cause death of the cell, which can disrupt the blood-brain barrier or impairment of the blood-brain barrier that can cause a vasogenic edema. The same thing can reverse again, which is a cascade. As I said, it is a cyclic process. One leads to the other and then rebounds back. Okay. So basically, the summary of this slide is you have three types of edema. One is the contusional, straight away it happens because of direct injury. This can set up a secondary cascade of event, which is can cause cytotoxic edema and vasogenic edema, which are interchangeable. The cytotoxic edema later tends to or lead to cause vasogenic edema, and the vasogenic edema further can worsen the cytotoxic edema. That understanding you have to keep. Management, straightforward. You know that what you do day to day, diuretic. So you can has been shown to prolong the reversal of blood-brain barrier osmotic gradient established with the osmotic agents by preferentially excreting water over solute. So if you are giving hypertonic saline to a patient, because mannitol as such is a diuretic, so if you are giving hypertonic saline, then in that case diuretic can help you also to enhance the effect of it. Hyperventilation is a transient phenomena recommended only for short-term control of ICP, as ineffective in sustained effect. The effect goes away because of balance of bicarbonate through the blood-brain barrier. Once it is established, your hyperventilation may not work. But the caution that you have to exercise is never drop the PCO2 beyond 25 millimeter mercury. Even this is too low. As I said, this is a transient time buying exercise till you have something definitive in place to save the life of the patient. Corticosteroid, again, there is no indication of corticosteroid in cerebral edema except chronic meningitis and acute bacterial meningitis under the cover of antibiotics. Also, malignant brain tumor, either primary or secondary, you need to give steroids in the peri-procedural period or in the presentation to the hospital. The patient have to be on some steroid to reduce the edema. Also is a part of adjuvant chemotherapy for CNS tumor, and as I said, perioperative brain surgery. But it is a contraindication for brain edema associated with traumatic brain injury. We know that already. This is a very important thing that is asked in the exam. Um, Steroid in traumatic brain injury has shown worsening outcome and increased mortality. There is no role in traumatic brain injury, but non-traumatic cerebral edema caused by tumor, bacterial meningitis, and chronic meningitis, there is a place for steroids. Other measures that you do, if there is refractory raise in ICP or refractory cerebral edema causing raised ICP, in that case you can consider barbiturate coma, which can reduce the cerebral metabolic rate and subsequently reduces the cerebral blood flow in ICP. And of course, if there is a mass in the brain, that has to be removed. If there is blood, that has to be evacuated. If there is a tumor, that has to be taken out. So, and also if there is recurrent increase in intracranial pressure, you may need some shunting. So these are the possible medical and surgical measures to control cerebral edema. Osmotherapy is a major part. So a little bit of things about osmotherapy. I believe they haven't been asked in most. I could not find a um, question asking about evidence behind osmotherapy. There is not many papers which have compared head-on with mannitol and hypertonic saline. Till date, there is no head-to-head trial. There are some smaller trials, but not a big multicenter randomized trial to show which one is better than the other one. It's based on the practice, how things you do in your practice. Again, Brain Trauma Foundation 2010 surprisingly quotes that retrospective observational studies with raised ICP burden, if you use a hypertonic treatment, there is less number of days where the ICP is more than 25, which is very obvious because you are giving the hypertonic saline, the ICP will be low. Length of ICU stay is also reduced, but the mortality difference is non-significant whether you use the osmotherapy or whether you don't use osmotherapy. Again, the quality of this evidence is very, very low, retrospective observational study. A RCT with 47 patients documented better ICP control with hypertonic saline, which is not a surprise. That's why we do it. But mortality benefit not being shown in big randomized trial, but it is a practice which is very widely accompanied, has been going on for a long, long time, but one of the field where we don't have much clinical evidence, and it will be very difficult to conduct a trial where you have a group where we'll treat the patient with hypertonic saline and we'll have a placebo in the other group because it will be not ethically correct. We know that this is a standard of care, though there is not much of a robust evidence behind it. But if there is a raised ICP, we have to give hypertonic saline. It's very difficult to run a trial where the other group will not be receiving hypertonic treatment and the effect or the treatment group will be receiving the hypertonic treatment. So that's why probably there is lack of evidence at this moment because it is so established in our practice. Now, mechanism of hypertonic saline, again, mechanism of traumatic brain injury is primary brain injury and secondary brain injury. I think Darshan will talk about that later on in the lectures. But there are multiple mechanisms how mannitol and hypertonic saline is asked. I think this is an important topic for you guys to learn because this hasn't been asked in the exam very frequently. So this is a potential question in the exam to differentiate between how mannitol works and how hypertonic saline works and what are the mechanism of action. The straightforward mechanism of action is mannitol works as a diuretic, and also it decreases the blood volume, decreases the CSA production, and decreases the vasogenic and cytotoxic edema. This is straightforward, we know that. But there are a few other things that can be an associated function with hypertonic saline, which includes its anti-inflammatory property. It can have, or it can reduce the level of TNF alpha and other sort of inflammatory markers in the brain, thereby causing less of edema in short term to medium term effect of it, and also enhances the aquaporin expression in the membrane, thereby causing more permeability to water coming out of the cell. So these are the some of the proposed mechanism in addition to the diuretic effect that can happen with mannitol and hypertonic saline. Hypertonic saline has this anti-inflammatory property in addition to whatever property mannitol has. Okay. Basically the mechanism of action is decrease the blood viscosity and increases the microcirculatory flow in the arterial flow and thereby causes decrease in cerebral blood volume. That's the major mechanism of action how mannitol works. But hypertonic saline along with that property has anti-inflammatory property there. As I said, I missed that point again, but Brain Trauma Foundation recommends that although hypoosmolar therapy may lower intracranial pressure, there was insufficient evidence about effects on clinical outcomes to support a specific recommendation or to support use of any specific hyperosmolar agent for patients with severe traumatic brain injury. So they don't support or don't defer the support or defer the use of hypertonic saline. There is no clear-cut guideline from the Brain Trauma Foundation, but the practice is to establish that we cannot do a trial saying that these group of patients will not receive any hypertonic saline if they have a high ICP. That's why I don't think there will be much evidence coming out of this. But later on in the subsequent years, I think there will be head-on comparison between types of hypertonic saline, whether it is glycerol, whether it is urea, whether it is hypertonic saline itself, or whether it is mannitol, which is better and how much should be given. So those trials can come in future, but yes or no for hypertonic saline, I don't think there will be a clear-cut answer because it is so established in our practice. Now going into the difference between hypertonic saline and mannitol, so pros and cons I have written there. So for pros, both hypertonic, common to both, hypertonic saline is superior to mannitol in control of ICP by early and sustained effect, less treatment failure, and controls ICP in cases where mannitol failed, right? These are the benefit of hypertonic saline over mannitol. So they have a more sustained effect, less failure rate, and also can be used where mannitol is not sufficient. Okay. And the benefit of hypertonic saline is that usually do not cause the diuresis. Mannitol does cause the diuresis, that by causing hypovolemia in the patient, right? Now, cons for both the treatment, the initial volume expansion on rapid infusion may precipitate heart failure. Both can do that, mannitol and your hypertonic saline and pulmonary edema. And also abrupt discontinuation can lead to rebound intracranial hypertension for both. That can happen, right? For hypertonic saline, rapid change in serum sodium, risk of cerebral central pontine myelinolysis or extrapontine myelinolysis that can happen because of change in sodium levels. That is a potential risk. Mannitol also is a diuretic, may precipitate acute kidney injury because of dehydration, pre-renal mechanism. Also, local brain edema or rebound increase in ICP due to accumulation of osmotically active molecules in the brain with the damaged blood-brain barrier. So, proposed mechanism is mannitol can cause crystals in the brain by disrupting the blood-brain barrier, which can cause localized brain edema, which can happen with the mannitol. But that's a proposed mechanism that can further lead to worsening of brain edema with ongoing use of mannitol. The last part, we'll be talking about the ICP monitoring devices. Now, not a very frequent use, not a very frequent monitoring system that you guys may encounter. I don't know how many centers in India do ICP monitoring. It is rampantly used elsewhere outside India in developed country, but I'm not sure how much that is done in India nowadays. But there may be a question on this. So basically they can ask about what are the devices that is currently in practice, how do you classify them, what is the pros and cons of those devices. So if they ask about what are the mechanism or what are the devices in practice, so you can measure the ICP both invasively and non-invasively. So invasive is the gold standard, no doubt about it. The gold standard is the external ventricular drain or EVD. The second part can be intraparenchymal catheter such as Codman or a subarachnoid bolt. These are the possible invasive mechanism how you measure the intracranial pressure. Non-invasive mechanism or main non-invasive measures are transcranial Doppler, optic nerve sheath diameter, even imaging such as serial imaging with CT and MRI, and tympanic membrane displacement. Usually they are not very accurate, but can be a surrogate if you don't have invasive measures of ICP, right? Now, this is a figure that shows where the catheter is for a particular modality. For example, the subarachnoid bolt, it is fixed, it is through the cranium, resting on the brain matter. Then you have a external ventricular drain which goes straight into the ventricle. There is something called as a tunnel EVD, nothing more apart from the extracranial courses tunnel in the scalp. And there may be epidural bolt where the tip of the bolt sits in the epidural space rather than going into the brain. And there will be parenchymal measurement also that can sit, the catheter tip can sit in the parenchyma, which is called as the Codman, which is more commonly practiced nowadays. Now, every system has its pros and cons. This is the intraparenchymal catheter, which is called as the Codman. The advantages are this is a unobstructive device, not like the EVD, which can clot off due to the blood clot or some tissue. This doesn't clot off because this is a rigid catheter. It has good waveform resolution. Nowadays, with the newer monitoring, you can see the waveform very clearly and the changes in the waveform. It is very easy to install because you don't have to go through the brain matter much longer compared to the EVD. This sits in the superficial part of the brain and it is less invasive than EVD and also less chances of infection with it. Disadvantages, it lacks the therapeutic uses. Like in EVD, you can always drain some CSF out, drain some blood out if there is blood in the ventricle. But in this case, it sits in the parenchyma, so you cannot do any therapeutic measures through that. It is unable to recalibrate following installation, but nowadays that has been corrected also. Newer device can be recalibrated. The transducer tip becomes obstructed if it comes into contact with brain parenchyma. sometimes because of long stay in the brain parenchyma, because of edema around it, or some clot around it, or some other things around it can cause abnormal reading from the transducer. There is infection risk is there still there. And uh, if it is placed, suppose the brain has infratentorial and supratentorial part. Suppose for a posterior fossa, you cannot place a EVD in the posterior fossa, or you cannot place a intraparenchymal catheter in the posterior fossa. We use an anterior approach into the frontal brain matter. How much is the real pressure in the brain compared to a focal pressure? So it can only measure probably the focal or local pressure rather than measuring the pressure from the infratemporal fossa. So it may not be the exact representation of the pressure in the brain when the site of injury is much away from the site of the catheter. The second one is the EVD. This is the gold standard, health and drainage of CSF and administration of medication, chemotherapeutic agent, antibiotics can be given based on what type of pathology the patient has. Disadvantage, highest rate of infection, associated complication while placement, it can cause bleed, it can cause damage to the brain matter, while removal also it can cause further bleeding and damage. It can cause hemorrhage, as I said. It can cause occlusion, so it may need frequent replacement and all those things. And there is always the inherent chance of infection we talked about. This is the old form of subdural bolt. Nowadays, very rarely used. It doesn't penetrate into the brain, sits on it. Lower risk of infection than the EVD and supposedly easy to place, but I haven't seen one in my practice. Again, disadvantage is you cannot use it as a therapeutic measure. You cannot drain CSF and the accuracy is doubtful. So nowadays, the current practice is these two, the EVD and the intraparenchymal, and also the non-invasive measures, which are the optic nerve diameter, transcranial Doppler, and serial CTs and MRI if you don't have it. So that may be potential viva question. Suppose you don't have the facility for measuring the ICP directly. What are the other things that you can do? So you can do serial measurement with the optic nerve diameter or with transcranial Doppler. In those things can be considered apart from invasive measures. This was my last, oh sorry, there are a few more, sorry. Now, ICP waveform. So how do you determine what is the problem? Usual ICP waveform has three parts or three subwaves in it. P1, P2, P3. P1 is called as the percussion wave. P2 is the tidal wave. And P3 is the dichrotic wave. As you can see in the figure, the P1 waves happens because, sorry, the P1 wave happens because of the arterial pulse. The P2 is vaguely related to the cerebral compliance and P3 is aortic valve closure or the dichrotic notch. So we are more concerned about two waves from here, P1 and P2. So ideally P1 should be more than P2, should be more than P3. This is the normal waveform, right? But when you have a prominent P wave, the systolic VP is too high. That means your blood pressure for the patient is around 200 or 250 by 100 like that, right? If the P1 wave is diminished, if the systolic blood pressure is low, P1 decreases and gradually it can disappear, leaving only the P2 there, okay? And P3 is not changed. That means your systolic blood pressure is low if the P1 height slide comes down gradually. Now, how do you differentiate between this one where the P1 is still there and there is a high P2 compared to here where the P1 gradually diminishes and becomes flat and there is a P2, right? This is the thing to see. Very difficult to mark in practical setting in a monitor, but theoretically, if you have a low systolic blood pressure, then the P2 gradually disappear, but there will be no increase in the P1 gradually disappear, there will be no increase in P2 height. But if you're struggling with the pressure, intracranial pressure, your compliance is low, then your P2 will start to raise up, right? The P1 will be here, the P2 will be more than P1. That's when your intracranial tension is high, intracranial compliance is decreased. So the any sort of mass lesion increasing the volume, the intracranial compliance is decreased. And if you do an inspiratory breath hold, as ICP will also rise, if the P2 is higher than P1, it indicates intracranial hypertension. But I don't think you can do an inspiratory breath hold in those patients because they are not probably breathing spontaneously. But this is very obvious on the monitor where you can find your P2 is more than P1. This can happen, as I said, in two scenarios when there is a systolic blood pressure which is low which is the previous figure, or it can happen when there is real increase in intracranial pressure and decrease in intracranial compliance. This is P2 more than P1. Now, diminished P2 and P3 wave. So if you hyperventilate a patient, initially the P2 will be high, then it gradually comes down with the decrease in the ICP and better, the compliance becoming better, right? If the ICP waveforms become rounded like that, loss of P1, only P2 there, then the ICP is critically high. But again, this will tell you a number which corresponds to somewhere between 30, 40 or whatever number there on the y-axis. So you don't have to go by the shape. But as for your understanding, it becomes rounded, loss of P1, only P2 there, then it is very high ICP. All right. I think that was the last slide. I cannot see any questions because I'll take some questions if there are any, otherwise I'll hand over to, okay, there's no questions in the chat group. Then I'll hand over to my next speaker, which I think is Darshan. If you guys have any questions, please post in the chat group or please post in WhatsApp. I'll try to answer them. Okay.
During
Any
which
questions
monitoring
if you
we
have?
get this, during which monitoring do we get these waves, sir?
Sorry?
During which monitoring do we get these waves? EVD.
EVD, okay. So you will get in both actually. You will get your EVD waveform, P1, P2, P3, and also you can see them in the chord band.
Okay.
Both of them, but EVD will have a more prominent waveform, P1, P2, P3, that will be more prominent.
Okay.
Yeah, because see, all the pressures are transmitted pressure. So irrespective of sort of monitor you use, the variation will be there. Only the discretionary power of the monitoring system is important, which can differentiate between pressure changes, P1, P2, and P3. You can see in both type of monitoring. All right then. Darshan,
Hi,
you
sir. I'm here. Yeah. Yes. I think so. We'll start with the next talk because there are no more questions, right?
I can't see any. So
Okay, sir. Well, is my slide visible, sir?
yes, we can see.
Okay. So, good evening, everyone. I hope I'm audible. So, the next talk is on traumatic brain injury. After a wonderful explanation about the cerebral physiology, ICP, the physiology of cerebral autoregulation, and the management of raised ICP, I think so. It's really easy for me to carry on with that background to the concept of traumatic brain injury and the management of traumatic brain injury. See, the outline of the talk would be based on the following headings like introduction, pathophysiology, diagnosis, management, and guidelines and few evidences. So the questions which have been asked in the previous question papers, one was describe the types and the immediate management of traumatic brain injury in the FNB exams. And there was another question on mannitol and hypertonic saline indication advantages and disadvantages as recently as in 2022. So, coming to the introduction, traumatic brain injury, as we all know, refers to the brain injury that is caused by an outside force. It can be a forceful event, or it cannot involve. Usually involves a forceful trauma to the cranium. It can either be a penetrating type of a traumatic brain injury or a non-penetrating traumatic brain injury. Penetrating traumatic brain injury happens when an object pierces versus the skull, example like a bullet, a shrapnel, or a bone fragment, and the brain tissue is penetrated. Non-penetrating type of traumatic brain injury is usually a closed head injury or a blunt traumatic brain injury, as it also is known as, is caused by a force which is enough to move the brain within the skull, but it does not cause any break in the cranium. This usually happens in falls, motor vehicle accidents, sports injuries, blast injuries, or by being struck by an object. So, coming to the etiology and epidemiology, the Western data from the CDC suggests that 1% usually happens during suicide, 20% more or less during the vehicular accidents. But if we see India's epidemiology and etiology, the RTAs take a humongous share. Actually, up to 60% of the traumatic brain injury in India is caused due to road traffic accidents. Mostly around 15 to 20% is usually involved with intoxication with alcohol, and the fatality rate is quite high. That is around 70 per 10,000 vehicular accidents. The mortality rate in severe TBI ranges up to 43%. That is, one person dies in India every 6 to 10 minutes. So we, by these things, we usually understand that not only RTA, there are other probabilities and issues which are causing traumatic brain injury. It's usually the bystanders also, not only the one who is driving the vehicle. So pedestrians also add up to around 25% of the caseload of traumatic brain injury. So, coming to the classification of traumatic brain injury, it is classified into mild, moderate, and severe based on the Glasgow Coma Scale. Mild traumatic brain injury is usually between a GCS of 13 and 15, moderate is between 9 to 12, and a severe traumatic brain injury is when a person's Glasgow Coma Scale is less than 8. So any patient who walks into the ER or comes into the foray of a medical attention, the initial assessment for any trauma case should be under these three headings. That is the primary survey, the secondary survey, and the tertiary survey. So this is the common protocol for any question you get in the exam based on trauma. It may be it penetrating abdominal injury, penetrating thoracic injury, or a traumatic brain injury. Whenever you get these questions in based on trauma, please answer them under these headings. So the primary survey usually, assesses the most catastrophic event at that point in time and tries to stabilize that. So usually the ABC, that is the airway, breathing, and circulation, disability and exposure and environment is usually taken care of, and the most important damage control is done during the primary survey, be it hemorrhage control, spine stabilization, or any other catastrophe which might lead to imminent death. The secondary survey usually is started after the primary survey has been established. That is, some amount of hemodynamic instability has been achieved. So after that, the secondary survey usually contains detailed history taking of the event and has a systematic head to toe examination of the patient. And once these two are done, the tertiary survey is usually done after 24 hours when we have complete understanding of the patient. Not going into much detail about that, I would like to delve into the Glasgow Coma Scale. The Glasgow Coma Scale was invented by Teasdale and Jennett in 1974 and usually was used to assess the neurological status of any individual. And it comprises of three broad headings and usually is a score ranging between 3 to 15 and utilizes three major responses based on eye-opening, motor response, and verbal response. The best is be around GCS of 15 and the least being 3. I think so most of us are aware of how to assess GCS. So do you feel that there are any drawbacks of GCS? I would like the audience to unmute and talk about. Is this a foolproof mechanism to go ahead? What are the drawbacks of GCS? So whenever
Brainstem is
yeah, please tell me.
the brainstem findings are not.
Excellent, excellent. One of that is brainstem. Go on. Okay, so it was actually not intended to score the most important thing. It was just for T. It was not intended for T by A per se. It was generally to assess the neurological status. It does not incorporate brainstem reflexes, as one of you told. It does, the M score does not factor into the unilateral pathology. If there is a unilateral pathology, we don't write anything about it in GCS. it is unreliable in patients with middle range GCS, that is between that is the moderate traumatic brain injury cases. So if you have a patient with a GCS of, say, suppose 4, the mortality rate depends on the individual components. So that based on just the number, if you say the patient's GCS is score, we cannot predict the mortality. That is one of the major drawbacks. For example, if you have a patient's GCS being 4, that is EVM being 1, 1, and 2, it has a mortality rate of roughly around 48%. The same GCS of 4, if the EVM component is 2, 1, 1, the mortality rate decreases up to 19%. So this is something that could not be carried forward, or any conclusions could not be done based on just the assessment of Glasgow Coma Scale. The other limitations usually appear while doing the assessment itself. Um, Whenever you have these applications, right, we usually face this issue that young nurses or young intensivists or clinicians, when they come into the ICU, they also make errors in assessment of GCS. It has also been seen that neurosurgeons are no less behind. They are up to 50% of the times, even they get the GCS assessment wrong. So variation in the score usually happens when the V is involved. That is whenever we have intubated patients. So we just write it as VT. Subject barriers can cause a lot of issues while assessment of GCS in the verbal responses, and it cannot be applied for small children. And it can be influenced by altered level of consciousness. Say, suppose the patient is under intoxication of alcohol, or the patient has been heavily sedated post seizures. These becomes a big drawback for GCS. So the validity for the use of GCS in toxicology is not there, and GCS per se for TBI does not show any good overall prediction model. So having said a lot of this, are there any other tools available that you guys know of apart from GCS?
Postcode.
Fourscore, very good. See, one of your questions can come as this itself. What is a Glasgow Coma Score? And outline the limitations of the same. This is one thing we are thinking is quite valid to come because it's used extensively. Okay. One of you excellently told, the other tool is the Fourscore. So Fourscore, what are the advantages? The advantages would be the use of a brainstem reflex as compared to the Glasgow outcome score. I'm not going to individual things here, but what I want you to look into these the four score is the two important things, that is the brainstem reflexes and the respiration. So if even though the patient is intubated, we are having some sort of assessment about the patient's respiratory status. Along with that, brainstem reflexes give us a deeper idea and understanding about the level of injury in the cranium. So this also helps us understand the patient's severity of damage. So these two are the advantages of Fourscore as compared to the Glasgow Coma Scale. So there is another tool called the AVPU tool, which is usually used as a screening tool whenever a patient comes inside the ER. Okay, so this is not something that can replace Fourscore or it can replace Glasgow Coma Score, but this is one of the earliest tool which is usually done as a screening tool, so that you can get the results as early as possible. One of the major drawbacks with the Fourscore or Glasgow Coma Score is the time involved in assessment of GCS. Whenever you have a patient coming with a severe traumatic brain injury or a moderate traumatic brain injury, a big, massive trauma, patient might not be hemodynamically stable. So this assessment would take time and further leading on to worsening of the clinical status. So in that case, AVPU can give you a better understanding or a faster assessment of the neurological state. So coming to the symptoms of traumatic brain injury, whenever we have a patient with a mild traumatic brain injury, usually these are 90% of the case load which we see. The symptoms will be as trivial as headaches, dizziness or fatigue, sometimes sleep disturbances, or cognitive dysfunctions in the initial period. Sometimes even the patient can be in lucid interval and then appear to be in a moderate to severe TBI, but after some time, when we reassess this patient, probably they have only mild TBI. Whereas, contrastingly enough, in moderate to severe TBI, which accounts to a caseload of roughly around 10%, patient can have signs of neurodeficit like slurred speech, confusion, seizures, persistent headaches, and sometimes may be in profound coma. So there is a Canadian CT score rule, which is usually taken into consideration whenever we get a patient And after our initial assessment of the GCS based on GCS or AVPU or the four score, that we need to do a neuroimaging. So whenever the patient's GCS is 13 in the emergency department, or if there is a drop in GCS after a 2 hours period, if there is an open or a depressed skull fracture, skull base fracture, usually having signs of hemotympanum or panda eyes, or signs of CSF leak or a battle sign, post-traumatic seizure, focal neurological deficits, more than one episodes of vomiting, hemodynamic compromise of systolic blood pressure of less than 90, patient having an LOC of more than 30 minutes. All of this with an elderly age group population with the prior history of coagulopathy warrant for an emergent non-contrast CT. So this is the Canadian CT rule. So this question most likely would be asked in your Viva. So please have a look. Okay. So this is something that you need to know: penetrating injuries, signs of base of skull fracture, post-traumatic seizure, new onset deficit or focal neurological deficit at presentation, prolonged loss of consciousness, persistent vomiting, or signs of raised ICP, elderly age group or coagulopathy, get a non-contrast CT. Or if the patient has a dangerous mechanism of injury. Whenever we say dangerous mechanism of injury, it refers to patient being associated with the death of a person traveling along with them. So whenever you have such sort of RTAs, it's always fair to get a CT for this patient as well. What are the forms of TBI that are present? It can be classified as extradural hematoma, subdural hematoma, subarachnoid hemorrhage, diffuse axonal injury, cerebral contusion, and skull fractures. So whenever you get a patient to the ER, got an NCCT, the Marshall score can be one of the earlier CT scores that you can apply to understand the complexity or the level of problems to assess. So the Marshall score usually involves three major issues, that is midline shift, presence of blood in the cisterns, or the density of the lesion. So based on these parameters, the Marshall score is graded between 1 to 6. So another important thing that is involved in CT guided assessment using Marshall score is whether the patient had a previous surgery and was there any surgical evacuation also being done. So that is one thing that also is incorporated in the Marshall score. What is the other score which is used in the CT-based assessment? Okay, so the other score is Rotterdam's CT classification. So these two are the things that you guys need to remember the names, not necessary to know the individual components. If they are asked, they mostly will be asked in your Viva. If you can answer them, well and good. Even here, the parameters which are used are the presence of blood in cisterns, or what is the status of the cistern, presence of midline shift, whether the mass lesion is present or not, and the whole score is summed up. So whenever you have a score of more than 1 or 2, it usually indicates the presence of a moderate to severe traumatic brain injury. So how do you differentiate between Marshall and Rotterdam? The two classifications more or less are similar. The only thing is Rotterdam has a better discriminative index and usually comparatively has less interoperator reliability as compared to Marshall score. The other advantage of Marshall score over Rotterdam is it usually takes into picture the surgical status of the patients in the in the CT guided assessment. So only thing is, Rotterdam scores better also in the part that it can have an ordinal based assessment. That is, numerical based assessment can be done easily with Rotterdam as compared to Marshall score. So just remember the names of these two. Otherwise, individually, I wouldn't suggest you to break your head about it. Remember, there are two names, that is Marshall and Rotterdam. This is CT guided based on the midline shift, based on the presence of blood in the cisterns or the status of the cisterns, and the density of lesion. That these things are more than enough. So coming to the subtypes, we discussed about the forms. What are the subtypes of traumatic brain injury? Usually, it can be broadly classified into focal or a diffuse type of a traumatic brain injury. Coming to the focal type of traumatic brain injury, it can be either a contusion or a hematoma. When it is a hematoma, it can range from epidural hematoma, subarachnoid hemorrhage, subdural hemorrhage, intraventricular hemorrhage, or intraparenchymal or an intercerebral type of hemorrhage. The other type of focal type of a traumatic brain injury is a penetrating type of injury. Coming to the diffuse type of traumatic brain injury, it can range from concussion, diffuse and axonal injury, blast-related traumatic brain injury, and in a pediatric or a neonatal scenario, it can show signs of abusive head trauma, which is usually associated with battered baby syndrome. So coming to the individual types, I would not much delve into the details, but I would like you to know that extradural hematoma usually comprises of around 8 to 10% of the traumatic brain injury. The one thing important in this image that you need to know is recognition of an extradural hematoma. It is usually lentiform, that is lens-shaped hyperdensity on a non-contrast CT. The hyperintensity usually tells the acuteness of the event. Most of the time, extradural hematoma, the patients have a lucid interval whenever they come and present to the ER. So if you have a patient having a lucid interval after the traumatic exposure before even getting a CT, you can suspect the possibility of a extradural hematoma. Usually, the spread of an extradural hematoma is limited by the suture lines, where the dura is usually adherent. So this is one of the differentiating features that you need to remember. Lens shape, lucid interval, and limited by the suture lines. Coming to subdural hematoma, usually accompanies roughly around 20 to 25% of the traumatic brain injury. Here you can see that it usually is crescentic in shape. Here you can see one has hypodense, another one has hyperdense. Based on this, you can tell the acuteness of the subdural hematoma. So usually unilateral subdural hematoma, the midline shift, if it is less, does not cause much of an issue. But when the midline shift is more, then emergent treatment would be necessary. The subdural hematoma is usually caused due to the tearing of the bridging veins, usually which are present over the cortical surface. And sometimes even the major venous sinuses can also be involved. Subarachnoid hemorrhage is another subtype of or a form of traumatic brain injury. This usually involves the presence of blood in these external spaces. Only thing that we need to know is you should differentiate it between an aneurysmal versus a traumatic subarachnoid hemorrhage. I'll be talking about in detail in the next subsequent talk on subarachnoid hemorrhage. Diffuse axonal injury is another subtype of traumatic brain injury. Usually, what you see in the MRI is actually a better neuroimaging modality as compared to CT for the diagnosis of diffuse axonal injury. Lacerations, punctate contusions at the interface between the gray and white matter is usually what is seen. Better done if it is after 24 to 48 hours following injury. It's usually divided into three grades, that is DAI grade 1, 2, and 3. Grade 1, usually only microscopic evidence of axonal damage is present, usually involves the brainstem area, corpus callosum. Very rarely, it might also involve the cerebellum. So grade 2, focal lesion, usually in the corpus callosum, with addition to the changes which are already seen in grade 1. Grade 3, focal lesions in both corpus callosum as well as dorsolateral quadrant of the rostral brainstem, in addition to the changes seen in grade 1 and grade 2. So usually this is what is the classification of diffuse axonal injury. Other subtypes are cerebral contusion and skull fracture, which I've already spoken to you in detail. The only thing which we need to keep in mind is the presence of cerebral CSF leak, involvement of cranial nerves, etc., which actually causes more morbidity to this patient. So these things are something that has to be assessed, evaluated, and documented when we have a patient with traumatic brain injury. So, what are the goals of care whenever we have any patient with traumatic brain injury? This is one of the important questions, both theoretically as well as in practicals, which they ask. So, whenever a patient comes with you to the ER and you're evaluating, what is your goal of care for a patient with TBI? So broadly, you can divide them into your first survey-based assessment of primary, secondary, and tertiary. You have secured the ABCs done. So airway, as soon as you see the patient is having a GCS of less than 8, secure the airway. maintain adequate respiratory support to this patient, make sure the SATs are more than 97%. Usually, PaO2 should be roughly more than 80 millimeters of mercury, and the PaCO2 should be hovering around 35 to 45, and it shouldn't be reduced below. The reasons for that was already mentioned in the previous class. The other thing is to maintain optimal cerebral perfusion pressure. The CVS parameters also should be maintained. So, the mean arterial pressure of more than 80 millimeters of mercury is supposed to be present. Along with this, you have to adequately treat other issues, that is mostly the metabolic problems. Avoid swings of blood glucose, that is prevent hypoglycemia and hyperglycemia. Avoid hyperthermia. These are the basic goals of care in TBI. I'll be dealing in detail about these individual things, but whenever they ask a question of goals, please remember under these headings. So all this, whatever we spoke about, even in the previous class about ICP management and cerebral edema, the whole thing about the traumatic brain injury is a balancing act, that is to maintain the metabolic supply to the brain and to reduce the demand. So these two things are very important because the cerebral autoregulation is altered in a patient with traumatic brain injury. All that we need to know is when the cerebral blood flow, as mentioned in the slide on your right side, is critically below 20 ml per 100 grams of the brain tissue per minute, the brain goes into a pro-apoptotic pathway, and after that, it is a downhill road, and the recovery from that phase would not be good. So we will lose much more tissue. That causes secondary brain injury. So the whole point of management or neuroprotection, as what it is called in traumatic brain injury, is to prevent secondary insults. So how do we do prevent secondary brain injury, or what are the secondary brain injuries? It can range from axonal injuries, excitatory or excitotoxic injuries, toxic proteinopathies, which can happen because of other issues in the brain apart from only traumatic brain injury, functional impairment, mitochondrial dysfunctions, which can happen because of poor perfusion, neuroinflammation or neuroinflammatory cascade activation, or if the patient is not having any sort of recovery or compensation which is being done at that particular time, can lead to autophagy, apoptosis, finally leading to necrosis and loss of tissue. What happens is the penumbra is something which we are looking at, and salvaging the penumbra is the primary goal in management of a traumatic brain injury. So the targets to sorry,
I'm
ma'am.
sorry. I'm sorry to interrupt. Just
Sure.
can you hide your the Zoom sharing? Yeah.
Sure.
Okay. Thanks. Yeah.
Okay. So coming to the targets to avoid secondary injury, these are the grid or the target grid in neuroprotective mechanisms or neuroprotective management. So whenever someone asks you what are the targets or what is the neuroprotective grid, this is what you need to mention. The ICP should always be less than 22 millimeters of mercury. The cerebral perfusion pressure should always be more or less more than 60 millimeters of mercury. The systolic blood pressure ranges between 80 to 100 millimeters of mercury. The partial pressure of oxygen should be more than 10 kilopascals, roughly around 80 to 100 millimeters of mercury. Oxygen saturation more than 95%. PaCO2 between 35 to 45 mm of Hg. Avoid hyperthermia or pyrexia. No need for any higher temperature regulation to reduce it, but avoid active fever. So actively manage the fever whenever it is present. Hypoglycemia should be avoided. Similarly, hyperglycemia is also detrimental. So keep a target between roughly around 180 to 200. Below that also is detrimental. And the serial sodium value, but if you go by Brain Trauma Foundation, what they suggest is 145 to 155 milliequivalents. Here they're roughly telling about 140 to 150. There are two major uh, uh, you know criterias or the compendium which are present, that is the Brain Trauma Foundation or the American Stroke Association. So based on these two authorities, the values can mildly change, but grossly there is no much difference in them. So coming to the airway management, as I've already spoken, when there is a GCS of less than 8, the patient is unable to maintain reflexes or there are signs of hypoventilation, better to intubate the patient. Always remember, whenever you have a patient with trauma, rule out the possibility of a C-spine injury. Use the Nexus score. After that, you can use even the manual inline stabilization for securing the airway. Always be careful. This is always an anticipated difficult airway. So use your other assessment of difficult airway algorithm. Can anyone tell what is the difficult airway algorithm mnemonic? Okay, you can use a score called as the Makocha score, which you have to know. Okay, so this is one of the things that you need to remember. I just wanted to ask a pop-up question. So coming to the next thing after the airway management, that is the blood pressure and the cerebral perfusion targets. That is systolic blood pressure more than 100 millimeters of mercury is what is supposed to be done. That is a broad blanket statement. But what BTF says is you need to have an age-based criteria. Whenever the patient's age between 50 to 69 years old, maintain the SPP more than 100 millimeters of mercury. But if it is a younger patient that is between the age of 15 to 49, or if the patient's age is more than 70 years, maintaining a higher target, that is a systolic blood pressure more than 110 millimeters of mercury, was shown to decrease the mortality. But the level of evidence is poor, that is level 3. So the ideal thing would be to maintain the cerebral perfusion pressure, which was between 60 to 70 mm of Hg. So whatever said and done, there is no clear-cut idea which is better, either 60 or 70. That is always dependent on the cerebral autoregulation of that particular patient. So whenever you have a patient whose ICP is fluctuating a lot, that directly as acts on to the mean arterial pressure, and the cerebral perfusion can go down. So you need to individualize this based on the ICP management as much as possible whenever you have the measurements available. So whenever you have this, always avoid that there should not be any aggressive treatment to maintain the cerebral perfusion more than 70 mm of Hg. What I mean by aggressive attempts is don't overload the patient by fluids whenever you see the patient is having a low BP. Optimize these patients. Always have your bedside ultrasound. Do your hemodynamic assessment. Based on this, choose an inotrope, because always the first 24 of traumatic brain injury, the patient will have a sympathetic overdrive, and always they will be prone to have cardiopulmonary complications. So this is something that we need to know. So what BTF suggests is don't do any aggressive methods, but reassess your patients and be very judicial in administration of fluids and pressors. Avoid albumin as one of your fluid of choices, as the SAFE study has already shown, very detrimental results when patients were given albumin solutions for volume replacement. Coming to ICP monitoring and management, there is no evidence that which modality needs to be used. But what the Brain Trauma Foundation says is there's level 2B evidence for ICP monitoring in any patient who has a traumatic brain injury. And this has helped to reduce the 2-week post-injury mortality. So which patient needs it, how long it is supposed to be there, these things are still left to the clinical judgment of the treating physician. So it always suggests another thing, that whenever the ICP is more than 22 millimeters of mercury, ICP reduction measurements have to be initiated at the earliest. So previously, sir had spoken wonderfully about how the cerebral edema sets in, how this ICP goes up, and what are the detrimental effects that can happen. So the tire-based approach is what someone can ask you in your exams for the management of traumatic brain injury. The patient with traumatic brain injury, or any patient who has a bleed in the brain, the treatment goes in a tire-based approach. The goal would be to reduce the ICP. So the treatment or the tire is triggered whenever the ICP goes more than 22 millimeters of mercury. The tier 1, or sorry, the tier 0 is the standard measures which has to be attributed to all patients, irrespective of whether the patient has a raised ICP or not. Okay, these are the mandatory things that you have to do at your bedside. Always see whether the ABCs are stable. If there's patient is under pain, treat the pain. Make sure the head is in neutral position, the head end is elevated, there is no hypothermia, and if there is any dyselectrolytemia or any other issues which are present, that has to, metabolic issues that are present, that has to be attributed. There is one thing that you might be seeing on the slides, that is steroids. This is level 1 evidence that it should not be given in a patient with a traumatic brain injury because it's directly attributed to increased mortality. But if your patient has a traumatic brain injury, the ICP is not coming down with your regular treatment, and your patient has a probable neurosurgical issue like a brain tumor or an abscess or a non-infectious inflammatory condition, only then you can use it. Coming to the tier 1 measures, it usually encompasses hyperosmolar therapy, temporary hyperventilation, CSF drainage, and consider surgical decompression as early as possible. The most important thing is hyperosmolar therapy. It's already been discussed previously. The whole idea is to start them on a hyperosmolar solution like mannitol or hypertonic saline and to get the ICP down. But this takes time, right? So because this takes time, usually a bolus is suggested. Even the bolus would take some time to get it down. So what has been proven is whenever you have a patient showing raised ICP and your Lundberg waves are persistent in the critical phase, that is the rounding of the ICP waveform of P2, that time you can do a temporary hyperventilation. That is, the target should be roughly around 30 to 35 mm of Hg. The best practice statement here would be to use an end-tidal carbon dioxide. So if you have an end-tidal carbon dioxide and you can ventilate the patient, you can safely assume that you're not causing any decrease in cerebral perfusion. Okay, so CSF drainage and surgical decompression would be considered as the final step whenever you have a patient whose ICP is not being managed with hyperosmolar therapy or temporary hyperventilation. This is just buying time. Coming to tier 2 measurements, you have started your hyperosmolar therapy, but the goals, that is what I mentioned earlier, that is 145 to 155 as per BTF 2016. If it's not reached, try and achieve that as early as possible. Repeat a fourth hourly or a sixth hourly serum sodium, calculate your serum osmolarity, and try to achieve this as early as possible. You have to optimize sedation and analgesia in such patients because these also can cause neuroexcitability induced raised in raised ICP. A rescue decompression should only be considered in a life-saving procedures. You have done all these things, and still, if the patient is unable to maintain his ICP and ICP is very high, then you can think about using sedative protocols or barbiturate coma, or you can continue using hyperventilation. In extreme rare cases, hypothermia has also been set in. That is moderate hypothermia with a core temperature of 32 to 34. Whenever you're using sedation or a barbiturate coma or you put propofol-based solutions, the most important tool that has to be present at the bedside is a continuous EEG monitoring to obtain burst suppression. So that is the target when you have to induce the patient into a comatose state. So that is the goal that we need to achieve. I will come to temperature-based assessment later on. The step ladder approach is similar to a tire-based approach. I wouldn't be going. This is another thing that you can go in a practical approach. The whole thing is similar to that. GCS less than 8, more than 22. You start using all your ICP reduction tools. The whole idea is to reduce it with the medications itself. If not possible, go for decompressive craniectomy. If not achieved, the status is not achieved, that is ICP less than 22, you go in with the barbiturate coma and hypothermia. Sir has already spoken about this in detail. That is the differences between mannitol and hypertonic saline. I'm not going much into detail, but these two slides actually give you much a broader perspective and a question based on the advantages or disadvantages of mannitol versus hypertonic saline, which is superior over the other. The debate will go on, I guess, because of the reasons which sir has already mentioned before. So what we need to know is mannitol causes more osmotic diuresis, can cause hypotension, can cause cerebral perfusion pressure to drop in the initial phases. But overall, there is not much difference between mannitol versus hypertonic saline. Both are more or less equally efficacious in the achievement of see higher serum osmolarity and osmotherapy. So there are other things that we need to think about when it comes to hypertonic saline. That is the anti-inflammatory effects of hypertonic saline, the volume expander capabilities of hypertonic saline, and there is something called as a permeability coefficient, which is actually better in hypertonic saline as compared to mannitol. Even if you see that the number is quite less, it's by zero point 0.1. But these are just numericals and these are just theoretical issues. Overall, a start in osmotherapy is what you need to know. You just need to know these headings. That is, what are the indications? What is the dosing? Dosing of mannitol is 0.25 grams per kg to 1.5 grams per kg. Then boluses as needed in fixed intervals. When you start with hypertonic saline, depending on whether you're using 2, 3, or 7.5 or 23.5, mostly in India we have 3% NS. So usually you should know how much ml per kg per body weight is supposed to be used. Usually it is 3 to 4 ml or 2 to 3 ml per kg body weight, and then you have to give it as a bolus and then titrate it accordingly. So the whole idea is to reach the osmolarity in the patient. And the osmolarity that is supposed to be achieved is roughly between 310 to 320 milliosmoles per liter. So the other things that you need to know is the change in mean arterial pressure is moderate in mannitol as compared to hypertonic saline, which has a greater change in mean arterial pressure because it puts in some amount of intravascular pressure and it causes better perfusion. If you see, that is one of the reasons its coefficient is higher as compared to mannitol. Only thing is, we need to know about issues with mannitol. That is, the patient can go into severe congestive heart failure, pulmonary edema, electrolyte disturbances, rarely even renal failure. That is one of the things that we need to know. Sometimes it has also been associated with post-operative bleeding. The most important side effects that you need to be cautious about in hypertonic saline is the rebound increase in ICP if you stop it. That is the reason we usually taper it down. Because it is saline, it can cause unexplained metabolic acidosis, hypokalemia. These are the things that you need to keep in check. Coming to anti-convulsive therapy, the only recommendation is whenever you feel that the patient has a traumatic brain injury of grade of moderate to severe, better to start them on anti-convulsive therapy in the earlier period, that is usually less than 7 days. There is no benefit usually after 7 days. Because early seizures is what is expected in patients with traumatic brain injury. They classify seizures in TBI as early seizures and late seizures. The incidence of late seizures is very less. It is seen only with the patient with a lesion in the brain or previously known stroke. So usually, if these patients are already on anticonvulsant therapy, better to continue. But if the patient does not have any intracranial pathology previously but has a TBI, they are prone to have early seizures. So in such patients, it's better to start anticonvulsant therapy for a period of 7 days. There have been comparisons between levetiracetam and phenytoin. Phenytoin has usually a higher side effect profile as compared to levetiracetam. So usually the drug of choice currently is levetiracetam. Previously phenytoin was used. So there is no difference in efficacy between the two. Other significant management is glycemic control. As I've already mentioned, try to target the blood glucose level between 150 to 200. Avoid any hypoglycemia and hyperglycemia. Temperature, the Eurotherm 3235 trial, that is 32 degrees to 35-degree trial, showed no better outcomes when your patient is subjected to hypothermia. So it was terminated prematurely because there was harm in the treatment group. So what you need to understand is patient should not have fever. Fever should be actively treated. Hyperthermia should be avoided, but there is no role for hypothermia. Decompressive craniectomy is one of the last things which we see in management of raised ICP in a traumatic brain injury. There have been multiple trials like the DECRA trial and the rescue ICP trial which have been done. Most of the trials which were done previously were only looking at mortality outcomes, and both of them had significant mortality benefits. But when you see the functional outcome, there is very little that we can see. So the idea previously was for mortality, and there was no inclusion of a functional outcome in these two trials. So if you are talking about mortality, yes, it usually based on the rescue ICP trial, it showed a lower mortality, but functional outcomes does not change. What the BTF usually recommends is whenever you have a patient with a refractory raised ICP, do a frontotemporoparietal decompressive craniectomy as compared to a bifrontal craniectomy, which was done previously. And usually, this has shown to have reduced mortality and a better neurological outcome. It is usually a level 2A recommendation. Drugs, steroids, crash trial, no benefit, increased mortality, so no role. Tranexamic acid started off with crash 2 for extracranial, and then there was crash 3. There has been shown some benefit, but the only thing that we need to know is if you read the article per se, the patients who were showing benefit with the use of tranexamic acid, usually two things were important. One, the initiation was very early. Okay, that has to be less than 3 hours of injury onset. The dosage was very specific. It is 1 gram bolus followed by 1 gram TID, and along with this, there was some amount of reduced mortality. But the problem was the patients who showed benefit more or less were patients who had the GCS ranging between 9 to 12 or 9 to 15. So they are better outcomes as it is. So whether actually tranexamic acid gave benefit is something which is still questionable. But for exam sakes, remember Trastri gave some mortality benefit with the use of tranexamic acid in traumatic brain injury. It reduced the 24-hour mortality. That is also something which is very important, and I forgot to mention earlier. But it did not, show any difference in the 28 mortality and the functional outcomes. There have been various novel therapies that have been tried, like beta blockers, metformin, vitamin D, so on and so forth. Only thing is this cerebrolysin, which is actually a neurotropic factor, that is a factor which helps in the recovery of neurons, has shown to have some amount of beneficial effects in the recent trials. So key recommendations: blood pressure targets, ventilation targets, reduce the ICP, no role for steroids. Always make sure there is osmotherapy whenever you have a patient with raised ICP before the patient goes for a definitive procedure like a drain or a surgical procedure. No role for hypothermia, but maintain normothermia. So this is in summary of management of traumatic brain injury. Thank you. Any questions? So if there are none, I'll move on to the next talk. So the next talk is about, is my slide visible?
Yeah, Darshan.
Yes, sir.
Oh,
Yes.
okay. So going on to the next talk, it's about subarachnoid hemorrhage. This is again a type of a traumatic brain injury itself if you have a traumatic type of SH. So the outline of the topic would be introduction, pathophysiology, diagnosis, management, and guidelines-based evidences. The only thing is there have not been a single question which has been asked in the theory papers, but this is one of the most common practical questions that you will be asked in your exams. So there may be questions regarding what is delayed cerebral ischemia, what are the causes for delayed cerebral ischemia, how do you manage delayed cerebral ischemia, role of transcranial Doppler. These might be the smaller subtype or part A, part B questions which you might get is what we are anticipating in the exams. So coming to the introduction, usually subarachnoid hemorrhage is the collection of blood between the arachnoid and pia mater. Based on the event, you can either classify it as a primary or a secondary. Secondary is where I've already mentioned earlier, like trauma, presence of coagulopathy or a cerebral amyloid. Primary is what I would like to focus in this particular talk. It is usually aneurysmal, perimesencephalic, or vascular anomalies. Coming to aneurysmal SAH remains one of the devastating diseases with mortality rates between 25 to 30% on day one, up to 60 to 65 at the end of 1 year. So this emphasizes the problem statement of aneurysmal subarachnoid hemorrhage. The most important thing is the mortality and morbidity is usually associated with development of delayed cerebral ischemia. So approximately 85% of the primary SAH is usually due to aneurysmal rupture and usually appears at the sixth decade of life. So risk factors of aneurysmal SAH ranges from hypertension, smoking, and alcoholism. Symptomatic use like the abuse of cocaine, genetic diseases like if the patient has polycystic kidney disease, Ehlers-Danlos, Marfan syndrome, fibromuscular dysplasia, familial history of an SAH, cerebral aneurysms of more than 7 mm in diameter, increasing age, like I mentioned earlier, the fifth and sixth decade of life, or a female preponderance. So whenever you have a patient who can walk into your ICU for any other reason, like say suppose a CKD whom is getting initiated on dialysis, and you incidentally find that he's a case of polycystic kidney, or you have a patient who presents to you with muffins for some other connective tissue disorder workup, or you have Ehlers-Danlos. So make sure that you evaluate such patients completely so that you don't miss an aneurysm. And probably if one of these risk factors are present, they can be managed earlier and a risk of aneurysmal rupture can be reduced. So these are the things that you need to remember. So, coming to the basic understanding and relevant anatomy, most of the aneurysms are present in the anterior circulation, that is the circle of Willis. The anterior cerebral artery and the anterior communicating artery seem to be one of the higher, regions where the aneurysms usually are present because of the high flow dynamics. This article in NEJM actually beautifully, picturizes how. An aneurysm is formed. Basically, the left main carotid keeps causing a lot of hemodynamic stress on the arterial intima, which usually gets weakened over time. And this, if the patient is having a previously mentioned genetic issues, can lead to the occurrence of an aneurysm. And if not treated because of increased pressure, can lead to a rupture. So, how does the patient usually present with headache, nausea, vomiting, seizures, pulmonary edema, shortness of breath, and cardiac arrhythmias are usually the spectrum of presentation which the patient might have on arrival to the ER. Sudden cardiac death has also been reported in less than 1% of the patients who had aneurysmal SAH. The classic presentation of SH is a thunderclap headache. What do I mean by a thunderclap headache? Is the presence of a sudden onset headache which peaks like less than a minute and stays up to a maximum intensity for an hour. Okay, so usually patients with thunderclap headache who have been diagnosed to have SAH complain of a previous episode of headache, which is called as the sentinel headache. So that would have occurred usually weeks or days prior to the onset of the current scenario. Other features accompanied, which are attributed to thunderclap headache are it may begin during an exertion, it may be associated with loss of consciousness or seizure, and the patient usually will have stronger risk factors for the occurrence of subarachnoid hemorrhage. So, how do we treat these patients? Whenever a patient comes to you with SAH, or any patient who comes to you with a neurotrauma or neuro issue, in your exam, better to answer it in such headings or remember this. How do you have a pre-hospital management whenever possible? You mention one or two words about it. If they've asked you management of SAH broadly or management of TBI broadly, write it under these headings: pre-hospital treatment, emergency department treatment, acute hospitalization care, post-acute care, and outpatient care. So usually what happens, we tend to finish our answers at acute hospitalization and forget rehabilitation and post-management. But there are a lot of research and critical care concepts involved. This will get you some brownie points if you write it under these headings. More or less, if you write it under these headings, you are less likely to forget points. So this is what usually we need to do. So how can we objectively analyze a patient with a sudden onset headache? We say the patient is having sudden onset thunderclap headache, right? So whenever the patient is of the age of more than 15 years and has a severe non-traumatic headache, and the intensity is similar to what as mentioned for a thunderclap, if the patient's age is more than 40, if he complains of neck pain or stiffness, usually has LOC or seizure accompanied during exertion, and has limited neck flexion on examination, this should subject the patient to undergo a non-contrast CT. So this is actually something called as the Ottawa SH rule. So if at all a patient has one of these features, this warrants for a non-contrast CT examination. So the 2023 guidelines places a 2B recommendation to use Ottawa wherever the patient comes with an acute severe headache. Better to get a CT to rule out whenever the patient is a young person. Okay, most of the time, subarachnoid hemorrhage, the patient would be conscious when they come to the ER, so they will be able to give history. So please ask about sentinel headache. Please ask about previous histories. Please ask about familial preponderances, and associations. So if these things are there, it's easier for us to go about with the evaluation. So whenever it is less than 6 hours and there is no neurological deficit, do a CT. If it is ruled out, probably there is some other cause. But if you feel that there is the non-contrast CT shows SAH, then the further workup using a digital subtraction angiography or a CT angiography would be warranted to localize the site of lesion. If at all the patient has a neurological deficit, presents to you more than 6 hours, but the CT does not show SH, can we leave the patient there? No. What the algorithm says is, if you can see in the right hand corner, use a lumbar puncture to determine the presence of xanthochromia can be done to check for the presence of subarachnoid hemorrhage. So both of this is a level 1 indication, that is doing a CT and doing a lumbar puncture for the evaluation for subarachnoid hemorrhage. The timing of non-contrast CT is very important. So what they say is, if the patient presents to you late, the likelihood of detection of the bleed would miss. The sensitivity for a CT-based detection for subarachnoid is very good. That is up to 100% within 6 hours. But after 6 hours, what happens is the blood starts degrading and smaller minor SHs can be missed. Location of the blood is something that is very important. Usually, where we see is in the basal cisterns. Additional locations can be in the sylvial fissure, interhemispheric fissure, and interpeduncular fissure. It can also be present in the quadrigeminal cistern and the suprasellar cistern. Does the location of the blood help predict an aneurysm? Usually, what happens is it helps us understand which artery is the culprit artery at that time. If it is present, in the frontal areas, probably the anterior cerebral artery or the anterior communicating artery is the one which has to be considered. In the interhemispheric fissure and the frontal that I've already mentioned, usually ACA is the culprit artery. If it is in the anterior temporal lobe, then the middle cerebral artery is the culprit artery. So these are the things that we need to know. So location usually helps us more or less localize, but obviously the gold standard would be to do a DSA or a CT angio to know where the location is. Again, choosing DSA or angio, there are multiple issues like prerequisites. A lot of things are there. It depends on what is the size of the aneurysm, and if at all a CT angio is negative, probably a DSA would pick it up because smaller aneurysms are usually missed in a CT angiogram. So this is the diagnostic algorithm. So we did a non-contrast CT. If we have a SH, well and good, do a CT angio. What if it is negative? What if a patient presented very late? We can't see an SH, but still patient's clinical symptoms point towards an SH. Probably it's better to do an LP. How does LP help you know whether it's SH? You have to usually collect 4 tubes of CSF sample, and the amount of RBCs should be same. That is, xanthochromia should be same between 1 to 4. If there is a drop from tube 1 to tube 4, probably it's a traumatic tap. On the other hand, if it is same from 1 to 4, it usually is suggestive of subarachnoid hemorrhage. So another thing what we need to rule out whenever we do an NCCT or an MRI to rule out subarachnoid hemorrhage, the other differential diagnosis that we need to remember are reversible cardiovascular syndromes, like PRESS, is another thing that you need to remember. So reversible cerebral vasoconstriction syndrome or PRESS is some other thing that can be a DD for SAH. Coming to the pathophysiology, it is usually divided into acute pathophysiology and subsequent events. Acute pathophysiology, you have the break of the vessel, release of blood, disruption of CSF flow, raised ICP, compression of brain tissue, leading to cerebral ischemia. See, whenever there is cerebral ischemia, the neurological symptoms start. Mild symptoms like headache can be the initial ones, leading to the severe ones being neurological deficits, seizures, or the worst case scenario, deeply comatose state. All this is because there is disruption of the flow of CSF and decreased cerebral perfusion. So whenever you have an aneurysm rupture, the site of the rupture and the location of the bleed matters a lot, because based on these, the patient can have certain deficits. So it can be both local as well as systemic. Local, I've already mentioned to you. The systemic is what we need to worry about. The systemic ones usually are probably non-infective fever, electrolyte disturbances, hormonal changes secondary to involvement of brain, and worst case scenario, because of the extreme sympathetic overdrive, they can have cardiac abnormalities, and sometimes can also have cardiopulmonary, compromise because of either pulmonary edema in a worst case scenario, even sudden cardiac arrest. So this usually is because if you see this image, there is a lot of blood. The neurons lose their cerebral autoregulation, and the glial cells are no longer able to take the sudden input of the blood into the picture. The tight junctions, which were usually present in the normal brain tissue, is lost, and there's a lot of blood particles like the platelets, the uh, inflammatory markers, everything enters into the neuroglial cells, which leads to the activation of the neuroinflammatory pathway and a cascade of events which starts happening, which causes both the local as well as the systemic problems. The local problems can be ischemia, and the systemic problems can be the involvement of both the lungs, which causes pulmonary edema, and the heart, which can cause dysrhythmias or sometimes even can lead to cardiac arrest. The other systemic issues I've already mentioned, like metabolic and endocrinal issues. So, how do we grade an SH? It is uh, previously the World Federation of Neurosurgeons scale and the Hunter SS scale was used. World Federation of Neurosurgeons was strictly very surgical oriented. It only talks about motor deficits and GCS because it was a surgical model, say yes or no, that's it. But when you use a Hunter S scale, it is morely a physician based model where you see the patient's assessment is based on a very structured format of neurological assessment is present. Whereas a modified Fisher scale is usually used after a CT is done, and that is probably helping us to understand the severity based on the location of the bleed, the size of the bleed, and the possibility of occurrence of delayed cerebral ischemia. So this is the progress in which the grading has happened over the few decades of understanding an aneurysmal SAH. The grades are between 1 to 5, 5 being the worst grade, 1 and 2 being the more or less stabler grades, where we need to usually intervene at the earliest so that best outcomes can be achieved. Usually, grade 3, 4, and 5 are called as poor grade aneurysmal subarachnoid hemorrhage. So this is what we need to remember. I will just be delving into few things in particular. Please look into the slide on the right hand side, that is the modified Fisher scale. You can see two red stars present where it mentions in grade 4 and grade 5. Uh, or else in modified Fisher scale, that is 3 and 4, as thick SAH. What I mean by thick SAH is not just the thickness. It also mentions about how many cisterns are involved. So this is what is usually given by the radiologist to tell us how serious the subarachnoid hemorrhage is. The other question which you might be asked from the practical point of view is what is the difference between modified Fisher and Fisher scale? Modified Fisher's scale usually has 5 gradings like 0, 1, 2, 3, 4, whereas Fisher scale had only 1, 2, 3, 4, 0 is not there, but the 0 is not absent. The whole difference between modified Fisher and Fisher is the description of the thickness. Initially, the Fisher scale just mentioned presence of thick or thin based on millimeters, that is 1 millimeters of size. But here, the cisternal involvement is one of the modification which is present in the modified Fisher scale. I hope that is clear. You want me to repeat? Please tell. Going ahead, coming to the management of aneurysm per se. Whenever you have an aneurysm in the management, till now what we have done is the basic management of any patient with SAH. After we have done the basic management, then you have to start the aneurysmal management. So prior to aneurysm management, there are few things which we have already achieved, few things that we need to still achieve. That is the blood pressure target. Along with it, what do we do for aneurysm per se? And after aneurysmal management, what is supposed to be done? So why do we do this? Usually to avoid early brain injury, which can range from rebleeding, raised ICP, occurrence of seizures, which are usually the most detrimental, and the onset of hydrocephalus. In delayed brain injury, it can cause DCI, it can cause other systemic problems. And because of these two issues, that is the early brain injury and delayed brain injury, there could be detrimental effects on the recovery of the patient. So prior to the management of aneurysm, ABC should be corrected and addressed. Blood pressure targets should be optimized, oxygenation should be optimized. If the patient was on any anticoagulation, that should be reversed. Seizure prophylaxis should be considered for high-grade SH. I'll be coming to detail about seizure prophylaxis later. Rest of the things would be based on the NCCT, CT angio, or the DSA report, that is neurosurgical consultation and the identification of hydrocephalus. Coming to the blood pressure management, there have not been a single criteria that which is present to tell that this is the target. Both the American Heart Association, American Stroke Association, and the Neurocritical Care Society have not come to a conclusion. But the only thing they say is SPP less than 160 millimeters of mercury or a MAP less than 110 millimeters of mercury may be personalized based on the blood pressure target, probably based on the person's autoregulation. That is, if the patient is a known hypertensive, probably a higher target would be required. So before achieving these targets, other confounders for raised blood pressure should be considered, like pain. Continuous outline monitoring is a safe or a best practice statement to have, so that any precipitous drop in blood pressure could be observed and managed accurately. Whatever said and done, the best thing to do at this point in time, if there is a raised blood pressure, is to use a titrable agent which is having a shorter half-life, so that if there is a precipitous drop, that can be controlled and cerebral perfusion can be optimally managed. So what usually has been suggested is nicardipine and clividipine. This depends on your institutional protocol, whatever is there. Only thing is, what you need to remember is to avoid nitroglycerin and nitroprusside. This is because there has been a lot of theoretical and few RCTs which have shown that it is associated with significant vasodilatory effect that can cause an increase in ICP, causing detrimental effects to the patient. So these things are something that practically you need to remember. A mean arterial pressure, usually persistent over more than 95 millimeters of mercury, has shown to be having detrimental effects. So what are the measures that have been suggested by the AHA for the prevention of rebleed? Is in a patient with aneurysmal SH, close blood monitoring is necessary. Targets are not present. If a patient is on an anticoagulation, correct the anticoagulation at the earliest. These two are level 1 recommendations. So these two things have to be thought about. But coming to the thought about use of antifibrinolytics like tranexamic acid or epsilon paproic acid, there is no evidence. So coming to the blood pressure per se, they have said that it's a level 1 evidence to monitor blood pressure. What is supposed to be monitored in that is based on this study by Ascanio et al. In 2020. They have seen that a greater blood pressure variability, that is in the first 24 hours, has shown to have worse outcomes for aneurysmal SH. What they mean to say is, if there is a significant fluctuation or a swing in the blood pressure, that is, say, if the patient came with a blood pressure of 180, 190, or 200, and it precipitously dropped to 120 and it couldn't be picked up at the earliest, or it stays low, that has shown to have poorer outcomes as compared to a standard value. Okay, so the ideal target or a safe target would be to keep it between 140 to 160 millimeters of mercury and avoid any swings. And to avoid any swings, close monitor would be better. So role of reversal for vitamin K antagonists, give vitamin K, along with that consider platelet concentrates or FFP. 4-factor platelet concentrates for newer oral anticoagulation like rivaroxaban, apixaban, and dabigatran. If you have adalimumab available, please go ahead and use it. All of this is level 1 recommendation. That is, if your patient comes and has a bleed and the bleed is significant, please, or insignificant, there is a bleed, please reverse the anticoagulation and hold the anticoagulation. Role of antifibrinolytic, there have been 2 trials, STAR and ULTRA. ULTRA is the latest one in 2021. It did not show any benefit for the use of tranexamic acid. There have been various limitations. STAR was done very like old 2000. So what they suggested was in ultra they would do a very ultra early initiation of tranexamic acid, whether that will give any benefit, but it failed to show any functional or mortality based outcomes with the use of tranexamic acid. Management of aneurysm, definite management. Earlier the better, less than 24 hours is the gold standard if at all it is safe and it is feasible. But if you do it earlier, ideally less than 48 hours of diagnosis, better outcomes can be seen. The method to usually secure this depends on the age, morphology, and location of the aneurysm. The level one recommendation for the endovascular or surgical repair is usually less than 24 hours, complete obliteration of the ruptured aneurysm whenever it's feasible. And if the patient is having an aneurysmal SH and falls between one grade two or with a sudden loss of consciousness, even then better to go ahead, evacuate the clot and perform the endovascular treatment so that the patient might have a chance of better outcome. So drop in GCS after assessment should not deter the patient for surgical outcomes. It is a level 1 recommendation. Whenever you have this, it has shown to reduce the mortality. For patient with a good grade SAH, that is grade 1 and 2, ruptured aneurysm in the anterior circulation, coiling is usually better over clipping, but the functional outcomes is also better. Having said that, it also depends on the type of aneurysm and a lot of other morphological features of the aneurysm. Posterior circulation is usually a very tricky, challenging position for an endovascular procedure, and usually a surgical technique will be better as compared to a endovascular technique. So, what the ISAT and the BRAT trials recommended was endovascular coiling generally yields superior outcome, being less invasive as compared to the clipping. What matters is if there is a patient who is elderly and the risk of rebleed, larger neck to fundus ratio, risk of rupture is there, surgical clipping would be better. I'm sorry, if it's an elderly patient, less invasive coiling would be better. But if you have risk of rebleeding, larger neck to fundus ratio, and risk of rupture, clipping would be better. So the choice of clipping to coiling should be depending on the aneurysm and location and the age. That is what I need you to carry on from this slide. Management of hydrocephalus and ICP. It should be done as early as possible because the onset of hydrocephalus is seen as early as minutes to days in SH. Hydrocephalus usually spontaneously resolves in 30% of the patients, but at sometimes it can cause blockage in the ventricular system and can impair the reabsorption of CSF, can cause hydrocephalus and detrimental effects secondary to reduce perfusion pressure and raise ICP. The risk factors for the development of hydrocephalus includes older age group, interventricular hemorrhage, posterior circulation aneurysm, treatment with antifibrinolytics, low GCS at presentation. So what has been suggested is ICP monitoring would be better. The Synapse ICU trial is one of the trials. It said that if you measure the modality of ICP measurement here was invasive. So they say that better outcomes would be possible if a closer monitoring of ICP was done. So this is the CT image of a patient with SAH with interventricular extension showing hydrocephalus features. What you need to see is dilation of ventricle, enlarged temporal horns, and rounding of the frontal horns. These are the things that are usually present in a CT. Management of hydrocephalus, usually symptomatic hydrocephalus is when some patient has uptendation or coma. EVD is one of the earliest treatment of choice, but if EVD is failing to reduce the hydrocephalus, the patient is still symptomatic, which usually happens in around 40% of the patient, he might require a VP shunt. Lumbar drain insertion is another option for patient with management of communicating hydrocephalus. If the patient has an obstructive hydrocephalus, lumbar drain may not be useful. Patients with obstructive hydrocephalus and ventricular, drain, frequent blockages usually would cause problems. So inserting an EVD early on should be monitored closely for obstruction features and signs of raised ICP. Probably if you insert an EVD, better to monitor the ICP, which will also help you understand the cerebral hemodynamics. What is Evans index? If someone can answer in the chat box, it would be better. And which condition it's used? Can we use it in SH? Seizures. Approximately 20% of the patients with SAH can have seizures, but there is no level 1 evidence for prophylactic use of anticonvulsive therapy in SAH. But if you have a poor grade SAH, better to do EEG regularly. Continuous EEG is gold standard. If at all the patient is having seizures, active management of seizures is necessary and has shown better outcomes because this reduces the possibility of occurrence of delayed cerebral ischemia. Having said that, what are the risk factors for seizures? Is if the patient is more than 65 years old, has a focal pathology with a thick SAH, intraparenchymal hemorrhage with a cerebral infarct, usually post aneurysmal clipping or with the presence of rebleeding, better to give the patient anti-epileptic therapy. Short course anti-epileptics should be sufficient up to 3 to 5 days. It has been backed up by both AHA as well as NCS. Levetiracetam is the drug of choice. But having said all of this, I still emphasize that prophylactic anti-epileptic therapy is not recommended. Majorly because whenever you have these patients on them, they have shown to have some cognitive dysfunction in the long run. So this is the level of recommendation. I've already mentioned earlier, prophylactic anti-epileptic therapy. Please always be aware the patient might have cognitive dysfunction in the long run. DCI, what is the definition of DCI? This is what I want you to focus on. It might be one of your questions. Any neurological deterioration that persists for more than 1 hour and cannot be explained by any other neurological deficit is called direct cerebral ischemia. DCI occurs on an average between 3 to 14 days and can peak around 7 to 10 days and persists up to 21 days. This is the usual sequence of or the temporization of delayed cerebral ischemia. So, management of DCI has direct effects on long-term outcomes and functional outcomes in the patient with aneurysmal SAH. So, risk factors for occurrence of delayed cerebral ischemia are these: younger age patients, more thicker SAH, intraventricular hemorrhage, as demonstrated by modified Fisher grading, which is usually grade 3, grade 4, and the previous history of patient being a chronic smoker, cocaine use, presence of systemic inflammatory response, hyperglycemia, subsequent presence of hydrocephalus or a non-convulsive seizure. These are the things which are higher risk factors for the development of delayed cerebral ischemia. So, what is the pathophysiology? How does this happen? So, in the first phase, that is the early brain injury, which you see on the right hand side, usually presence of blood itself in the cisternal places can cause a lot of issues that can be attributed to poor cerebral autoregulation. Can be because of poor glial function, poor removal of inflammatory markers. It can trigger a procoagulant cascade. It can lead to endothelial dysfunction, and it can lead to cortical spreading of depressions. So, based on all of this, this usually leads to a cerebral vasospasm, which can be both microvascular and macrovascular, loss of autoregulation. This leads to the occurrence of delayed cerebral ischemia. So the box in green is what you have to remember: reactive microglial responses, presence of oxyhemoglobin, microthrombi in glial lymphatics, procoagulant activation, endothelial dysfunction, and spreading of cortical depressions. These things will put a cascading effect leading to occurrence of cerebral vasospasm, occurrence of microthrombi reducing cerebral perfusion, loss of autoregulation, and can have detrimental effects on the hemodynamics. So, how do we monitor for delayed cerebral ischemia? Is usually by a serial neurological examination that is necessary. Usually, whenever you have a patient's with aneurysmal SH, a serial CT scan can help you find out. It's not necessary that everyone is having transcranial Doppler at their bedside to check for cerebral vasospasm. CT itself can lead us to understanding the occurrence of cerebral vasospasm. So, if you see a new onset infarction, which is unrelated to the arterial network where the bleed has happened, then it is attributable to delayed cerebral ischemia. This can be done, the monitoring can be done using ICP monitors, transcranial Dopplers, continuous EEG, and CT angio, CT perfusion studies. So, having said this, is all vasospasm significant? There is something called as angiographic vasospasm and clinical vasospasm. Angiographic vasospasm is usually seen when the patient undergoes a CT scan. So your radiologist might report a thing telling that feature suggestive of vasospasm present. But if the patient does not have a clinical symptom, that means to say the patient has less likely chances of developing delayed cerebral ischemia. But on the contrary, it does not let us, be take a back seat and stop observation. He has to be closely monitored because these patients are still at risk of development of DCI. So you have to understand the difference between angiographic versus clinical symptomatic vasospasm. Clinical symptomatic vasospasm is something that needs to be monitored closely. It is detected by the decrease in GCS of more than 2 points in a span of 1 hour. And other causes for drop in GCS has to be ruled out. May it be seizures, presence of hyperparexia, occurrence of hydrocephalus, use of sedatives, and metabolic causes. So neurological improvement, if there is a presence of BP augmentation, usually is indicative of delayed cerebral ischemia or cerebral vasospasm. What I mean by improvement of neurological status after BP augmentation is there have been drugs which has usually shown to increase the blood pressure. That is, by definition, inducing hypertension. And if you induce hypertension and the patient's GCS improves, that is an indicator that the patient had vasospasm leading to delayed cerebral ischemia. So this is one of the retrospective methods of understanding or a non-invasive method of understanding cerebral vasospasm. Transcranial Doppler, I think so most of you know about it. The level of evidence is still two-way. What is usually done is you see the velocity, means systolic velocities to the middle cerebral artery along with the ipsilateral ICA. So what is checked here is the peak systolic velocity with the mean flow velocity. That is what is supposed to be calculated. Usual velocities in the MCA is between 90 to 120 centimeters per second. But if the flow velocity is between 120 to 150, it indicates mild vasospasm. If the mean flow velocity is between 150 to 200, a moderate level of vasospasm. And if it is more than 200, it is indicative of severe vasospasm. Based on the calculation using ipsilateral internal carotid artery, there is a ratio called as the Lindergaard ratio, which usually uses PSV and the mean flow velocity. And if the ratio is between 3 to 4.5, it indicates mild. 4.5 to 5, 4.5 to 6 is moderate, and more than 6 indicates a severe vasospasm. So these are the usual windows which are used for the measurement of transcranial Doppler: suboccipital window, transtemporal window, or supraorbital window. Even that submental window is also present. Coming to the management, whenever you have a patient with the onset of subarachnoid hemorrhage, please start prophylaxis for delayed cerebral ischemia. It's level 1 recommendation, 60 milligrams every 4th hourly for up to 21 days. The It's a calcium channel blocker. The exact mechanism of action is actually multifocal, and no one is exactly able to tell how it's beneficial, but it has shown mortality benefits. So always continue the use of nimodipine. One thing which is worrying is it can cause some amount of hypertension that has to be monitored and managed. Any other method that is usually used? Can anyone tell that? Okay, for want of time, there is EEG-based assessment of occurrence of cerebral vasospasm. What they usually see is the loss of faster frequencies. Whenever you have a loss of faster frequency, that means to say the alpha frequencies are reducing. The alpha frequencies are directly attributable to cerebral blood flow. So if the cerebral blood flow is reduced, there is vasospasm, and because of vasospasm, there is drop in the alpha delta ratio. So EEG is another method that you can do to diagnose cerebral vasospasm. So if you don't know how to use a TCD, or if you don't have it ultrasound module with TCD, then you can use EEG to diagnose cerebral vasospasm. So the level 1 recommendation is earlier enteral nimodipine, but every other modality, there was triple H therapy, which was told about earlier. They are all not showing any benefit for management of cerebral vasospasm and delayed cerebral ischemia. The only component of the triple H therapy that has remained is hypertension, but that has to be properly assessed and started. There have been various other methods which are novel therapies that have been tested. I would like you to look at two things: that is intravascular administration of milrinone as well as the lumbar drain. For the removal of uh, subarachnoid blood. The data for the early drain trial is already out. It was published in 2023 that has shown promising results. That is early, that less than 24 hours removal of blood from the subarachnoid space has shown better outcomes, including mortality. But optimal, the full study is yet to be published, but there is evidence that use of milrinone can prevent delayed cerebral ischemia. A lot of other trials are still being done, but there's no outcome benefit or guidelines which are still available. Hyponatremia is one thing that is usually associated with subarachnoid hemorrhage. Etiologies for hyponatremia needs to be assessed. It can be pseudohyponatremia, it can be cerebral salt wasting, or it can be SIADH. So this is one thing that we need to know. I was mentioning earlier about the hormonal changes which are present and the electrolyte imbalances that can happen in an aneurysmal SAH. So this is what is necessary for us to understand. So you need to understand SIADH in this case could be multifactorial. It has to be ruled out, from a cerebral salt wasting, because usually it is going to have features similar to that of cerebral salt wasting. The only differentiating feature between CSW and SIADH is the hypovolemic state, and usually patients respond well to hypertonic saline. So in detail, management of hyponatremia is with the use of hypertonic saline. Always avoid hyponatremia because that can be detrimental. It can cause a lot of fluctuations in the cerebral perfusion and can cause poor outcomes. Coming to DVT prophylaxis, prior to aneurysm protection, only this thing, pneumatic compression devices should be used, but chemical DVT prophylaxis is usually contradicted because there is active bleed. So after aneurysm protection, when to start it? Usually first 24 to 48 hours, it's not taken into consideration. Always be aware of the fact that heparin or low molecular weight heparin can cause HIT. So these patients need closer monitoring of coagulation profile when you start initiation of DVT prophylaxis. Better so, make sure that the patient can be mobilized, active rehabilitation is started. These are something which are very necessary and usually missed when we answer in theory as well as practicals when we are talking about DVT prophylaxis and overall management of aneurysmal SAH. Cardiopulmonary complications, this is usually because of severe outflow of sympathetic drive from the CNS, and this can cause a lot of problems ranging from stress cardiomyopathy to neurogenic pulmonary edema. This is usually due to the activation of both the alpha and the beta receptors. So whenever you have an activation or an overdrive of alpha receptor, you can see peripheral vasoconstriction that leads to increase in peripheral pulmonary capillary pressure, leading to neurogenic pulmonary edema. If there is a surge causing beta receptor activation, that usually leads to myocardial contraction and necrosis, which usually causes Takotsubo or stress cardiomyopathy, leading to decreased LV ejection fraction, leading to shock. So, in summary, early detection ABCs should be maintained prior to aneurysmal clipping or definitive treatment. Maintain your blood pressure, mark targets, correct the coagulopathy. Don't use the antifibrinolytics, even though there are a few things. Ultra trial has already shown that there is no use, so better to avoid that. So maintain euvolemia. That is what is necessary. There is no role for hemodilution or hypervolemia. Maintain normal blood pressure targets. Nimodipine grade 1 evidence. Better to start it early, 60 milligrams for hourly. Neuromonitoring is supposed to be done on a regular basis. Check for vasospasm. Other general treatment should be present as similar to traumatic brain injury. Always monitor for cardiac complications like arrhythmias, pulmonary edema, etc. If there is a DCI, hemodynamic augmentation and urgent endovascular therapy has shown to have benefits. Thank you. I know I'm exceeding a lot of time, but these topics are quite large. I'm sorry for the next speaker, but I'm going to continue with the talk. Any questions, I'll be really happy to address them in the chat box or later on in the group. So going to intracerebral bleed, that is the next talk. This is more or less something that we need to know on a need to know basis, because most likely this is going to be asked in the practicals. Theory, no questions as of now. So you need to know that it is the bleeding in the brain parenchyma, which can extend into the ventricles and less frequently into the subarachnoid and the subdural spaces. It can be spontaneous, and usually it can be non-traumatic. And non-traumatic intracranial bleeds is something that we are going to focus in the current talk. It can be two types, that is primary or secondary. Primary usually associated with chronic hypertension or amyloid angiopathy, whereas secondary can be associated with bleeding diathesis, or it can be associated with vascular malformations, neoplasms, or conversion of an ischemic stroke. Sites, it can range from the presence, usually hypertension can cause non-lobar ICH more than the lobar ICH, but the hypertensive ICH are usually present in the putamen, thalamus, subcortical white matter, pons, and cerebral. Etiological classification, you can remember for ICH using the mnemonic SMASH-U, that is structural lesions, medications, amyloid angiopathy, systemic diseases, hypertension, and undetermined cause. Risk factors, usually you can classify under modifiable and non-modifiable. Modifiable like hypertension, coagulopathy, smoking, alcohol, diabetes, and use of illicit drugs. Non-modifiable are advanced age, gender, ethnicity, presence of cerebral amyloid, chronic kidney disease, coagulopathy, which is congenital, presence of tumors, etc. Clinical presentation, usually this is similar to the ones which are present earlier, like in traumatic brain injury and subarachnoid hemorrhage. They usually present with features of raised ICP, or sometimes when with focal neurological deficits, which is as worse as coma or as trivial as probably TIA. So what we usually need to do is a non-contrast CT whenever the patient presents to you with such features. Okay, it's the basic thing. Whenever we do a non-contrast CT, it's usually to rule out a bleed. And when it is to rule out a bleed, it is what type of a bleed. If it is an SH, it is an SH, rule out aneurysmal or traumatic. If it is an parenchymal or an intracerebral hemorrhage, then we need to know what to be done. So how do we assess the status of the intracranial hemorrhage? The score which is used to calculate the volume of the bleed is ABC by 2. Why we need to do this is usually the subsequent management of an intracranial hemorrhage depends on the volume of the hemorrhage. Various studies have been done to monitor this particular volume and then formulate the treatment protocol. So usually A is the longest axis, B is the longest axis perpendicular to A, and C is the number of slices which are attributable. Usually when we take number of slices, we have to take, and it is dependent on the axial cuts. So when we have these cuts in hand, whenever there is involvement of less than 25%, a score of 0 is given. So that number of slices would not be involved. If it is between 25 to 75%, a score of 1, and 75 to 100, a score of 2 is given. So based on this, the total number is calculated. After that, it is using the formula ABC into 2, we usually calculate the ICH volume. Spot sign is something that is usually seen whenever you have a patient with intracerebral hemorrhage and you have an occurrence of a rebleed. So this is something that you see in picture C. There is some hyperintensity which is present in the previously occurred hemorrhage. So whenever you have such signs, there are various signs which you have, like the island sign, the blend sign, black hole sign. All these signs are present in the patient with intracerebral hemorrhage. These are features of an occurrence of hemorrhage or re-bleeding. So these things should warrant for emergent treatment. So whenever you have these ICH or IC bleed, you have a score. And ICH score is one of the scores which helps us understand the 30-day mortality. So the parameters of the ICH score are ICH volume, the presence of intraventricular extension, infratentorial location, that is very important, age, and GCS. The total score is usually between 0 and 6. So what you see here is as the score goes beyond 2, the mortality actually starts increasing. So this is what is mentioned for the patients who have a intracranial hemorrhage. So whenever a patient has an ICH volume of more than 30 cc itself, you need to be aware of this, and they have to be actively managed. So 30 cc is something that I want you to remember. Acute management, like previous things that you need to remember, is predicting the hematoma expansion, prevention of hematoma expansion by measures like blood pressure control, reversal of INR. Uh, the role of platelet transfusion and metabolic issues I'll be explaining. And you have to also monitor complications of ICH like seizures and hydrocephalus, which have a detrimental effect on the worsening of intracranial hemorrhage. So preventing hematoma expansion, these are the following methods that you can do. That is blood pressure control, reversing the INR, platelet transfusion, and metabolic causes. So how do we objectively assess the hematoma expansion? This is one of the scoring systems that I have mentioned. That is the brain score. That is what was the baseline ICH volume, what is the recurrent ICH, if it's present or absent, whether the patient was on anticoagulation with warfarin, etc., in presence of intraventricular extension, and number of baselines from the baseline, number of hours from the baseline tomography. This is what is necessary. Based on this, you can have actually predict the possibility of a re-expansion or a presence of hematoma expansion. So there were a lot of trials which were done for BP management and BP targets. Interact trial started as early as 2008, and even attached trial. Right now, the current recent trials are Interact 2 and Attach 2. Both of them actually saw at intensive treatment, that is within 6 hours of onset or 4.5 hours of symptom onset, to reduce the BP target less than 140. Attach actually targeted it between 110 and 139. So what does Interact 2 trial show? It actually had a good patient population with a treatment arm targeting a SBP less than 140 and a control arm targeting a SBP less than 180. It showed that intensive blood pressure lowering showed better functional outcome based on the modified Rankin scales at 90 days. But death and disability was similar in both the groups. So the only thing which they found was functional outcomes were better in the 90 days. Attached to trial, on the other hand, did not find any death or disability rate differences similar to what was seen in the Interact 2 trials. But what they noticed was the rate of renal adverse events were higher in the intensive treatment group, that is 9 versus 4%. So this is something that was attributed to aggressive management of hypertension in these patients. Maybe the only understanding in this case is the autoregulatory issues which are present in the patient with a higher blood pressure target, leading to decreased renal perfusion and the occurrence of renal adverse events. The meta-analysis of these two trials, including Interact and Attach 2 trials, show that stable systolic pressure reduction in the first 24 hours to a level between 120 to 130 had more favorable outcomes. So better to reduce it, but have a close monitoring. So whenever you have a patient coming with any type of a bleed, reversing coagulation is necessary. The patient is on anticoagulants. I've already mentioned vitamin K antagonists, newer oral anticoagulants, be it factor 10A inhibitors or dabigatran or heparins. The subsequent reversal agents should be used. The most common ones for vitamin K oral anticoagulants being the 4-factor PCC. The doses are mentioned here. That is, if the INR is between 1.3 to 1.9, you can use 10 to 20 international units per kg. But if it is more than 2, usually you use 25 to 50 international units. The best way to assess and go about reversal of coagulopathy is to use point of care devices like a TEG or a ROTEM and then to treat it. Whenever you have an absolute antagonist like adarisumab or andexanet alpha, better to go ahead and use them. But the availability and the cost is one of the issues that we have. Protamine, as you all know, is the drug which is used to reverse heparin. Antiplatelets, whenever the patient is present on antiplatelet and that causes an intracranial hemorrhage, there is no evidence for prophylactic treatment. The trial which was done here is the patch trial. So patch trial did not show if that prophylactic initiation of platelet infusions would reduce the risk of rebleed in such patients. Steroids, again, there is no evidence. It can increase the complications. So it's similar to traumatic brain injury. Intracranial pressure management, same like a traumatic brain injury, head end elevation, sedation, avoidance of neuroexcitability, maintained cerebral perfusion, and all the metabolic targets should be achieved. Invasive ICP monitoring, not routinely recommended, but always maintain a cerebral perfusion pressure between 50 to 70. Complications which are usually associated with this is, whenever you have an EVD placed, there can be occlusion, and that can cause some amount of hydrocephalus, or a patient can have a raised ICP. Poor grade patients also would require the insertion of drains for cerebral, fluid drainage. So the level one recommendation is whenever you have a patient with hydrocephalus, trapped ventricle, or poor grade GCS, better to put in an EVD and then drain this so that the pressure is reduced and perfusion is better. So that is the only level one evidence. But for monitoring and improvement of mortality, the invasive methods are not showing any benefit. Osmotherapy is similar to TBI. You can either use hypertonic saline or mannitol. Salvage therapy, like the induction of pharmacological coma, hyperventilation, and neuromuscular blockade, can be used as temporizing measures only to you get a definitive treatment like an EVD placed. But for long-term treatment, only for refractory raise in ICP, you can use pharmacological coma with EEG monitoring. Otherwise, there is no benefit. So what they use is phenobarbital or propofol. Always remember, whenever you're using, the side effects are something which is supposed to be monitored, especially with propofol. The occurrence of PRIS is very high. That is, propofol infusion syndrome should be kept in mind. Whenever you have refractory bradycardia, metabolic acidosis, cardiovascular collapse, please think of PRIS. Okay, don't attribute it just to raised ICP and Cushing's reflex causing bradycardia, hypertension, or hypotension at that particular time. Hyperventilation is only as a saving grace until you have a definitive treatment. Never ventilate less than 26 millimeters of mercury. That can cause ischemia and worse outcomes. Neuromuscular blockade, you have to always remember that you're sedating the patient with paralysis. Along with this, the loss of assessment of neurological functions would be present. So this is something which is counterproductive to what you want to do. So if you have a raised ICP at that time, probably yes, but infusion should be avoided. Pharmacological management, use of tranexamic acid by the TRIDGE trial, it showed that there was no difference in functional status or mortality. Factor 7, again, the FAST trial, when it showed if the treatment was initiated within 4 hours of onset, it reduced the growth. But when you see the survival benefit, the risk of MI and ischemic stroke was actually higher in these patients who received factors 7. So that is one of the reasons it is a level, class 3 level of evidence is A for this. So routine use of factor 7 should be avoided because side effect profile is higher, even though it showed reduction in bleed. Supportive care like glucose management, temperature management, and seizure prophylaxis is similar to traumatic brain injury. So fluctuations and active hypothermia should be avoided. Prophylactic anti-epileptic therapy is usually not advised. Only if the EEG changes are showing presence of seizures, anti-epileptic therapy can be initiated. Complications, like I mentioned, there's seizures, hydrocephalus, and DVT. Seizures, level 1 evidence, monitor EEG if the patient is severely obtunded. Infusion would be necessary. Treat them like a probable status epilepticus. Patient with hydrocephalus, go ahead and insert an EVD. It has a class 2A evidence, which is still showing some amount of benefit. DVT prophylaxis, usually like subarachnoid hemorrhage, start with pneumatic compression, then go for pharmacological management. So risk of DVT is very high for these patients. First, pharmacological treatment not recommended for the first 48 hours. After 48 hours of ICH, probably you can start them. Surgical management, early versus medical management, it's actually not showing much of an evidence. If you can see the Kaplan-Meier curve here, early surgery that less than 24 to 48 hours did not show great benefit. Even the stage 2 trial did not show much evidence. So supratentorial ICH, usually the usefulness of surgery was not very well. But if you see the posterior circulation surgery, posterior or the infratentorial intracranial hemorrhage, earlier evacuation of the bleed was showing to have better outcomes. So supratentorial first 96 hours usually not recommended. Better to do medical management, observe the patient. Open craniotomy is not usually advised. Minimally invasive techniques over open techniques did not show any benefit. That was by the MISTI 3 trial. I told you before, posterior cranial fossa, if the volume is more than 15 ml, better to get the patient under surgical consult and better earlier evacuation. Uh, Again, minimally invasive evacuation over surgical evacuation. Better to do minimally invasive techniques earlier than to go with definitive, larger open craniectomies. So this is one of the surgical management tools that can be used. Whenever the patient has an obstructive hydrocephalus, EVD has shown to have a class 1 evidence for mortality reduction. Rest all the other things like presence or insertion of an EVD plus a thrombolytic or a hematoma evacuation, all of this has seen to have a class 2A or class 2B level of recommendation. So secondary things are when do we restart patients whenever they are on aspirin or if they are on any anticoagulation. What the restart trial says is after 10 days rebleeding is unlikely. So usually a lower dose can be started like anywhere between 30 to 160 as soon as 48 hours of intracranial hemorrhage has been established. So this is something that we need to usually monitor. So 48 hours after the ICH, you can usually restart because rebleeding is usually less. Atorvastatin, whenever patient has been taking this, will it worsen ICH? Usually not, but there is conflicting data that it worsens ICH. At this current point, based on the Sparkle trial, it's better to continue the patient on statins if there were any. Poor prognostic factors being the admission GCS, increasing age, larger volumes like usually more than 60, presence of intraventricular hemorrhage or infratentorial location. Prognosis is usually poor. They have all of these issues, especially with hypertriglyceridemia, persistent elevated blood glucose, or a poor grade CT or MRI finding. So GCS score and Funk score are one of the scores which are usually used for mortality or prediction in these patients. Funk score, if it's less than 4, better outcomes are present. If the patient has more than score of 11, the patient usually has a 80% mortality. So these are one things which I've already mentioned before: location, age, male preponderance, previous use of anticoagulation, hypertriglyceridemia. These are things can cause ICH recurrence, and these patients need a close monitoring. So these are the references. Thank you. I'm sorry I went beyond my time, but these topics had a lot of things that has to be spoken about. If there are any questions, I'll be happy to answer them in the chat box. Any questions? Okay, I think so. The next speaker can start. Bhuvana, are you there?
Yes, I'm there. Yeah.
Sorry, Bhuvana, it took a long time.
Okay, sir.
Yeah, it was quite extensive. Thank you.
Yes.
Okay.
Just can you end the screen sharing, sir?
Yeah, doing it. Thank you.
Yeah. Can you see the screen, sir? PPT is seen.
हाँ बोना.
Okay. Good evening. So today we'll discuss about acute ischemic stroke. ICH has been covered before, so we'll cover the acute ischemic stroke. So acute ischemic stroke is a sudden onset of neurological deficit from a vascular mechanism. So it could be ischemic most of the times, hemorrhagic 15% of the times, it could be SAH or ICH. What is TAA? An ischemic deficit that disappears within 24 hours without any radiological evidence of infarct is called a TIA. So, what are the common causes of stroke? It could be embolic, it could be thrombotic, it could be hypercoagulable state, it could be vasculitis related or vasospasm related. Embolic, it could be cardioembolic 20% of the times, like atrial fibrillation, mural thrombus, MI, DCM, valvular lesions. It could be artery to artery. Any disease of carotid, aortic arch, aortic dissection can cause stroke. Thrombosis, there could be large vessel thrombosis or small vessel thrombosis causing lacunar strokes. Hypercoagulability, there could be protein C, protein S deficiency, antithrombin deficiency, homocystinemia, APLA, malignancy, factor V Leiden mutation, OCPs. Could be vasculitis and vasospasm related, as I told. So, what are the differential diagnoses of stroke when a patient presents to ER you should think of? It could be migraine, seizure with a post-ictal state, there could be tumor or abscess, it could be CVT causing venous infarct, it could be a functional disorder, hypertensive crisis, TBI, any mitochondrial disorder, multiple sclerosis, PRES, RCVS, spinal cord disorder, SDH, syncope, any systemic infection, any toxic metabolic disturbances like hypoglycemia or intoxication, transient global amnesia, viral encephalitis, or Wernicke's encephalopathy. So, coming on to the management of stroke, what is the pre-hospital stroke scale we should use? It is Cincinnati pre-hospital stroke scale, which includes facial droop, arm drift, dysarthria. If the score is 1, there is 75% probability that the patient is having a stroke. If the score is 3, there it is 85%. It has a 85% probability that the patient is having ischemic stroke. So, what are the time targets we should remember, which is important for exam also? The NINS time targets, that is National Institute of Neurological Disorders and Stroke time targets. Door to physician time less than or equal to 10 minutes. Door to stroke team time, that is less than or equal to 15 minutes. Door to CT initiation time, that is less than or equal to 25 minutes. Door to CT interpretation time, that is less than or equal to 45 minutes. Door to drug time, which is less than or equal to 60 minutes. Door to stroke unit admission time, that is ICU admission time, less than or equal to 3 hours. Coming on to the management part. So first we have to concentrate on history and examination. Onset and progression of neurological symptom. This is important because the decision on thrombolysis will be decided based on this. Any history of prior TIAs, comorbidities, anticoagulant use, oral contraceptive use, or any substance abuse to be ruled out. So coming on to NIHSS scale, which was one of the short note asked in the recent exam. So it is nothing but National Institutes of Health Stroke Scale. It has level 1 it has 11 components, out of which few have subdivisions. Number 1 is level of consciousness. Based on that, it has been graded into 0, 1, 2. 1B is orientation questions, 0, 1, 2. 1C is response to commands, graded as 0, 1, 2. Second component is gaze. Third component is visual fields. Fourth component is facial movement. Fifth is motor function. Sixth is motor function lower limb. Seventh is limb ataxia. Sensory involvement. Language component. Articulation. Extinction or inattention. So, if the overall score is 0, there is no stroke symptom. If the overall score is 1 to 4, it is minor stroke. If the overall score is 5 to 15, then it is moderate stroke. If the overall score is 16 to 20, it is moderate to severe stroke. If it is 21 to 42, it is severe stroke. This scaling is the one major component which has been used for all trials for thrombolysis, for mechanical thrombectomy. So knowing the score, knowing the grading is very important. Coming on to investigations, the initial neuroimaging should be non-contrast CT. MRI when to do, I would discuss. The other important investigations to rule out stroke mimic is GRBS, ABG, renal function test, CBC. If suppose we are starting a patient on thrombolysis, then we need to have a baseline prerequisites of platelets and INR. And to rule out any coexistent cardiac issue, cardiac ECG, ischemia markers, and coagulation profile, and coagulation profile. Imaging. So the primary imaging as suggested by AHA is non-contrast CT. The main goal of neuroimaging is that we have to rule out hemorrhage, because if it is a ischemic stroke, we have to give thrombolysis. If it is a hemorrhagic stroke, it is only BP management and conservative treatment. So to exclude hemorrhage and to differentiate between ischemic core and penumbra, and to identify stenosis or occlusion if it is an MRI. Now, MRI to identify diffusion positive but flare negative lesions, and in patients who awake with stroke and have unclear time of onset more than 4.5 hours from baseline or last known well. That is when we are considering MRI. CT angio with CT perfusion or MRI angio with perfusion can be done for selecting candidates for mechanical thrombectomy between 6 and 24 hours after last known well. So coming on to the CT finding, in non-contrast CT, what are the earlier signs you're going to see? There could be a hypo-attenuating brain tissue, obscuration of lentiform nucleus, there could be dense MCA sign, there could be insular ribbon sign, there could be loss of sulcal effacement. So you can see that within 6 hours this CT has been done. There is an area of hypoattenuation. So these are other images showing obscuration of the lentiform nucleus with insular ribbon sign and the dense MCA sign. So coming on to the diffusion sequence, we can see that there is a left MCA infarct here, and this is an angio which is showing a cutoff sign of the MCA territory. This is CT angio, a perfusion, and the plain CT. So this is another MRI sequence with diffusion showing posterior, anterior, and middle cerebral infarction. So these are other images. So I was telling you that if there is a diffusion and flare mismatch, if there is a perfusion and a diffusion mismatch, that is when you decide on thrombectomy is needed or not. I will tell you the criteria. There is also one more score called aspect score, which is nothing but Alberta Stroke Program Yearly CT score, which is a 10-point quantitative topographic CT scan score. So it is a segmental assessment of the vascular territory where 1 point is detected from the initial score for every region involved. So lesser the score, more severe is the stroke. So based on anterior middle circulation, based on posterior circulation, the score has been divided. So when do we admit the patient into ICU? For airway protection, if there is a posterior circulation stroke with a risk of herniation or complications, if it is a malignant MCA infarct or a large cerebellar infarct, post thrombolysis monitoring, when there are signs of raised ICP, when the patient is having arrhythmia or severe hypo or hypertension. So coming on to supportive care, general supportive care, airway support and ventilatory assistance as needed, and especially in patients with bulbar dysfunction to concentrate on airway protection, and to provide supplemental oxygen only if the saturation is less than 94. If the saturation is more than 94, then no need to provide oxygen support. Coming on to blood pressure management, which is a very important question, theory wise, practical wise also. Hypotension and hypovolemia should be corrected to maintain the systemic perfusion and organ function. Patients who have elevated BP and are otherwise eligible for treatment with IV alteplase should have their BP carefully lowered so that their systolic BP is less than 195 millimeter mercury and their diastolic BP is less than 110 millimeter mercury before the IV fibrinolytic therapy is initiated. In patients for whom mechanical thrombectomy is planned and who have not received IV fibrinolytic therapy, it is reasonable to maintain BP less than or equal to 185 110 millimeter mercury before the procedure. The usefulness of drug-induced hypertension in patients with acute ischemic stroke is not well established. Coming on to treatment of hypertension, if suppose the patient is having more than 180, more than 220 BP, what are the drugs we should consider? Labetalol 10 to 20 milligram IV over 1 to 2 minutes, may repeat one time, or nicardipine 5 mg per hour IV, titrate up to 2.5 mg per hour every 5 to 15 minutes, maximum of 15 mg per hour. Clevidipine 1 to 2 mg per hour IV, titrate by doubling the dose every 2 to 5 minutes until desirable BP is reached. The maximum dose is 21 milligram per hour. If the BP is not maintained less than or equal to 185 110 millimeter mercury, do not administer alteplase. During and after reperfusion therapy, if the systolic BP is more than 180 to 230 millimeter mercury or diastolic BP is more than 105 to 120 millimeter mercury, then labetalol infusion can be considered 10 mg followed by continuous infusion of 2 to 8 mg per minute. Nicardipine 5 mg per hour IV followed by 2.5 mg per hour every 5 to 15 minutes you can titrate to a maximum of 15 mg, and clevidipine as previously said dose with a maximum of 21 mg per hour. If BP is not controlled or if the diastolic BP is more than 140 millimeter mercury, consider IV sodium nitroprusside, and the monitoring of BP, which is asked in almost always in all examinations, it should be done every 15 minutes for 2 hours, then every 30 minutes for 6 hours, and then every 1 hour for 16 hours. So these are some of the trials which are done for BP titration in acute ischemic stroke, where there was a CATIS trial where they tried tiered reduction in SBP versus normal management. There was no difference in death or major disability. There was also a trial called Enchanted trial where there is intensive BP reduction with intravenous thrombolysis therapy for acute ischemic stroke. Intensive group was 130 to 140 millimeter mercury versus guideline BP. Acceptable safety, but no major improvement in the functional outcome. So coming on to eligibility criteria for intravenous thrombolysis. The inclusion criteria are clinical diagnosis of ischemic stroke causing measurable neurological deficit, onset of symptoms less than 4.5 hours before beginning treatment. If the exact time of stroke onset is not known, it is defined as the last time the patient was known to be normal or at neurological baseline, and adult patients who are more than or equal to 18 years of age. So coming on to the exclusion criteria, if there is a history of ischemic stroke or severe head trauma in previous 3 months, if there is a previous intracranial hemorrhage, if there is an intracranial neoplasm, if there is a GI malignancy, GI hemorrhage in the past 21 days, intracranial or intraspinal surgery within the past 3 months, symptoms suggestive of SAH, persistent blood pressure elevation more than 185, more than 110, active internal bleeding, presentation consistent with infective endocarditis, stroke known or suspected to be associated with dissection, aortic dissection, or acute bleeding diathesis, platelet count less than 1 lakh, current anticoagulant use with the INR of more than 1.7, therapeutic dose of LMWH within 24 hours, and current use of NOACs, in direct thrombin inhibitor or direct factor 10A inhibitor with evidence of anticoagulant effect suggested by the lab investigations. If there is a evidence of hemorrhage, if there is extensive regions of obvious hypodensity consistent with irreversible injury. Warnings: only minor or isolated neurological symptom or rapidly improving symptom like a TIA, serum glucose less than 50 to rule out stroke mimics, serious trauma in the recent past 14 days, major surgery in the past 14 days, GI bleeding, seizure at the onset of stroke with postictal neurological impairments, pregnancy, arterial puncture at a non-compressible site previous 7 days, large untreated intracranial aneurysm, untreated intracranial vascular malformation. You should be a bit careful about giving IV alteplase because the bleeding risk is very high in these patients. Additional exclusion criteria, warning criteria from the ECAS trial and all: age more than 80 years, oral anticoagulation used regardless of INR, if there is a severe stroke with the NIHS is more than 25, and combination of both previous ischemic stroke and diabetes mellitus. So coming on to the trials, important trials which you should know in stroke for thrombolysis in acute ischemic stroke. One is the first trial, National Institute of Neurological Disorders and Stroke Recombinant Tissue Plasminogen Activator trial, that is NINS RTPA trial, where they tried thrombolysis in patients who presented less than 3 hours of symptoms. They excluded patients with hypertension, AV malformation, acute bleeding tendencies, thrombocytopenia, recent heparin within 48 hours, or INR more than 1.7, arterial puncture within 7 days, and any evidence of ICH on the CT, where they found that there is absolute risk reduction of 8%, meaning there was functional independence. There was another trial called ECAS-3 trial, that is European Cooperative Acute Stroke Study, where the inclusion criteria was the same. Exclusion was patients having ischemic stroke and diabetes mellitus, where they evaluated presentation within 4.5 hours, where there was an absolute reduction of 7%, the functional independent. And there is a next trial called IST3 trial, that is third international stroke trial. The inclusion criteria were same as RTPA, except there was no limit for age, where they tried thrombolysis for less than 6 hours. They found thrombolysis was beneficial, but the results were not statistically significant. And the next trial was a wake up trial, where MRI guided thrombolysis for stroke with unknown time of onset, where they included same inclusion criteria as NINS RTPA. Addition to that, last time known well more than 4.5 hours, and they also did a diffusion scanning MRI scanning, where there was a mismatch between presence of an abnormal signal on the diffusion and no visible signal on the flare. So if there was a diffusion flare mismatch, then they included those patients to save the penumbra. So thrombolysis was given in such patients. There was significant functional independence with a risk reduction of 11.5%. So this study had led us to think like whether the extra patients who come even after 4.5 hours can be included into the thrombolytic criteria. So coming on to the thrombolysis protocol per se, so the drug we commonly use is alteplase. So infuse 0.9 mg per kg with a maximum dose of 90 mg over 60 minutes with 10% dose given as a bolus over 1 minute. Always admit the patient to the ICU. If the patient has severe headache, acute hypertension, nausea, vomiting, or worsening of neurological symptoms after starting alteplase, stop the infusion and get an emergency CT scan. Always monitor the BP after thrombolysis. After starting thrombolysis, every 15 minutes during and after IV alteplase infusion for 2 hours. Then after 30 minutes, every 30 minutes for 6 hours, and then hourly until 24 hours after IV alteplase treatment. Increase the frequency if the BP measurements are more than 180, 105 during the administration of alteplase. Delay placement of nasogastric tubes, indwelling bladder catheters, intra-arterial pressure catheters if the patient can be safely managed without them. Obtain a follow-up CT or an MRI scan at 24 hours after IV alteplase before starting any anticoagulants or antiplatelet agents. So the delay placement of tubes can be up to 24 hours. Actually, there is no clear-cut guidelines mentioned anywhere, but most of the trials which are done had followed this protocol. So we are using that protocol to wait up to 24 hours. So so this is a gist of trial which showed comparison of other TPAs, other thrombolytic agents compared to alteplase. So there was a randomized trial of tenecteplase versus alteplase for acute ischemic stroke, where they used alteplase of 0.9 mg per kg regular dose and tenecteplase less than 6 hours of onset of ischemic stroke, where tenecteplase was associated with significantly better reperfusion and clinical outcomes than alteplase in patients with stroke who were selected on the basis of CT perfusion imaging. And there was one trial called Extend 1A tenecteplase trial, where they compared tenecteplase and alteplase within 4.5 hours of symptom onset, where tenecteplase before thrombectomy was associated with higher incidence of reperfusion and better functional outcome than alteplase. And followed by that, there was a Extend 1A tenecteplase part 2 trial, which suggested that high dose versus low dose tenecteplase did not offer any major change in the outcomes of the stroke patients with large vessel occlusion. And there was one trial called NOR test trial, where they compared tenecteplase versus alteplase, where tenecteplase was not superior to alteplase and showed a similar safety profile. Next, coming on to a meta-analysis which was released in 2019 comparing all significant trials, which showed an accumulated clinical trial data provides a strong evidence that tenecteplase is non-inferior to alteplase in the treatment of acute ischemic stroke. So there was one study called TRACE-2 study, which was released in 2024, which compared tenecteplase versus alteplase in acute ischemic cerebrovascular events, which was a randomized control non-inferiority trial, which showed that tenecteplase was non-inferior to alteplase in people with ischemic stroke who are eligible for standard intravenous thrombolytic but ineligible for thrombectomy. And this was another study in NEGM, which compared tenecteplase for stroke between 4.5 to 24 hours, where they found this was done in a Chinese population, which is a multi-center open label randomized control trial in China, which included many ICUs, where they found that in Chinese patients with ischemic stroke who did not have access to thrombectomy, tenecteplase administered between 4.5 to 24 hours after the onset of stroke symptoms with no disability had a better 90-day outcome. Just 1 minute, I'll just get the charger, just 1 minute. I'm so sorry. Sorry. Can you see my screen? Please, one of you, can you respond?
Yes, ma'am.
Yeah,
Yes.
sorry for the delay. Okay, there was another study in NEGM which compared ritaplase versus alteplase for acute ischemic stroke, which was a phase 3 randomized non-inferiority trial conducted in 62 sites in China, where they found that in patients with acute ischemic stroke who were eligible for intravenous thrombolysis within 4.5 hours after the onset of symptoms, ritaplase were more likely to result in an excellent functional outcome than alteplase. So coming on to the management of symptomatic intracranial bleeding after administration of IV alteplase. So stop alteplase infusion, send off the coagulation profile, basic hematological parameters with typing and cross matching, immediately get a CT brain plane. If there is a bleeding, then administer cryoprecipitate, 10 units infused over 10 to 30 minutes, and administer additional dose if fibrinogen is less than 150 milligram per deciliter. So tranexamic acid 1 gram to be administered over 10 minutes, and immediate hematology neurosurgery consultation to be taken if suppose DC is required, and general supportive management to be followed. If suppose the patient develops an orolingual angioedema after IV alteplase administration, maintain the airway, SOS intubation, and keep cricothyroidectomy ready, and discontinue IV alteplase infusion, hold AC inhibitors, administer steroids, diphenhydramine, ranitidine or famotidine. If there is further increase in angioedema, administer epinephrine intravenously as well as nebulizer wise. Coming on to mechanical thrombectomy. Patients who are eligible for mechanical thrombectomy can undergo IV thrombolysis if they had come within that window. And Dawn and Diffuse are the early RCTs which showed beneficial effects of mechanical thrombectomy who present even after 6 hours from the onset of the symptoms. So these criteria are usually followed when we take up a patient for mechanical thrombectomy. So what are the Dawn criteria used? So Dawn is nothing but diffusion or CT perfusion assessment with clinical mismatch in the triage of wake up and late presenting strokes undergoing neuro intervention with Trevo trial. So patients who present to the ER between 6 to 24 hours after last seen well are eligible. If there is an occlusion of intracranial ICA or proximal MCA are eligible. And there were 3 groups they included. Group A, who are more than 80 years, more than 10 NHSS score, but infarct volume of less than 21 ml. B, less than 8 years, NHSS score more than or equal to 10 with an infarct volume of less than 31 ml. And group C, less than 80 years, NHSS score more than or equal to 20 with an infarct volume of 31 to less than 51 ml. And CT or MRI based imaging and software analysis. Coming on to diffuse, patients presenting between 6 to 16 hours of last seen well, same transcranial ICA and proximal MCA, but they had different MRI infarct volume criteria less than 70 ml and CT based imaging criteria. So these patients who were included underwent thrombectomy, and there was an absolute risk reduction of 28% in diffuse 3 trial and Dawn trial, 36% in Dawn trial, which showed significant improvement. There were also other trials which did mechanical thrombectomy, less than 6 hours Swift Prime trial, which had a risk reduction of 24%, REVAS-CAT trial, which did less than 8 hours, which had 16% risk reduction, Escape trial, which tried less than 12 hours risk reduction 24%, and Extend 1 year trial where we thrombolize and then take up for thrombectomy, where there was a risk reduction of 31%. Because there are many trials in the recorded class, you can just slowly pause and see all the description of the trials. There were also a Mr. Clean trial which was tried less than 6 hours, which showed 14% risk reduction. And these are the trials which tried mechanical thrombectomy in a posterior circulation stroke, especially with a basilar artery occlusion, where Biochi and Attention trial, where they tried mechanical thrombectomy in a basilar artery occlusion between 6 to 24 hours and within 12 hours, where they found a significant improvement in the functional outcome. But Best and Basics trial, they did not show any significant improvement in the functional outcome. So Best and Basics had a negative outcome outcome. Biochi and attention had a positive outcome when it comes to posterior circulation stroke with basilar artery occlusion. So when we had Viva in stroke, they asked us about the retrievers which are used in mechanical thrombectomy, the name of the retrievers which were used in the trials. So these are some of the retrievers you should know of, at least the names. One is coil retriever, aspiration retrievers, stent retrievers, and these are the various trials which used these retrievers across various years. So coming on to the management of stroke in ICU, so head end elevation should be done. Analgesic sedation to blunt the sympathetic response and to improve the tube tolerance and synchrony. Avoid hypercapnia and hypocapnia. Temperature control, as Darshan sir said, in TBI or any neurocritical care, the secondary injury should be prevented. So the guidelines remains the same. So first is head end elevation, analgesic sedation, temperature control, which is an independent predictor of poor outcome. So treat the temperatures which are above 37.5 degrees Celsius. Glycemic control, so AHA recommends 140 to 180 milligram per deciliter. As there is a trial which showed a better outcome with such a sugar management, which is called SHINE trial, but no benefit on a tight control. Infusion is preferred over subcutaneous administration if the sugar levels are high, and hyperglycemia is one of the independent risk factor for a malignant stroke conversion. Coming on to nutrition, enteral feeding should be started within 7 days at least, or as soon as possible. For patients with dysphagia screening to be done. So initially, NG tube can be tried in the early phase, but later if the patient is fully dependent on the Riles tube, then a PEG can be tried after 7 days. Coming on to seizure management, usually uncommon after acute ischemic stroke. Unless witnessed, no need to treat seizures. If there is a witnessed seizure, then you treat. The choice of agents are phenytoin and levetiracetam. The main reason is that it causes secondary damage and worsens the edema, causing secondary brain injury. Continuous EEG monitoring is required in patients with sensorium out of proportion to the ischemic stroke. Coming on to antiplatelets, as per AHA, administration of aspirin is recommended in patients with acute ischemic stroke within 24 to 48 hours after the onset. If the patient is undergoing thrombolysis, then wait till 24 hours and then start. If the patient is not undergoing thrombolysis, then you give antiplatelet immediately, like 150 mg of ecospirin start, followed by a continuation dose to be continued. In patients presenting with minor non-cardioembolic ischemic stroke with NHS scores of less than or equal to 3, a treatment with dual antiplatelet therapy started within 24 hours of after the symptom onset and continued for 21 days is effective in reducing the recurrent ischemic stroke for a period of up to 90 days from the symptom onset. But it should be individualized and guided by the patient's underlying thrombotic and bleeding risk profile. So the starting of antiplatelet in an acute ischemic stroke, it could be a separate question. In Viva, this is a hot question always asked, like when to start and how long to continue is a common question asked. And these are the gist of trials which were done for antiplatelet therapy in an acute ischemic stroke. The important ones are point, chance, tails, fast trials, where the dual antiplatelet with aspirin and ticagrelor or clopidogrel given within 24 hours of high risk TIA or a non-cardioembolic mild to moderate stroke effectively reduces the risk of recurrent stroke and events compared with monotherapy. But they are also associated with risk of bleeding, and there is no difference in the risk of all cause death. This is as per Thales trial. So please remember the name of the trials and important outcomes in 1 or 2 trials. So overall, what we understood is ecospirin to be started within 24 to 48 hours, but dual antiplatelet therapy can be started in a minor stroke and continued up to 21 days. But bleeding risks are always there, so always measure the risk-benefit ratio. Anticoagulation, another hot question. So the usefulness of urgent anticoagulation in patients with severe stenosis of an ICA ipsilateral to the ischemic stroke, or for non-occlusive extracranial intraruminal thrombus, and the usefulness of argotraban, dabigatran or other thrombin inhibitors is not well established. But patients with acute ischemic stroke, in the setting of atrial fibrillation, it is reasonable to initiate anticoagulation between 4 and 14 days after the onset of neurological symptom. Contraindication in the first 24 hours post thrombolysis, if there is a large acute stroke involving more than 1/3 of the MCA territory, or if there is advanced microvascular changes in the brain as an amyloid angiopathy. Coming on to thromboprophylaxis, intermittent pneumatic compression is a grade 1 recommendation in addition to the routine care. Benefit of prophylactic LWMH or UFHN is not well established. Patients with stroke at a high risk of thromboembolic events and hemorrhagic transformation, initiation or continuation of antiplatelet or anticoagulation therapy may be considered depending on the specific clinical scenario and underlying indication. So coming on to cerebral edema, I think this has been extensively covered in the TBI. So based on this you have to keep in mind mainly for the malignant stroke and in the posterior circulation strokes, where the CPP has to be maintained between 60 to 70 millimeter mercury. Hyperventilation can be tried, which is a temporary measure. Therapeutic hypothermia can be tried, but there are no benefits as per UTHRM and POLAR trials. Barbiturate coma can be tried as a last resort if the initial trials have failed, and no role of steroids in acute ischemic stroke or cerebral edema unless it is malignancy related. Coming on to osmotic therapy, this also has been covered. 3% saline, mannitol can be either of that can be used. But 3% as per some of the meta-analysis systematic studies, 3% saline has advantage over mannitol in patients with hypovolemia and less chances of renal failure. But risk of rebound cerebral edema if stopped abruptly. So in patients with stroke and atrial fibrillation, rate versus rhythm control strategy, there is no benefit from rhythm control strategy over a rate control strategy as per AFFIRM, RACE and CHF trials. If LV function is good, try beta blockers for rate control. If LV function is poor, try digoxin and amiodarone. If unstable, try synchronized cardioversion. If the charts VAS score is more than 2, start anticoagulation and always check for the risk of bleeding using Has-Bled score. Coming on to malignant cerebral infarct, which could be asked as a short note and in viva. So when we call it as a malignant MCA infarct, when there more than 50% of the MCA territory is involved in CT, when the perfusion deficit is more than 66% on CT, if the infarct volume is more than 82 ml within 6 hours on MRI, or if the infarct volume is more than 145 ml within 14 hours in the MRI. So patient will have progressive deterioration of sensorium. There could be severe neurological impairment, and this will lead to increased mortality outcome. So embolic and thrombotic occlusion of distal ICA or main branch of MCA, or a failed recanalization with TPA are the usual risk factors which causes malignant MCA infarct. So this is a CT and a CT perfusion imaging showing malignant infarct, which is showing more than 50% of the MCA territory being involved. So what is the pathophysiology? It usually happens between the first and the third day after symptom onset. Severe reduction in the cerebral blood flow to the ischemic territory compromise the normal functioning of sodium potassium ATPase channel pump in the cell membranes, causing intracellular accumulation of sodium and water, causing cytotoxic edema. There is also increased permeability of the blood-brain barrier, causing vasogenic edema, and endothelial damage causing hemorrhagic transformation. So there will be midline shift and transtentorial herniation. There could be brainstem compression and death. So the clinical predictors for malignant stroke is that increased age, if the patient is having uncontrolled hypertension, or if the initial NHS score is only more than 20 or more than 15 within 6 hours of symptom onset, presenting level of consciousness is very poor. Radiological predictors, as I already told you, involving more than 50% of MCA territory, infarct volume more than 82 centimeters per cube, midline shift of more than 5 mm, simultaneously affecting other territories. And as I told you, this fever, hyperglycemia, age, hypertension are the clinical predictors which could tell us there could be this patient can go into malignant infarct. So we should control those. So in such cases of malignant infarct, the immediate treatment would be, along with all supportive care, a decompressive craniectomy can be tried. So the rationale is it decreases the ICP, it prevents the transtentorial herniation, and it could improve the perfusion in the penumbra. But it should be tried only if the age is less than 60 years or less than 48 hours since stroke. So these timelines are all set based on various studies conducted before. So these are the trials assessing the effect of decompressive craniectomy in a malignant MCA stroke. So there was a decimal trial conducted in 2007 where they did DC in malignant MCA infarct, where they found that there is an absolute mortality reduction of 52% with DC, but there is no difference in functional outcome. There is another trial called Destiny 1 trial where it showed a mortality reduction of 88 to 40, mortality reduction from 88 to 47% with DC after 1 month, but it did not comment on functional outcome. Then Hamlet trial done in 2009, there was a risk reduction of 38% for mortality, but no reduction in functional outcome. There was also a head first trial done on 2014 where craniectomy and durectomy where the difference in mortality was not significant. And there was Destiny 2 trial where they tried in elderly patients more than 60 years of age, there was significant reduction in severe disability. So this is again the gist of 3 trials. You can go through in the recorded class. So in all these trials, the functional outcome which I am repeatedly uttering is the modified Rankin score which they are using to assess the functional dependence of the patient. So this completes acute ischemic stroke. I have put what all important trials is needed for the exam as well as for the Viva and for clinical practice. If any doubts, please put up in the chat box. I will answer once the class is over. The second topic we are going to cover is CIPN. Hi, because there is a silence. Are my slides visible?
Yeah, Bona.
Yes. So coming on to critical illness, polyneuropathy and myopathy. So before going into the topic proper, topic proper, we'll just see the differential diagnosis of neuromuscular weakness in ICU, because this has been repeatedly asked, like as a differential diagnosis, or flaccid paralysis in the ICU, or myopathy in the ICU. Repeatedly, many questions had been asked. So we'll just see as a gist, the main causes of neuromuscular weakness in critically ill patients could be from central to peripheral. It could be CVA. It could be spinal cord related transverse myelitis, or there could be compression or infiltrative lesion. Coming on to anterior on cells, there could be amyotropic lateral sclerosis or poliomyelitis. Coming on to peripheral nerve, it could be GBS, CIPN, or vasculitis, or toxic neuropathies. Coming on to neuromuscular junction, it could be myasthenia, Lambert-Eaton syndrome, or we are giving a neuromuscular blocker which is causing the effect, or it could be botulism. Coming on to muscle, it could be CIM, severe electrolyte disorder, drug-induced and toxic myopathy. It could be infectious or inflammatory myopathy. There could be genetic disorders, mitochondrial disorders. So what we understand from this, so CIM, CIPN is not like immediately we see and diagnose. There are always confounding factors which will give differential diagnosis too. So it is kept as a differential diagnosis whenever the patient is having myopathy and neuropathy. So coming on to the topic, so this CIPN or ICU acquired weakness, this terminology was defined by Bolton and colleagues in 1986. So it is defined as a clinically detected weakness in a critically ill patient in whom there is no plausible etiology other than the critical illness has been found. So it can be further classified into myopathy, critical illness polyneuropathy, and myopathy based on the histopathological division. It could be cachectic myopathy, thick filament myopathy, necrotizing myopathy, or it could be a combination of myopathy and neuropathy. Coming on to the etiology, there is no single etiology which has been defined. It is usually the risk factors which we see if a patient is in a patient whom we are suspecting a CIM or a CIPN. So usually steroids and neuromuscular blockers, which we commonly use in ICU for various illness, could be the major contributing factor for CIM. It is told that if more than 10 grams of hydrocortisone is being used over a period of 1 to 2 weeks, and if the neuromuscular blockade has been continued for 3 to 5 days, then these patients are at risk to develop CIM or CIPN. So coming on to the main pathophysiology, so it starts with the muscle. If it is a myopathy, so there could be microvascular alteration causing vasodilatation, increased permeability, chemoattraction, and hypoxemia. If there could be metabolic alteration which could be happening at the muscle level due to hyperglycemia, there could be activation of catabolic pathway, there could be mitochondrial failure, there could be free radical injury and hypoalbuminemia induced damage. There could be electrical activation because of sodium channel dysfunction, calcium channel dysfunction, and cell inexcitability. So overall, the microvascular, metabolic, and electrical failure leads to CIM and CIPN. So as I told, there is no specific causative etiology. It is just the risk factor we look for. If the patient is having severe sepsis or septic shock, if the patient is having MODS, prolonged mechanical ventilation immobilization, increased duration of SIRS, increased duration of MODS, hyperglycemia, age, increased age, female gender, increased Apache score, hypoalbuminemia, hyperosmolality, parenteral nutrition, RRT, vasopressors, corticosteroids, or prolonged infusion of neuromuscular blocking agents are the risk factors for developing CIPN or CIM. So again, if the patient is on mechanical ventilator, parenteral nutrition, prolonged admission, hyperglycemia, severe sepsis or severe multi-organ failure could lead to acquired weakness. So same. So here this diagram is just dividing whatever I told into modifiable and non-modifiable risk factors. So the modifiable risk factors are our targets for the treatment protocol in CIM and CIPN for rehabilitation of the patient. We can control hyperglycemia, parenteral nutrition can be adjusted, drugs can be modified, and mobilization can be started, physiotherapy can be started. But non-modifiable risk factors which we cannot help with are older age, female sex, obesity, higher severity of illness, higher Apache score, and mods. So the criteria for diagnosing ICU acquired weakness are: the patient is been critically ill for more than a week. It is a very important criteria which you should remember, which is usually asked as a short note and especially in Viva. The weakness developing in critical illness more than 7 days. The weakness being generalized, that is proximal and distal muscle being symmetrical, flaccid, generally sparing the cranial nerve. And the weakness is not related to any other illness. Critically ill more than 7 days. Generalized weakness, symmetrical, proximal and distal, flaccid weakness, sparing cranial nerves, and the underlying causes are ruled out. And along with that, muscle power assessed by Medical Research Council, score of less than 48 on more than 2 occasions, separated by more than 24 hours, or dependence on mechanical ventilation. So they would ask, like, a patient is there bedside, how are we going to assess the patient is having CAM? So the patient might have only facial grimacing to pinch, deep pain stimuli, and the patient will have a retained pupillary reflexes. These are the bedside assessments which can be done for CAM. The Medical Research Council score, which I was talking to you about, if the patient has any visible motor activity. In upper extremity, we are seeing wrist extension, elbow flexion, shoulder abduction. In lower extremity, we are seeing ankle dorsiflexion, knee extension, and hip flexion. So the score is graded as 0, no visible contraction, 1, visible muscle contraction but no limb movement, 2, active movement but not against gravity, 3, active movement against gravity, 4, active movements against gravity and resistance, 5, active movement against full resistance. So usually the maximum score is 60. If anything less than 48 on more than 2 occasions separated by more than 24 hours is considered significant for ICU acquired weakness. Now, diagnostic criteria for specifically for CIP and CAM. So whatever criteria I told is that generalized criteria for both. Now we have to break down it to CIP and CIM. So in CIP, the polyneuropathy, there will be an electrophysiological evidence of axonal motor and sensory polyneuropathy, but there will be a normal response to repetitive nerve stimulation. Whereas in myopathy, there will be reduced motor response, amplitude of less than 80% of normal in at least 2 nerves without conduction block. There will be preserved sensory response because the nerve is intact, and there will be a myopathy pattern in EMG and muscle non-excitability in DMS and normal response to repetitive nerve stimulation. And if you do a muscle biopsy, you would see one of the 3 types of the myopathy. And usually they tell there will be a fibrillatory pattern in a EMG. So this is again the electrophysiological factor which I told you. The additional thing which this table is telling to you is that the serum CPK, which will be elevated in a myopathy, but it will be nearly normal to normal in a neuropathy. Otherwise, rest all has been discussed. So coming on to approach. So how are we going to approach the muscle weakness? When a patient, critically ill patient, is having a muscle weakness, if you have ruled out all the underlying other differential diagnosis, then the first thing the next thing we are suspecting is a CAM or a CIPM. So we are subjecting the patient either to MRC score, which should be less than 48, and there is a device called hand grip dynamometry. So where the patient will hold that dynamometry and press that dynamometry device, what is the maximum compression the patient can give. So if the hand grip dynamometry is more than or equal to 11 kg in males or more than or equal to 7 kg in females, then there is no ICU acquired weakness. I will share the picture of this dynamometry. I forgot to put it. But if the pressure, if that compression weight is less than 11 kg in males or less than 7 kg in females, then we have to subject them to MRC, and if it is less than 48, then there is a diagnosis of ICU acquired weakness. And once we diagnose that, we are going to subject the patient to nerve conduction study and electromyography based on the suspicion. And we have seen that definitive clinical features in both headings where we differentiate. But overall, whatever differentiation we do, the treatment is rehabilitation and nerve stimulation if it is a neuropathy. So it is again the table which is differentiating the features. Coming on to management. So as I told you, the modifiable risk factors to be addressed: hyperglycemia, sedation, steroids, and any other risk factor which we can modify. And the most important role is done by physiotherapy, that is rehabilitation by early remobilization, or functional electrical stimulation if it is a neuropathy, and intensive physical therapy and passive mechanical loading are the adjuncts to the management. So why it is very important? Because it is going to increase the duration of mechanical ventilation, increase the hospital stay, increase the mortality and secondary infective dependent factors. So that is why the modifiable risk factors has to be addressed. So coming on to a sequelae of that myopathy, neuropathy, whatever the neuromuscular weakness a patient is facing, even after discharge, which is called as a post-intensive care syndrome, which is again a new topic, has been recently asked, which you should mandatorily know. So why this topic is important? Because as per a study, these are the most common symptoms where the patient come back and get admitted to the ICU post critically ill phase and getting discharged home and coming back to us. The most common symptoms would be fatigue, depressive symptoms, anxiety symptoms, frailty, and PTSD symptoms. So overall, there could be pain, fatigue, psychosocial, physical impairments, which forms the overall composition of post-intensive care syndrome. So basically, this was designed by SCCM in 2010 to raise awareness among clinicians, patients, families, and the general public to increase the screening for specific impairments in a patient who had been critically ill, prolonged admission and been discharged, and to facilitate further research into specific morbidities. So it is not a medical diagnosis, but it is a concept for improving education as well as to understand the post-ICU impairments in patients and to help them out. So the definition goes like, it is a new onset or a worsening of impairment in physical, cognitive, mental health that arose after the ICU and persisted beyond the hospital discharge. But this can also be applied to the patient family member who has been continuously exhausted because of the critical illness, financially, physically, mentally. If it comes to the experiences of the family member, then it is called PICSF, of a survivor of critical illness. So all these components to be there in the definition: physical, cognitive, or mental health that arise after the ICU and persistent beyond the hospital discharge. So the risk factors for this PICS are advanced age, female sex, history of mental illness, increased severity of the illness, or poor ICU patient experience, including negative memories of the ICU and delirium. And these were the factors were significantly associated with the mental and the cognitive impairments. And the subtypes of PICS are, it could be mildly impaired physical and mental health status. It could be moderately impaired physical and mental health status. There could be severely impaired physical and moderately impaired mental health status. or there could be severely impaired physical and mental health status. So there is a study called ALTO study, which is a multi-center study which assessed the PIC syndrome in an ARDS patient at a 6 and 12 months after ARDS and after discharge. So this study had given a better insight to PICs with the data evaluating the cognitive, physical, mental impairments. So this study divided the PICs into hyper and hypoinflammatory subphenotypes, where the hyperinflammatory type was associated with decreased survival at 90 days, but the physical, cognitive, mental outcome with both phenotypes at 6 and 12-month follow-up were more or less the same. So this is the diagram showing clinical manifestation and risk factors for PICs. So coming on to the mental health, there could be depression, anxiety, PTSD, self-harm and suicide. Coming on to cognitive impairment, there could be memory loss, dementia, impaired executive function. Coming on to physical impairment, there could be disability, dyspnea, weakness, mobility impairment, malnutrition and sleep disturbances. Coming on to financial toxicity, there could be bankruptcy. Coming on to family impact, there could be a caregiver burden, financial loss, change in the family structure, complicated grief and mental health issue. So as I told you, here also the risk factors are divided into non-modifiable, modifiable and potentially modifiable risk factors, where we cannot change anything with the non-modifiable, but we can definitely address the sedation use, delirium addressal, immobility, sleep disturbances, hyperglycemia and negative memories of ICU, like which we should understand in a day-to-day practice, which we can improve from our side to prevent PICs. So this is the diagram showing the socio-economic factors exacerbating and exacerbated by PICs. So as an individual, as a family level, at a community level, at the health system and policy wise. Coming on to the PICS family, if the patient undergoes death or worsening severity of illness, or if the caregiver bound to be younger age or a child of an adult patient, financial instability with a decreased educational level or a decreased social support, or if there is poor communication with the staff, less family involvement on rounds, these are all the risk factors for PICS family, which could lead to anxiety, depression and complicated grief and PTSD in caregivers. And the other complicating factors could be caregivers burden, job loss and financial toxicity. So this is a diagram showing what is the usual transition of care should be and what are the barriers that is preventing this transition of care. So whenever the patient is in the ICU getting discharged to the floor, they should be screened and they should be arranged for a PICS clinic visit. So once the patient reaches home between 2 to 4 weeks, there should be a follow-up for the PICS clinic, where the PICS clinic is run by a multidisciplinary team by neurologist, the psychiatrist and the intensive care physician or the pulmonologist and the physiotherapist, who all play a major role in the post-ICU clinic. But what are all the barriers that could stop this transition of care? Patient, one is increased age, severity of illness and dependence on others, frailty. There could be financial reasons. There could be environmental reasons, where these PICS clinics are very new. Like it may be present only in the metro cities. They may not be able to reach from interior places. So these are all the barriers which could prevent this transition of care. So as I told you, this is the actual treatment of the PICS which you should mention in your answer sheet. So there are some named indexes which are mentioned here. I'm not going to go into deep into that because there are many. Please refer to the abbreviations. Coming on to cognitive part, there should be cognitive retraining, compensatory strategies, exercise therapy and occupational therapy. Coming on to the physical part, it can be divided into respiratory, general and weakness therapy, where respiratory oxygen titration, breathing exercises and pulmonary rehabilitation should be tried. and mobility aids, environmental adjustments, graded exercise programs, physical therapy should be tried, and psychological support groups, psychotherapy, psychiatric referral, and social work referral should be done. So again, this is a gist. So it should be run. So whenever you feel a patient fits into higher risk category of PICS, advise them for the transition of care to the PICS clinic within 2 to 4 weeks to come back with the psychiatrist, psychologist, physiotherapist, and neuropsychologist to help out with all the components of PICS. So these are the previous questions with stroke and critical illness which I told you. Please look into it. Thank you. Any doubt you can put up in the chat box. Thank you. Whomever is the next speaker can take over.
Thank you, Guna. Able to see my slides?
No, ma'am. The PPT has not opened. It is
Okay.
same that list is seen.
Okay, sorry. Okay, done.
Yes, ma'am. Now I can see. Yes.
Okay. So good evening, everyone. So till now we have discussed the major CNS topics and one of the neuromuscular disorder. So in the next 45 minutes, we will be discussing two other important neuromuscular disorders. The first one is the GBS and the second one is the myasthenic crisis. So we'll start with the GBS. So my outline would be introduction, the different variants of GBS, the pathophysiology, clinical features, how to diagnose, what are the criteria for ICU admission, the treatment, and how to monitor the disease progression, what are the complications, and management of the clinical progression with the outcome prediction, and important thing is the rehabilitation. So the previous year questions were it was not asked many times in the exams, only once in the FAT 2020. Basically, the differential diagnosis and ICU management of a patient with acute flaccid paralysis. So coming to the introduction, what is GBS? It is nothing but an inflammatory disease of the peripheral nervous system and is one of the most common cause of the acute flaccid paralysis. So it is defined as acute onset ascending sensory motor neuropathy, and the global incidence is around 1 to 2 per 1 lakh population. Males are most commonly affected and all age groups are equally affected. Coming to the variants of GBS. So the most common one is the classic sensory motor, that is nothing but the AIDP, acute inflammatory polyneuropathy, demyelinating polyneuropathy, followed by you have the pure motor, the Miller-Fisher syndrome, the Bickerstaff brainstem encephalitis, the pharyngeal cervical brachial syndrome. So coming here, and this is actually a beautiful description of the different variants of GBS. If you see in classic sensory motor, you will have both the motor as well as the sensory symptoms. In the motor, pure motor, it is only the motor symptoms. Coming to the Miller-Fisher variant, okay, it mainly involves the ataxia, and in the facial there are some motor symptoms. And coming to the Bickerstaff brainstem encephalitis, it basically involves the ataxia, the sensory and the motor symptoms, and important one is the decreased consciousness. So as we see, the most common is the classic sensory motor GBS, followed by the pure motor and the paraplegic, and the least one is the pure sensory. So coming to the Miller-Fisher syndrome, the frequency is around 5 to 25%, and it is a triad of ophthalmoplegia, ataxia, and areflexia. Becker-Staff brainstem, it is a combination of ophthalmoplegia, ataxia, areflexia with some pyramidal tract signs and the impaired consciousness. Coming to the pathogenesis of GBS. So around 2/3 of the patients have a preceding event. That too, most common is a preceding infection in the past 6 weeks of the onset of the condition. And the most common infectious agents are Campylobacter jejuni, CMV, hepatitis E virus, mycoplasma, EBV, and the Zika virus. One important thing is the absence of an antecedent illness will not rule out the diagnosis of GBS, as these infections or other immunological stimuli can be subclinical. The other preceding event could be any vaccination, previous vaccinations, especially the influenza vaccine, or administration of any immunoglobulins like TNF antagonists or any interferon antagonists. So, sorry. So as I told, what is the immunopathogenesis of GBS? So these two important words are, have to be mentioned in your exam. One is molecular mimicry. Second is anti-ganglioside antibodies. So coming to this, so as we know, in Campylobacter jejuni, these are the bacteria which have an outer membrane and an inner membrane, and these outer membranes have a lipo-oligosaccharides. Okay, so these lipo-oligosaccharides on the C. jejuni outer membrane, they elicit the production of the antibodies which cross-react with the gangliosides on the peripheral nerves. So this antibodies, they bind to especially the nodal axolemma, leading to complement activation and membrane attack complex formation, which leads to the disappearance of voltage-gated sodium channels, leading to detachment of the myelin, especially in the paranodal region, leading to nerve conduction failure. Okay, especially the most common site in AIDP is the Schwann cell, where these antibodies go and get attached, and whereas in the Aman, it is the node of Ranvier. Coming to the clinical features. So these are divided into two. One is the typical features and the other are atypical features. So what are the typical features? One is it is a rapidly progressive bilateral weakness of both the arms and the legs in the absence of any CNS involvement or other obvious causes. Second is there is either absent or decreased reflexes. Third is the dysautonomia. Okay, where there is a variation or instability in the blood pressure, heart rate, there is pupillary dysfunction and bowel and bladder dysfunction. The other one is pain. Pain is actually a frequent manifestation in GBS, and it could be muscular, radicular, or neuropathic. And the other one is the disease onset. Usually it is acute or subacute, with the patients typically reaching the maximum disability within 2 weeks. Suppose if the patient reaches the maximum disability within 24 hours or after 4 weeks, then you have to think of any alternative diagnosis. It has a monophasic clinical course, except for some relapses and the treatment related failures. Coming to the atypical features. So as we told, it is basically symmetrical, can present as asymmetrical, and could be predominantly proximal or distal, and it can start anywhere. Usually it starts with the legs and then as it is an ascending one, it could also be a descending one also. There could be severe and diffuse pain or isolated cranial nerve dysfunctions, which can precede the onset of weakness. And in children, it could be poorly localized pain, refusal to bear weight, irritability, meningism, or an unsteady gait. So coming to the diagnosis. So diagnosis, basically you should rely on the clinical history and the examination, and this can be supported by ancillary investigations like CSF examination and electrodiagnostic studies. So there are two diagnostic criteria for GBS. The important one and which we follow is the NINDS criteria, which is the National Institute of Neurological Disorders and Stroke, which was proposed in 1978 and revised in 1990. So this is very important, especially in the practicals. They will ask all these things. What are the features for diagnosis? What are the features that strongly support diagnosis and which cast a doubt on diagnosis. So as I told, features required for diagnosis are two important things. One is the proximal bilateral weakness of arms and legs, and there could be absent or decreased tendon reflexes. So what are the features which strongly support the diagnosis? One is the onset, as we told, usually less than 2 weeks, and it should be symmetrical. There could be relatively mild sensory symptoms and signs. And cranial nerve involvement, especially the bilateral facial nerve involvement, is very common. Autonomic dysfunction. And if you come to the CSF, there could be albuminocytological dissociation and the electrodiagnostic features. Features which cast a doubt on diagnosis. This is the most common question which has been asked in the practical exam. So as we told, any increased number of mononuclear or morphonuclear cells in the CSF. Second, if there is an asymmetry of weakness. If there is a bowel or bladder dysfunction at onset of the weakness, or if there is fever at the onset, or if it is less than 24 hours or more than 4 hours, 4 weeks after the symptom onset, or if there is a sharp sensory level indicating a spinal cord injury, the others. And the other criteria, which is not regularly used, is the Brighton collaboration diagnostic criteria, which is level 1, level 2, level 3. If you know the name, that's more than enough. Coming to the differential diagnosis of GBS, I think Bhuvan has already discussed about this, the same. What are the causes for acute flaccid paralysis? So it could be any CNS conditions, muscle conditions, NMJ conditions, or the polyneuropathies. Rather than putting in the box, I think this would be a better description. You can just put a diagram and just mention like this. So if you have a dorsal root ganglia dysfunction, then the causes could be Friedreich ataxia, hereditary sensory neuropathy. If there is any anterior horn sense involvement, it could be secondary to spinal muscular atrophy, polio, tetanus. If there is a peripheral nerve involvement, it could be important causes the Guillain-Barré syndrome. And if there is a neuromuscular junction involvement, the most common is the myasthenia gravis, botulism, Lambert-Eaton syndrome, and Duchenne muscular dystrophy. And for the muscle, you have the facioscapular humeral dystrophy. Coming to the laboratory investigations. So we have a lot of differential diagnosis, right? So to rule out all this, we have to do a lot of laboratory tests like a complete blood count and glucose levels, electrolytes, kidney function tests, liver enzymes, basically to rule out other causes of acute flaccid paralysis. Now coming to the serum level of anti-ganglioside antibodies. How important is it? As actually it is limited, availability is limited, and it is assay dependent. A positive test can be helpful, especially when the diagnosis is in doubt, but a negative test doesn't rule out the diagnosis of GBS. Anti-GQ1B antibodies actually are found in 90% of patients with Miller-Fisher syndrome and have a greater diagnostic value in these patients. But other antibodies are actually not so important for the diagnosis. So when GBS is suspected, you do not wait for any antibody testing results before starting the treatment. So as I told, the ancillary tests, two important. One is the CSF examination and other one is the electrodiagnostic tests. So what is the classic finding in GBS in the CSF is the elevated CSF protein levels with a normal CSF cell count. That is nothing but the albuminocytological dissociation. However, these protein levels are normal in around 30 to 50% of patients in the first week after the disease onset and 10 to 30% of patients in the second week. Therefore, a normal CSF protein levels do not rule out a diagnosis of GBS. Coming to marked pleocytosis, that is more than 50 cells, suggest any other pathologies like leptomeningeal malignancy or infections or any other inflammatory diseases of the spinal cord or the nerve roots. Coming to the electrodiagnostic studies. These are also not required to diagnose GBS. It is just helpful in supporting the diagnosis in patients with especially the atypical presentation. So a sensory motor polyradiculoneuropathy or myopathy, polyradiculoneuropathy, which is indicated by the reduced conduction velocities, reduced sensory and motor evoked amplitudes, abnormal temporal dispersion, and there is a partial motor conduction blocks. These are actually the things which are seen in this electrodiagnostic studies. The typical for GBS is nothing but the sural sparing pattern in which the sural sensory nerve action potential is normal, but when you test the median and the ulnar sensory nerve action potential, they are either abnormal or even absent. So these electrophysiological measurements might be normal when it is performed early in the disease, that is within 1 week of symptom onset, in patients with initially proximal weakness, mild disease, slow progression, or in MFS. In such patients, a repeat electrodiagnostic study 2 to 3 weeks later may be helpful. So these are the different subtypes and the NCS findings. In AIDP, you will find demyelinating polyneuropathy. In MAN, you can find axonal polyneuropathy and the sensory action potential could be normal. In AMSAN, you can see the same axonal neuropathy and the sensory action potential is either reduced or absent. So this is the difference between these two. And in Miller-Fisher variant, in almost all cases, in most cases, it is normal. But the antibodies are important in Miller-Fisher syndrome. So coming to the other diagnostic, other diagnostic procedures which can be helpful in GBSR for MRI. This is not a part of a routine diagnostic evaluation, but it is helpful in excluding the differential diagnosis such as any brainstem infection, stroke, spinal cord or anterior horn cell inflammation, leptomeningeal malignancy. The presence of a nerve root enhancement on gadolinium enhanced MRI is a non-specific but a sensitive feature of GBS, and it can support a GBS diagnosis. Coming to the ultrasound imaging of the peripheral nerves, which is now gaining importance. So what do you see is nothing but the enlarged cervical nerve roots early in the disease course. So this technique helps to establish a diagnosis of GBS early in the disease course when you have still a diagnosis dilemma. So coming to the ICU admission criteria. So what are the criteria? One is if there is any evolving respiratory distress with imminent respiratory insufficiency. The second one is if there is severe autonomic cardiovascular dysfunctions like arrhythmias or any fluctuations in the blood pressure. Third, if there is a severe swallowing dysfunction or diminished cough reflex. And the fourth one is rapid progression of weakness. So now, as I told here, there is imminent respiratory insufficiency. What do you mean by that? So the imminent respiratory insufficiency is defined as a clinical signs of respiratory distress, which includes breathlessness at rest or during talking, inability to count to 15 in a single breath, use of accessory respiratory muscles, increased respiratory or heart rate, the vital capacity of less than 15 to 20 ml per kg or less than of around 1 liter, or an abnormal ABG or a pulse oximetry measurements. So this is one of the important prognostic tool. What is that? IGRIS, the Erasmus GBS Respiratory Insufficiency Score. Okay, this was developed to calculate the probability of a patient who requires mechanical ventilation within 1 week of the assessment. So there are basically 3 measurements. One is the days between onset of weakness and hospital admission. Then facial and or bulbar weakness at hospital admission, and the MRC sum score at hospital admission. So MRC sum score already Bhuvana has discussed. So you have the 3 categories and you have a score of around 0 to 7. So an IGRIS of 0 to 2 tells that there is a low risk of mechanical ventilation, around 4%. A score of around 3 to 4 tells that 24% of patients may land up in mechanical ventilation, and a score of more than 5 or equal to 5 tells that there is a high risk of mechanical intervention, that is around 65%. So this is an important prognostic tool which we have to perform when a patient of GBS comes to our ICU. Now, what are the risk factors for prolonged mechanical ventilation? The first one is inability to lift the arms from the bed at 1 week after intubation. Second one is an axonal subtype or unelicitable nerves in the electrophysiological studies. In these patients, better to consider early tracheostomy. Now coming to the treatment. So we all know 2 important treatment modalities. One is the IVIG and the plasma exchange. So IVIG, the dose is around 0.4 gram per kg body weight daily for 5 days. And the plasma exchange, which is 200 to 250 ml plasma per kg body weight in 5 sessions, which is usually performed in on the alternate days. And there are a lot of studies and systemic reviews which have told that both are equally effective treatment for the GBS. But the advantage of IVIG is that it is easier to administer and generally more widely available than the plasma exchange. Hence, usually they tell it is a treatment of choice for GBS. And plasma exchange followed by IVIG is no more effective than either treatment alone. A lot of trials have been done on this. Now, what are the other treatment? So, a lot of people also tell about the corticosteroids. So, is there any role of corticosteroids in GBS? So, theoretical wise, corticosteroids would be beneficial in reducing the inflammation and therefore the disease progression in GBS. But there are some 8 randomized controlled trials which has shown that there is no significant benefit, and they have even shown that it has a negative effect on outcome. So there is no role of corticosteroids in GBS. Coming to the antimicrobial or antiviral treatment, it can be considered in patients with GBS who have an ongoing infection. However, preceding infections have usually resolved before the onset of the weakness. Coming to the treatment of pure Miller-Fisher syndrome. So basically, these patients have relatively mild disease course and most of them recover completely without any treatment within 6 months. But they should be monitored closely because a subgroup can develop limb weakness, bulbar or facial weakness, or respiratory failure. Coming to the Becker stuff, so this is the most severe form of the GBS. So it justifies treatment with IVIG or plasma exchange, although evidence for the efficacy of this treatment in this context is limited. Coming to the pregnant woman with GBS. So neither of the treatment is contraindicated during pregnancy. However, plasma exchange requires additional considerations and monitoring. So IVIG would be better preferred in these patients. Now next, how to monitor the disease progression. So first one is you have to monitor the respiratory function. So you monitor if the patient is using any accessory respiratory muscles, and you have to do this counting during expiration of 1 full capacity inspiratory breath. That is nothing but a single breath count, which we usually do in a patient who is not requiring the mechanical ventilation. So they tell that value less than or equal to 19 predicts a requirement for mechanical ventilation. And the other important rule which is important in GBS is the 20-30-40 rule. This is nothing but a patient is deemed at a risk of respiratory failure if his vital capacity is less than 20 ml per kg. The maximum inspiratory pressure is less than 30 centimeter of water, and the maximum expiratory pressure is less than 40 centimeters of water. Second is you have to assess the muscle strength in the neck, arms, and legs using the MRC grading scale, which has already been discussed. And the third one is the functional disability, which has to be assessed by using the GBS disability scale. So this has 0 to 6 number. So 0 means healthy. 1 is the minor symptoms. 2 is the patient is able to walk without support. Third is able to walk with support. Fourth is the patient is confined to bed or chair bound. Fifth is the patient requires assisted ventilation. And 6 is death. The next one, patient should be monitored for swallowing and coughing difficulties. And the last one is the autonomic dysfunction, which has to be assessed via ECG to monitor the heart rate, monitor the blood pressure, bowel and bladder dysfunction. Coming to the complications of GBS. So the complications include either choking, cardiac arrhythmias because of long stay in hospital, and because there are a lot of artificial tubings. Hospital acquired infections are more common in these patients. Pain and tactile allodynia. Most of the patients land up in delirium, depression. There could be urinary retention and constipation. Corneal ulcerations, dietary deficiencies, pressure ulcers, and compression neuropathies. And if you don't give any rehab, then the patient might land up in limb contractures and ossifications. So the management of clinical progression. So first one is insufficient response to treatment. So you have given IVIG or plasma exchange and then you saw that patient was not responding properly. So what do you do? So around 40% of patients do not improve in the first 4 weeks following treatment. Such disease progression does not imply that the treatment is ineffective, as progression might have been worse without the treatment. So in such conditions, you may consider repeating the treatment or changing to an alternative treatment. But at present, there is no evidence that exists to approach that this approach might improve any outcome. The second one is treatment-related fluctuations. So this is seen in 6 to 10 patients of GBS. So this is defined as disease progression occurring within 2 months following an initial treatment-induced clinical improvement or stabilization. So this has to be distinguished from clinical progression without any initial response to treatment. So TRF indicates that the treatment effect has worn off while still the inflammatory phase of the disease is ongoing. Therefore, in such patients, you can again repeat a full course of IVIG or plasma exchange, although evidence to support this approach is still lacking. So actually, we had recently this patient who had been given around 5 sessions of plasma exchange. He improved for a week. Then again, he had worsening of the weakness. So we thought it is treatment-related failure. So we gave 3 more days of plasma exchange, and now there is a significant improvement in weakness. So the third one is the chronic. When the patient goes into a chronic stage, around 5% of patients with GBS, they relapse, and this is known as acute onset CIDP. It typically presents with 3 or more TRFs or a clinical deterioration of greater than or equal to 8 weeks after the disease onset. Now, predicting outcome in GBS. So most patients with GBS, even those who are tetraplegic at nadir or require mechanical ventilation for a long period of time, actually show extensive recovery, especially in the first year after disease onset. So around 80% of patients regain the ability to walk independently at 6 months after the disease onset. So the probability of regaining this walking ability can be calculated by using the modified EGOS prognostic scale, that is nothing but the modified Erasmus GBS outcome score. So this is usually done at hospital admission and at 7 days of admission. So it basically includes the age at onset, any preceding diarrhea, MRC sum score at hospital admission and at 7 days of admission, and then the total score. So death occurs at around 3 to 10% of cases, most commonly due to cardiovascular and respiratory complications. And the risk factors for mortality are advanced age and severe disease at onset. The recurrence rate of GBS is around 2 to 5%. The important thing is the rehabilitation. So patients with GBS can experience a range of long-term residual problems like incomplete recovery of motor and sensory function, fatigue, pain, and psychological distress. So before the patient is discharged, these possible long-term effects of GBS should be considered and managed. So coming to first the physical function. So you have to arrange a rehabilitation program with a specialist, especially the rehabilitation specialist, physiotherapist, and an occupational therapist. Basically, the aim is to reduce the disability in the early stages of recovery and later to restore the motor as well as the sensory function and physical condition to the pre-disease level. So you have to give a lot of exercises to them. You have to do some stationary cycling, walking, and strength training has to be done. But while doing all these things, you should keep in mind this, these patients actually go into fatigue very easy. So just give some, breaks in between your exercise or the any rehabilitation modes. Now, the second one is, as I told, fatigue. Around 60 to 80% of these patients may complain about disabling complaints like fatigue. As with recovery of physical function, a graded supervised exercise program has been shown to be useful in reducing the fatigue. Coming to the pain, severe pain is actually reported in around 1/3 of patients with GBS, even after 1 year of the disease onset, and it can persist for more than 10 years. So the chronic pain is characterized by muscle pain in the lower back and limbs, painful paresthesias, arthralgias, and radicular pain. So these may lead to immobility, and neuropathic pain is a very devastating pain in these patients. So mobilization and drugs for the neuropathic or the nociceptive pain has to be given to these patients. Coming to the psychological distress, Early recognition and management is important in these patients as it can influence the physical recovery and also the mental status of these patients. So refer the patient to a psychologist or a psychiatrist, and you have to provide accurate information on the relatively good chances of recovery and the low recurrence rate in these patients, which may help reduce their fear and their anxiety. So connecting patients with others who have had GBS will help them to guide them through the rehabilitation process. For this, there is something known as GBS or CIDP Foundation International. This is basically an association where you have the previous GBS treated patients and their experiences. So this is the last slide, which shows 10 steps to diagnose and manage the patients of GBS. So if you just write this for a 10-mark questions, that is more than enough. So we have already discussed everything in detail about this. Thank you. Now my second topic would be myasthenia gravis. I will not be dealing the myasthenia gravis topic, but I'll be only dealing with the exacerbation and the crisis because these are the patients who usually come to our ICUs. Now, my outline of the topic would be introduction, definition, what is the pathophysiology, the precipitants, clinical features, diagnosis, and management. There were no previous questions as such of myasthenia crisis or myasthenia in your theory exams. So, coming to the introduction, as we know, myasthenia is actually a disorder of neuromuscular junction, and it is usually auto-antibody mediated. The usual incidence is around 3 to 4 per million per year. So coming to the exacerbations or the crisis per se. So these are the most critical incidences in myasthenia gravis. Around 15 to 20% of all myasthenia patients, they develop a crisis in their course of the disease. And around 20% patients actually manifest as an initial symptom. Means these patients doesn't know that they have a myasthenia gravis, but they actually manifest as a crisis. And then they would be diagnosed as a myasthenia gravis. The recurrence rate is around 30% and the lethality is around 5 to 10%. So the intensive care of myasthenic patients basically includes the management of dysphagia, delirium, and the perioperative management of patients undergoing thymectomy and weaning. These are the specific challenges in the treatment of myasthenic patients in the ICU. So what is the definition of this myasthenic crisis? It is nothing but a constellation of clinical conditions in which within a few days or more rarely within a few hours, there is a severe weakness of the bulbar innervated muscles or the respiratory muscles, which restricts breathing or the speech ability so severely that a supporting feeding, intubation, or ventilation are required. So there are three things in the myasthenic crisis. One is the acute respiratory insufficiency. The second one is aspiration, leading to aspiration pneumonia. And the third one is the restriction of the ability to swallow or cough, leading to globus. Now, coming to pathophysiology of myasthenia gravis in general. So, first we'll come to know what is a normal neuromuscular transmission. So, as we know, in the motor nerve impulses travel to the motor nerve terminus, where the acetylcholine is released, and this acetylcholine diffuses across the synapse, which leads to across the synapse, and then they get attached to the ACH receptors in the motor end plate, leading to depolarization of the muscle fiber and causing muscle contraction. So what happens in the neuromuscular transmission in myasthenia gravis? So basically till this step, it is the same. So the acetylcholine will be released, it gets diffuses across the synapse. But what happens later is that these ACH receptor sites are either weakened or destroyed by the antibodies which block the ACH receptor, leading to basically what happens is the depolarization and the muscle contraction doesn't occur, leading to the blockage of the neuromuscular transmission. So as I told, the ACH will be released here. These are the nicotinic receptors. So the released ACH will bind to this receptor and leads to muscle contraction. But what happens in myasthenia gravis? So the ACH is released here, but coming to the nicotinic receptors, what happened here is there is antibodies against these nicotinic receptors. Hence, the acetylcholine will not be bounding to this receptors, and there will be no neuromuscular transmission or the muscle contraction. So what are the precipitants for this myasthenic crisis? Any concurrent infections, pregnancy, surgical interventions, tapering of immunosuppressive drugs, and other drugs which might lead to the causation of myasthenia gravis. There are a lot of drugs which cause the myasthenic crisis, important among them being the calcium channel blockers, the antiarrhythmics, the quinolone derivatives, H2 receptor antagonists. Antibiotic wise, you have the aminoglycosides, macrolides, most of the anti-epileptics, and magnesium sulfate, and any neuromuscular blocking agents. So what are the clinical signs of exacerbation or imminent crisis? So there will be some febrile infection in the preceding 2 weeks of the crisis. Inverse aspiration, that is, food and drink might enter the nose when swallowing. There could be insufficient swallowing, which may manifest as coughing or throat clearing after swallowing. Insufficient cough impulse. There could be aphonic dysarthria. There could be drooped head, drooped chin, any new facial onset. Or when you do bedside PFTs, the vital capacity could be less than 1.5 liters in men and less than 1 liter in women. Now coming to the exacerbations and crisis after thymectomy. So most of the myasthenia gravis patients who have a thymoma may undergo thymectomy. So what are the precautions that has to be taken before the patient undergoes the thymectomy is, so thymectomy as myasthenia therapy should never be done as an emergency measure, but it should be performed only on stabilized patients. So what are the red flags for a post-operative myasthenic crisis post-thymectomy? One is if the vital capacity is less than 2 to 2.9 liters, if the patient is a long-term myasthenia, that is more than 6 years, if the pyridostigmine daily dose is more than 750 mg per day, if the patient has a history of a chronic pulmonary disease, if there is a pre-operative bulbar symptoms, and there is a history of myasthenic crisis, there is more than 1 liter of intraoperative blood loss, or more than 100 nanomole per liter of acetylcholine receptor antibody titer, and there is pronounced decrement at 3 Hz stimulation of more than 18%. If these are present and the patient undergoes thymectomy, then the patient might have post-operative myasthenic crisis. Now coming to the perioperative management of these patients. So typically the pyridostigmine dose should be low or moderate, that is less than 360 mg per day before thymectomy. Then anesthesia should be performed by an anesthesiologist who is experienced with myasthenia. And what are the principles that has to be kept in mind? You have to use low dose benzodiazepines during pre-medication. You avoid non-depolarizing muscle relaxants. Okay. And depolarizing relaxants like scoline are absolutely contraindicated. You have to deepen the inhalational anesthesia. And while using sedation, it should be rapidly or ultra rapidly effective narcotics should be used. And extended post-operative monitoring in the intensive care units has to be done. Now coming to the diagnosis of myasthenia gravis in general. So you do the fatigue test, you do the ice test or a sleep test, hydrophonium test, serological screening for any antibodies like ACH receptor antibodies, MuSK antibodies, and you do the EMG testing and a thyroid panel to rule out any coexisting conditions. Important is the treatment of the myasthenic crisis. So two important therapies, one is the plasma exchange or immunoadsorption therapy, and the other one is the IVIG. Both are the first choice methods. You can choose any one of these. So what are the advantages of immunoadsorption versus plasma separation are that it has a low circulatory load and elimination of need for donor plasma or human albumin in immunoadsorption technique. Treatment is usually 5 to 6 sessions, which has been shown to be effective over 10 to 12 days. That is an alternate day session. So how do you know that the Plex is effective? There will be the decreased titer of the myasthenic specific antibodies. Coming to the IVIG, so there are comparative study of Plex and IVIG, and they told that both are equally effective. But the thing is, some in individual case studies, they have showed that there is a delayed effect of IVIG up to 2 weeks, or in some case there is a negative effect of also. There is initial deterioration also. So what is the dose? It is around 0.4 gram per kg body weight on each of 5 successive days. Okay, now is there any role of cholinesterase inhibitors? So if the patient has been intubated and ventilated, there is no need for administering any pyridostigmine. If the patient is on, you can stop it. So basically, why you have to stop it? Because cholinesterase inhibitors lead to increased bronchial mucus secretion, which may lead to increased rate of pulmonary complications. However, parenteral use of pyridostigmine or neostigmine in moderate doses can be used as an auxiliary therapy in patients who are planning for weaning from the mechanical ventilation. Now, the other thing is corticosteroids. So actually corticosteroids are used just as a treatment for myasthenia gravis, but in crisis, these are not the first line response treatment. So you can start these corticosteroids in parallel to IVIG or Plex, because a positive effect can be expected 3 to 4 weeks afterwards. So you can start in parallel to IVIG or Plex. The initial dose is around 100 mg of methylprednisolone, which is administered orally or intravenously. Coming to immunosuppressants, so it is always indicated to start immunosuppressants in patients with myasthenic crisis. The approved drug is azathioprine, and if there are any contraindications, we can use alternatives like mycophenolate, rituximab, and other MABs. So this in general is the treatment of both myasthenia gravis and the myasthenic crisis. So for a myasthenia gravis patient, so you start with either pyridostigmine plus a corticosteroid, that is the prednisolone. So if the patient is not responding, then you go for azathioprine. And if any contraindications, you use mycophenolate or cyclosporine. And in drug refractory myasthenia gravis, you either use rituximab or cyclophosphamide or tacrolimus. And in case of severe weakness, exacerbations, or crisis, you give either immunoglobulins or IVIG. And if the patient has thymoma, then thymectomy is the treatment. Now, the other thing which is very important is to manage the ventilation of these patients, right? So breathing and ventilation, the parameters for bedside ventilation during myasthenic crisis is, this is a beautiful table. So normally, the vital capacity should be more than 60. The negative airway pressure should be more than 70, and the positive airway pressure should be more than 100. You have to intubate these patients when the vital capacity is less than 20. As I told, 20, 30, 40 rule is also applicable in all the neuromuscular disorders. So when to wean this patient? When the vital capacity increases to more than 15 ml per kg, the negative pressure is more than 20, and the positive airway pressure is more than 40. When do you extubate this patient? Is more than 25 ml per kg of vital capacity, more than 40 of negative airway pressure, and more than 50 pressure of positive airway pressure. So actually any mode can be selected, but pressure regulated breathing modes are actually stressed by most of the guidelines. So other important measures are respiratory toilet measures. Okay, better to do via bronchoscopy, and physical measures can be done, but due to limited coughing force, better to do with a bronchoscopy. During the weaning phase, we have to do a slow weaning. Okay, so when you have a change from the control mode to a CPAP mode, so don't keep a patient on a continuous CPAP mode. You make it like a periodic one. So you give 4 hours of a CPAP and 2 hours of a controlled mode. Okay, so it has to be in a stepwise manner. Otherwise, the patient may have a fatigue and he might fail the spontaneous breathing trial. So as with other neuromuscular disease, an early elective tracheostomy is indicated if the crisis is prolonged. NIV is discouraged during myasthenic crisis, especially the risk of aspiration is more when dysphagia is present. In cases of aspiration pneumonia, early antibiotics should be initiated after sending appropriate microbiological diagnostics. Coming to treatment of dysphagia in ICU. So dysphagia is a common among patients with bulbar disorders, especially those who are MuSK positive cases. So around 17% of patients might present with initial dysphagia symptoms, and 53% may have present in a subsequent course of the disease. So you have to assess with a FES examination, and basically because it identifies silent aspiration and may support the indication for intubation. NG feeds to be initiated and continued until the dysphagia resolves. Coming to the delirium, so these patients have high risk of going into delirium. Especially the risk factors includes high dose of pyridostigmine, prolonged ventilation, delayed use of plex or immunoadsorption techniques, and high dose administration of cortisone. The treatment includes the delirious and anxious agitated patients who are not intubated usually respond to lorazepam. Occurrence of delirium in the pre-crisis situation is an ominous sign of impending need for ventilation within the next few hours. So in the weaning phase, this delirium might make it difficult to assess the cough impulse, the breathing, the swallowing, and it might prevent reliable communication with the patient. Also, it limits the clinical progress, extending the ventilation time and stay in the intensive care unit. So we need to treat the delirium as soon as possible. So benzodiazepines and phenothiazines can be used, but they should be administered in the smallest possible doses, as these are one of the risk factors also for medication-induced myasthenia. So the best drug would be haloperidol. So experience with dexmedetomidine, because this is one of the drug which has been used as a sedative to prevent delirium. But in case of myasthenia patient, there is no sufficient evidence to recommend this therapy. Early initiation of day structuring activities, establishment of a day-night rhythm, non-drug measures, mobilization, physio and ergotherapy are the other measures to prevent delirium in these patients. Thank you. There is one more topic, delirium, and I would be discussing this topic in the last. So I request Sri Hari to continue with his CNS topics.
Okay. Is the screen visible?
Yeah, visible, Sri Hari.
No problem. Good evening to all. So today's talk will be on acute meningoencephalitis and status epilepticus from my side. So I'll be dividing meningoencephalitis into two parts. One will be acute meningitis and one will be acute encephalitis. So before I go into topic proper, meningoencephalitis was asked as a very long question in October DRNB exam. It came in paper 2. And it is also a very important long case. I had got it as one of the long cases during my practical exams at Apollo Hospital, Hyderabad. So it is very important to know about it. And also it is one among the commonest cases that are admitted in the ICU. So it is important to know about the aspects in relation to meningitis and encephalitis. So we'll go into the topic. So for acute meningitis, I'll be discussing about the introduction, the risk factors, etiology, pathophysiology, clinical features, management, complications, and role of adjuvant steroids. So coming to the introduction, meningitis is basically an inflammatory disease of the leptomeninges. Now, leptomeninges mean the inner two meningeal layers, that is the pia mater and arachnoid mater, between which the CSF circulates. And we have risk factors for acute meningitis. So the important ones are any recent infections, especially respiratory or ear infections, recent exposure to someone with meningitis, injection drug use, recent head trauma, or travel to an endemic area. And there are also host factors associated with increased risk of meningitis, like asplenia or postplenectomy, complement deficiencies, glucocorticoid excess, that is more than prednisolone intake of 5 milligrams over more than 21 days. Presence of diabetes mellitus, alcoholism, HIV infections, or hematological disorders like thalassemia or sickle cell disease, which invariably affect the splenic function. So coming to the etiology, you have bacteria. The most common in the community are Streptococcus pneumonia, which is a gram-positive cocci, Neisseria meningitis, which is a gram-negative cocci, Haemophilus influenzae, which is a gram-negative Coccobacillus, and Listeria monocytogenes, which is a gram-positive Bacillus, which is most commonly seen in patients who are age less than 1 month or more than 50 years and in an immunocompromised group of patients. And among the nosocomial groups, which is most commonly seen in neurosurgical ICUs, what we anticipate the most are Enterobacteriaceae, gram-negative bacilli, especially Klebsiella, Pseudomonas, and Staphylococcus aureus. In the nosocomial setting, it is mostly methicillin-resistant variant of Staph aureus. So, in addition to the bacterial classification, you have an aseptic meningitis group. Now, how do you define it? It is basically defined as lack of bacterial growth in cultures. That's the most simplest way to put it. So, the etiology for that is infectious. And in infectious, you have bacterial, which can be classified as partially treated bacterial meningitis, Mycobacterium tuberculosis, Leptospira, Chlamydia, Brucella, Rickettsia, and nocardial infections. Then you have viral etiologies like influenza A and B, parainfluenza, polio, enterovirus, Epstein-Barr virus, cytomegalovirus, adenovirus, rubella, HSV1 and 2, and HIV. Then you have fungal like Aspergillus, Candida, Cryptococcus, and Histoplasma. And parasitic like Toxoplasma gondii, which is most commonly associated with HIV infections with low CD4 counts, and Taenia solium, which can manifest in the form of neurocysticercosis, but it most commonly causes encephalitis, though meningitis case reports are there. And you also have non-infectious causes, which can be malignancy related like lymphomas, leukemias, or metastatic carcinomas, autoimmune like SLE, sarcoidosis, or Behçet's disease, and drug-induced like azathioprine, cotrimoxone, and NSAIDs like ibuprofen. So coming to the pathophysiology, now 4 processes are being described in relation to the pathogenesis. The first one is colonization of the respiratory, gastrointestinal, or the lower genital tract. The second one is the invasion of the bloodstream, which is the most common route in immunocompromised patients. Transdural, which can be due to surgery, trauma, that is cribriform or Peters bone fracture, or parameningeal infectious foci like sinusitis, mastocytitis, otitis, or osteomyelitis. And you have transparenchymal. There can be a brain abscess which has ruptured and it directly injects into the ventricles or the subarachnoid space. So, because of any of these 4 genesis, there can be invasion of the subarachnoid space by the meningeal pathogens. And eventually there will be multiplication of organisms and lysis of organisms by bacterial antibiotics, fungicidals, or antivirals. So that will cause a release of pathological toxins like endotoxin, teichoic acid. And there can be 4 events that can occur. One is an altered blood-brain permeability, adherence of leukocytes to cerebral capillary endothelial cells, alteration in cerebral blood flow, production of excitatory amino acids and reactive oxygen species, which can ultimately lead to cytotoxic and vasogenic edema, which leads to increase in intracranial pressure, which can lead to coma and eventual death. So this is one among the easiest way of mentioning the pathophysiology. This has been clearly made in perspective of the theoretical exams. So coming to the clinical manifestations, the commonest manifestation are fever, headache, neck stiffness, and altered sensorium. So if any of the 2 features are present, the patient is 95% likely to have meningitis. So the important thing to note is the classical triad of fever, headache, and nuchal rigidity is actually seen only in 40% of the patients. So it is not necessary to have all 3 features in patients with meningitis. If 2 of them are there itself, you can have a high suspicion and work up for meningitis. So the other findings can be decreased level of consciousness that can manifest as GCS less than 14, nausea, seizures, aphasia, cranial nerve palsies, rash, or papilledema. So for examination of meningeal irritation, there are 3 common tests. As you all know, one is the Kernick's, Brzezinski, and jolt accentuation. So for Kernick's sign, you place the patient supine with the hip flexed at 90 degrees. You place the patient supine with the hip flexed at 90 degrees, then attempt to extend the leg at the knee level. The test is positive when there is a resistance to extension at the knee level. That is more than 135 degrees, you feel that there is a resistance or there is pain that is elicited in the lower back or posterior thigh. So if any of these features turn out to be positive, that means chronic sign is positive, which can be a sign that there is meningeal irritation. The next is the Brudzinski sign. You place the patient supine and passively flex the head towards the chest. And the test is positive when there is flexion of knees and hips of the patient. That is, you flex the head towards the chest and you see that the lower limbs are being flexed in response. And jolt attenuation or headache, it's not routinely done, but it's one of the tests that have been mentioned. Patient rotates his head horizontally 2 to 3 times. The test is positive if the patient reports exacerbation of his or her headache with this maneuver. So coming to the management, so when they ask management in exam, you have to mention about the diagnosis and the treatment. So both of them have to be combined together. It does not exclusively mean that you have to mention about treatment. If you mention treatment alone, the marks that will be obtained will be less. So a patient with features suggest of meningitis, as I mentioned in the previous slide, if those features are there, you do in initial investigations, as you do for any patient who is initially admitted in the ICU. You do a complete blood count, you go over the blood urea, serum creatinine, and electrolytes. You take 2 sets of blood cultures and coagulation parameters if it is implicated. If there is underlying disease processes like underlying chronic liver disease, that you feel there is a need for it. Then assess for any of the following. That is, assess whether the patient is immunocompromised. The patient already has a history of CNS disease. Patient has a new onset seizure. Features of papilledema, altered consciousness, or focal deficits. To assess for 6 of these features in a patient who has been admitted with an acute meningitis. So if any of these features are present, you send blood cultures immediately. Start the patient on dexamethasone first and then start on empirical antibiotics and take a CT head. So once you've done all of this, you just check if there is any contraindication for a lumbar puncture. And if it is present, you continue with treatment for acute meningitis. You follow the blood cultures, but at the same time, you also consider for alternate diagnosis. You look for other factors like of any other sources of sepsis or any other causes of febrile encephalopathy. But if the 6 factors are not present, you send the cultures first, as you have planned in the initial investigations. Then you perform a lumbar puncture. Then, based on the lumbar puncture, you start on injection dexamethasone, which has to be given as 0.15 milligrams per kg every 6th hour for 4 days. And the important thing is it has to be given before the antibiotics are administered. At least 20 minutes before the antibiotics are administered, it needs to be given. The rationale for this, I will be explaining in the subsequent slide on the role of adjuvant steroids. And along with that, empirical antimicrobial therapy has to be initiated. So if the CSF is consistent with acute meningitis, the next plan of action will be you have to check whether there is a positive gram stain or gram culture sensitivity. So in gram stain, as I mentioned, if it is a gram positive cocci or gram negative cocci, either can be a streptococcus or a Neisseria. If it is a gram negative Coccolo-bacillus, it can be a Haemophilus. Or if it is a gram positive bacillus, there is a chance of Listeria which can be present. Usually the cultures do not come immediately. It will take at least 24 to 48 hours. But if it is done as a multi-top, probably within 24 hours, you will get the primary reports. Or you can also send a rapid diagnostic test like the BioFire testing, which can have a subset of organisms. Around 7 to 15 organisms will be there. Based on that, you can identify which organism is present. But if the CSF is inconsistent with an acute meningitis, that most of the parameters are within normal limits, then you consider alternate diagnosis. So if the CSF analysis have shown positivity for the presence of an infection, as I mentioned, like positive gram stain or cultures or a rapid diagnostic, if it is not there, you continue just with the empirical treatment. But if it is there, you go towards the targeted therapy. That is, from the empirical antimicrobials that are given, you can further de-escalate it to the targeted antimicrobial therapy for that specific organism. So coming to the CSF analysis, there are 4 important things to look into. One is the opening pressure, which is invariably going to be elevated in all the organism variants, that is bacterial, viral, TB, or Cryptococcus. The most important thing is to look into the WBC count and the differential count, the glucose levels, and the proteins. So on bacterial, patients are going to have a high WBC count. It will be varying between 10 to 10,000, and it is going to be neutrophilic predominant. There are conditions where it can be lymphocytic, that is in patients who are partially treated. It can be. And the glucose levels will be markedly reduced in bacterial with mild elevation in the protein levels. So this is a normal picture for a bacterial meningitis. Whereas for a viral meningitis, there will be a lymphocyte predominant leukocytosis with normal glucose levels in most of the cases, with marginal elevations in the protein levels. So this will go more in favor of viral. Whereas in TB, again, the leukocytosis will be less in comparison to viral, which will be lymphocytic. The glucose levels will be low, but there will be a marked increased levels of proteins in CSF. So if CSF proteins are markedly elevated, there should be a high index suspicion of TB. And in Cryptococcus, it is almost similar to a viral, where there will be lymphocytic predominant leukocytosis. There will be mildly reduced glucose levels with marginal elevations to marked elevations in protein levels. So other studies that can be checked in CSF are, one is the CSF lactate. So usually the cutoff that mentioned in most of the studies was 2.5 to 3.5. So if it is less than 3.5, it can be suspected as viral or fungal, that is if it is a community-acquired based infection. Whereas if it is more than 3.5, bacterial has to be kept in mind. But in nosocomial cases, if the CSF lactate is shown to be more than 4, there is a high evidence that there is a nosocomial meningitis which is present. And another utility of CSF lactate in management of meningitis is it can be used for assessing the trend of the disease, whether there is a response to your antimicrobial therapy or not, especially in neurosurgical patients. Then, as I mentioned in the previous slide, CSF PCR for rapid diagnostic testing can be done, as it can aid in targeted therapy. So it aids in antimicrobial stewardship and reduces the risk of resistance. And if TB is suspected, you will have to further proceed for TB PCR, AFP stain, and AFP cultures, and ADA. Though the utility of ADA in TB meningitis is low, as part of routine testing, it is recommended. So coming to the treatment, we have a disease-specific treatment and a general ICU treatment. What I would personally suggest is, if any case-based question is asked in the exam, I think this would be one of the best ways of writing it. You mentioned it as the general ICU management, where you mentioned about the fast track bill, but not as fast track bill. You have to elaborate it just as what each letter means, and the disease-specific management. So in relation to meningitis, in disease-specific management, we have antimicrobial therapy, seizure management, and management of raised ICP. Now, management of raised ICP has been spoken very robustly by the previous speakers, so I will not go into that. Seizure management, I will talk separately in status epilepticus. So I will concentrate mainly on antimicrobial therapy and steroids. So coming to antimicrobial therapy, empirical therapy is the mainstay. The important thing is it has to be administered via IV route only. No oral, because it will have a low bioavailability, leading to reduced CNS concentrations. So for community acquired, if the patient is between 18 to 50 years, the most common organisms you're going to anticipate is SNNH, that is Streptococcus, Neisseria, and Haemophilus. So your first line therapy is to go with the third generation cephalosporin. The most commonly used is ceftriaxone. An alternative, cefotaxime, can also be used. But the problem with cefotaxime is you need to give increased frequency of dosing, which may be cumbersome for the nursing team. You also have to give vancomycin, which is at the dose of 15 to 20 milligrams every 8th hourly to 12th hourly, with monitoring of the trough levels. That is, the therapeutic drug monitoring has to be done ideally. Looking for a maintenance in dose levels between 15 to 20 mics per ml. So it is almost equivalent to the same dose, 15 to 20. Whereas if the patient's age is more than 50 and they also have evidence of T cell deficiency, you have to add listeria also to your empirical regimen. So in that scenario, along with the third generation cephalosporin and vancomycin, you need to add ampicillin, which comes at a dose of 2 grams IV 4th hourly. And if herpes simplex is suspected, or there is being a rapid diagnostic testing showing evidence of HSV, you also have to add acyclovir, which is 10 milligrams per kg IV 8th hourly. I mentioned it only as 10 milligrams, it should be 10 milligrams per kg. And if it is a hospital acquired, as I mentioned previously, the commonest organisms you're going to anticipate are Enterobacteriaceae, Pseudomonas, and Staphylococcus. And in hospital acquired setting, already most of the patients would be exposed to prior antibiotics, which would be narrow spectrum. So they are going to develop resistance to it invariably. So in those scenarios, it is ideal to start them on a broad spectrum antimicrobials like meropenem at a higher dose. That is 2 grams IV 8th hourly with vancomycin, as you give in a community acquired case. Now, the important thing which is being commonly asked in Vivas is about beta-lactam allergy. So there were plenty of articles which are very complicated. The simplest way of explaining is, as I felt, was in this manner. So if the patient has a history of a penicillin-related allergy in the past, you start them on ceftriaxone and cefotaxime plus vancomycin. That is what we routinely put. You just continue with that. Whereas if they have had a history of a cephalosporin-related allergy in the past, instead of a third generation cephalosporin, you go ahead with meropenem. But if you had a patient who's admitted with meningitis and you will initially start them on third generation cephalosporin and he's developed a reaction to that, then you need to avoid beta-lactams as a whole. In that scenario, you need to start them on a fluoroquinolone, that is moxifloxacin, 400 milligrams every 24th hourly plus vancomycin. Why moxifloxacin is selected among the fluoroquinolones is it has a good CNS penetration. And if age is more than 50, in place of ampicillin, you need to add cotrimoxazole. So cotrimoxazole dose is calculated mainly based on the trimethoprim equivalent component, which is 5 milligrams per kg every 8th hourly. So this needs to be kept in mind. And I think this is the most simplest way of explaining it. So once you've done a gram stain or a culture, or you've done a rapid diagnostic, and you've found the organism which is present, you go for a targeted therapy. So if it is the if it is the Streptococcus pneumoniae, you continue ceftriaxone plus vancomycin. And vancomycin needs to be continued if the ceftriaxone MIC is more than 1 microgram per minute. Now, this is very important to be kept in mind because this is very commonly asked as a Viva question. Because they commonly ask, why is vancomycin continued even after the targeted organism has been isolated? So the duration is for 10 to 14 days. Whereas if it is a Neisseria or Haemophilus, you can go with just a third generation cephalosporin like ceftriaxone or cefotaxime, and the duration is just for 7 days. Whereas if it is for Listeria, they say to go with ampicillin and to add gentamicin for synergy, that is for better clearance, which is given at a dose of 1.5 milligrams per kg, given every 8th hourly. Whereas if it is TB, you have an intensive phase and a continuous phase. In the intensive phase, you have to add on 5 drugs. That is isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin. Now, streptomycin has to be given in the setting of a TB meningitis. It has been recommended by the Indian guidelines itself. Whereas in the continuous phase that needs to be given over 6 months, you can go ahead with isoniazid, rifampicin, and ethambutol. Whereas if it is Pseudomonas, you need to assess whether it is an ESBL or if it is not an ESBL. If it is an ESBL, you need to go ahead with meropenem. But if it is a multi-drug sensitive variant, you can go with either cefepime, ceftazidime, or meropenem. It is upon the discretion of the physician. And the duration goes for 21 days. Whereas if it is Enterobacterial like Klebsiella or E. coli, if there is no resistance pattern, you go with just ceftriaxone that is given as 2 grams every 12th hourly as mentioned previously. Whereas if it is nosocomial, where most commonly it is ESBL related, you have to start on meropenem. Whereas if it is a CRE bug, you need to start them on ceftazidime avibactam plus or minus astianam based on the genetic study. That is, you need to check whether it is an NDM, KPC, or an OXA variant. So based on that, you will have to decide whether you need to give astianam. Because if it is NDM, astianam needs to be added. So the duration of treatment is for 21 days. And if it is staph aureus, you need to start on oxacillin. It is not cefazolin like how we give it for bacteremia because cefazolin has poor CNS penetration. You need to give it at a dose of 2 grams every 4th hourly like how we do for ampicillin. And if it is MRSA, you need to continue with vancomycin and the duration as for this is also around 14 to 21 days. So this is about the commonest organisms that are found in cases of acute meningitis and the doses and the duration. Whereas in fungal meningitis, which is very rare, seen more in immunocompromised cases, you go with Candida, whether if it is Candida, Cryptococcus, or histoplasmosis, you go with liposomal amphotericin B plus flucytosine, and the duration of therapy is around 2 weeks. Whereas if it is leptospirosis, you go with doxycycline or ceftriaxone, doxycycline around 100 milligrams 12th hourly, and again the duration is around 7 to 14 days. Whereas if it is chlamydia rickettsial species, that is scrub typhus, you go exclusively only with doxycycline. The duration is as before. And if it is aspergillus related, you need to start them on voriconazole, which is 6 milligram per kg into 2 doses on day 1. Following that, we go with 4 milligram per kg every 12th hourly. And IV administration can be changed over to oral after 7 days to avoid the risk of nephrotoxicity because the IV medications are usually having a capsular chain, which is supposed to be nephrotoxic. So the duration again is for 4 to 6 weeks. So we have started on targeted therapy and we are assessing the response. Now, when do we need to go ahead with a repeat CSF analysis? Now, it is indicated in the following circumstances. One, there is no improvement even after 48 hours of initiation of therapy. Indication 1. When there is persistent fever more than 8 days without any other explanation. That is, patient is in ICU, look for both other infectious and non-infectious causes, and still you are not able to remove a specific diagnosis, then becomes an indication to assess for repeat CSF analysis. And in patients with a drug-resistant organism, you want to assess the trend of the disease after 72 hours. In those kind of scenarios, a repeat CSF analysis is indicated. So the indication for intrathecal antibiotics for community-acquired meningitis, definitely no. There are not any proven evidence for that. But in nosocomial meningitis, it is yes. Because in nosocomial, most common organisms that can be present are either Acinetobacter or Pseudomonas. So in those set of organisms, in addition to parenteral antimicrobial therapy, you can go for intrathecal antibiotics. So the drugs that can be given are colistin, polymyxin B, gentamicin, tobramycin, and amikacin. So the complications that can occur as a result of meningitis are seizures, focal neurological deficits, sensory neural hearing loss, hydrocephalus, especially with TB meningitis, increased ICP, brain abscess, and ventriculitis. Now, the important thing to note is seizures, focal neurological deficits, and sensory neural hearing loss can be decreased with the use of steroids. But the important thing is it has to be administered at least 20 to 30 minutes prior to administration of your antibiotics. So now role of steroids in acute meningitis, the main rationale for its use. It's very, very important, very, very commonly asked in practice. The release of bacterial cell wall components by bactericidal antibiotics leads to the production of inflammatory cytokines, interleukin-1 beta and TNF alpha in the subarachnoid space. Now, dexamethasone exerts its beneficial effect by inhibiting the synthesis of these cytokines at the level of mRNA thereby decreasing the CSF outflow resistance and stabilizing the blood-brain barrier, which can deteriorate in the presence of inflammation. So the rationale for giving dexamethasone 20 minutes before antibiotic therapy is that dexamethasone inhibits the production of TNF alpha and interleukin 1 beta by macrophages and microglia only if it is administered before these cells are activated by the endotoxin. And dexamethasone does not alter TNF alpha production once it has been induced. So this is very, very important point to be noted. So the results of clinical trials of dexamethasone therapy in meningitis due to Haemophilus, Streptococcus, and Neisseria have demonstrated its efficacy in decreasing meningeal inflammation and neurological sequelae as the incidence of sensorineural hearing loss. So there has been a Cochrane study, and that's based on systemic reviews on steroids for acute bacterial meningitis. And the key results, it's kind of too much of content, but I'll make it as simple. They have told only for Streptococcus there is a mortality benefit. Whereas in Haemophilus, Neisseria, and in Streptococcus, there has been a good response to the reduced incidence of sensory neural complications. That is, like hearing loss and other neurological sequelae have been reduced with the use of steroids in these organisms subset. So that needs to be kept in mind. But in patients who have developed a Haemophilus meningitis or a Neisseria meningitis, administration of steroids does not have any effect on the mortality. In TB meningitis, the dosing is different from that which is given for other bacterial meningitis, especially Streptococcus, Neisseria, or Haemophilus, where they give 0.15 milligram per kg every 6 days for 4 days, whereas in TB meningitis, you have a different regimen where they give 0.3 to 0.4 milligram per kg per day for 2 weeks, taper it by 0.2 milligram per kg per day for 1 week, then again taper it to 0.1 milligram per kg for 1 week, and then every week 1 milligram of dexamethasone is tapered for the subsequent 6 weeks, and after 6 weeks, you taper it for oral prednisolone, which needs to be continued for 2 to 4 months. But the problem in resource-limited settings, especially in Africa and East Asian countries, is the role of adjuvant steroids is highly controversial because majority of the studies over there are not shown to be beneficial. Because one is because they have a significant delay in clinical presentation because of poor nutrition status and presence of underlying HIV infections. Thank you. So this is about the meningitis part. So next I'll go into the encephalitis. So now coming to acute encephalitis, it was asked along with meningitis as a case, as a question like acute meningoencephalitis causes and management in the last year's theory exam, that is October 2023. And it's also important to know about the management because in Kerala, from around June to August, there were frequent outbreaks of amoebic encephalitis, and in the previous year, there were also Nipah encephalitis outbreaks. So it is very important to know about how you approach a patient and what are the treatment modalities that are available for this. So for encephalitis, I'll be discussing on the introduction, etiology, clinical manifestations, infectious encephalitis, and immune-mediated encephalitis. So introduction. Encephalitis is basically inflammation of the brain parenchyma accompanied by neurological dysfunction, whereas meningitis was the inflammation of the leptomeninges. The thing with encephalitis, it has a wide variety of manifestations. Whereas when meningitis we had seen fever, neck stiffness, then probable altered sensorium can be that. And these were the predominant symptoms. Whereas some of the features of encephalitis can also be present in meningitis. So how can you differentiate meningitis and encephalitis? The presence or absence of normal brain function is the main important distinguishing feature between meningitis and encephalitis. Patients with meningitis may be uncomfortable, lethargic, or distracted by headache, but their cerebral functions remain normal. It is in most of the cases. But however, the distinction between both is often difficult, and since both patients have both meningeal and parenchymal process that infection or inflammatory process that occurs, which is called as meningoencephalitis. So this is the main reason why it is difficult to differentiate meningitis and encephalitis, because invariably most patients will have a process whereby both meninges and the parenchyma will be involved. So coming to the etiology, you have an infectious cause, you have a non-infectious cause, and you have an unknown etiology. Under infectious, in bacterial, you have TB, Listeria, Toxella, Mycoplasma, rickettsial species, like scrub typhus and leptospira. Under protozoal, you have Plasmodium falciparum, Naegleria fowleri, and Acanthamoeba. In fungal, you have Cryptococcus and Histoplasma. And viral is the commonest cause of infectious encephalitis. So under that, we have herpeviridae organisms which can cause like HSV1-2, varicella zoster, Epstein-Barr virus, cytomegalovirus, and HHV6. It is human herpes virus 6. Then you have respiratory viruses like influenza and adenovirus. Then you have enteroviruses like enterovirus, Coxsackie A and B, echovirus, and poliovirus. Then you have arbovirus groups like Japanese encephalitis, dengue, West Nile, and Zika, and others like rabies, mumps, measles, and Nipah. And these measles and Nipah come under the same group, or that are paramyxoviruses. Whereas in non-infectious causes, you have autoimmune, paraneoplastic, and post-infectious etiologies. So the clinical manifestations in most patients of encephalitis, there will be an underlying acute febrile illness. That is, they will have fever as one of the main symptoms. Along with that, they have an altered level of consciousness, which can manifest as confusions or behavioral abnormalities, or a depressed level of consciousness, that is mild lethargy to coma. So there can be a wide variation in the GCS in many of the patients who present with encephalitis. And along with this, there can also be involvement of the hypothalamic pituitary axis, which can manifest as temperature dysregulation, which can be where the patient can have either hypothermia or hyperthermia. Both manifestations can be present, and there can also be diabetes insipidus or SADH. And in addition to this, there can be seizures which can be focal or generalized. And there can also be focal neurological deficits in the form of aphasia, ataxia, upper or lower motor neuron pattern of weakness, involuntary movements, especially the extrapyramidal symptoms, extrapyramidal pathways is involved, and cranial nerve defects. And along with that, psychosis can be present in the form of hallucinations or agitation. So first we will talk about the infectious encephalitis management. So the diagnostic evaluation is as follows. So first is about the history and examination. The importance is you need to focus on the social history, travel history, history of exposure to muddy lands, whereby the risk of leptospirosis is high, like in agricultural areas, especially in rainy seasons, and exposure to animals and insects. So all these need to be noted. And along with that, on examination, you need to look for presence of rash in a dermatomal pattern, to look for any varicella zoster, any presence of parotitis in unvaccinated patients like from mumps, presence of hydrophobia or aerophobia as in rabies, or presence of an SR as in scrub typhus. But the important thing to note is SR may be present only in about 50% patients, 50 to 90%. There is a wide variation, but it is not present in all cases. So that needs to be kept in mind. And the initial labs that needs to be done is to look for the complete blood count, the renal function tests like blood urea, creatinine, and electrolytes, liver function tests. 2 sets of blood cultures need to be sent, anticoagulation studies is implicated, and abdominal imaging. You need to assess for hepatomegaly, splenomegaly, or both. So why it needs to be done is most of the viral infections will have an associated splenomegaly also, especially in like Epstein-Barr virus, cytomegaloviruses. So that may aid in further workup. The next is neuroimaging. In encephalitis cases, the ideal imaging of choice is to go with MRI, but initially when a patient comes to us to the ICU, we don't want to go directly to an MRI. We preferably like to have a CT to rule out other conditions, other common conditions before going into encephalitis workup. So the advantage of CT helps to rule out space occupying lesions. Whereas in MRI, you can assess for demyelination also, that is in patients with ADAM. You can consider this as a good modality. There can be specific lesions that may be present on MRI. Like example, in temporal lobe involvement is very commonly seen associated with herpes viridae group of viruses, like HSV, Varicella zoster, EBV, or HHV6. The importance of this point is we might have read up previously that HSV is associated with temporal lobe. The important thing, it is not HSV alone, which is the herpes viridae group, which can be associated with temporal lobe involvement. Then there can be involvement of the thalamus and basal ganglia in respiratory viral infections, TB or arboviruses. Now, usually dengue and Japanese encephalitis infections usually have a high association with the involvement of the basal ganglia, especially in dengue, which manifests as expanded dengue syndrome. In those kind of cases, these kind of manifestations can be there. And if hydrocephalus is there, it goes more for a non-viral etiology, most likely associated with tuberculosis. So the next thing is to look for an EEG. So in EEG, it is very often abnormal in acute encephalitis patients. And acute encephalitis is one of the commonest causes of new onset refractory status epilepticus, that is NOS. So the specific findings will be, there will be PLEDS, that is lateralized periodic epileptiform discharges, that is most commonly associated with HSV1. Sorry. I have not put any pictures based on this, but I personally recommend to have a look on it, because in OSCE stations in the afternoon, usually it can be kept as one of the questions. So once you go on with the history examination, you've done the basic investigations, you've done neuroimaging, and you've done an EEG. It is also important to go for a CSF analysis also. Usually examination of CSF will help in confirmation of inflammatory diseases of CNS, but it is difficult to differentiate between aseptic meningitis and encephalitis. For etiological assessment, the CSF PCR is usually done. It helps in aiding in diagnosis, like a biofire panel can be done, which will help in identification of the organism. Whether the utility of CSF cultures, if no antibiotics have been administered, then positivity can be seen in 70 to 80% patients. And the sensitivity pattern aids in antimicrobial stewardship. But the problem with viral culture is it takes too long for results. So you can't wait for the patient's condition like to initiate antivirals based on the viral cultures, because it's going to take a long time and may affect the patient's course of disease. And only 6% cases have actually showed positivity. So in routine practice, CSF cultures for diagnosis of viral infections is not routinely recommended. And in cases of arbovirus or leptospira or scrub infections, scrub typhus infections, usually they prefer to go with serology. That is assessment for IgM. And in those whom multiplex PCR has not shown any organisms, usually most of the multiplex PCR have a certain subset of organisms for which they are tested. So if at all it is not there, and the PCR studies for those specific viruses like dengue, Japanese encephalitis, or leptospira is not there, then I think we can go for IgM. It is also mentioned as one of the investigational modalities. But the only thing with the IgM studies is once the infection is started, it takes at least 4 to 7 days for the IgM antibodies to be produced into the circulation. So we'll have to wait for that period before testing. Otherwise, invariably, it will turn out to be negative. So that was one thing that needs to be put in mind. And other than CSF, PCR, or serology, It also needs to be looked at, serology needs to be looked in other sites also, like in throat, urine, and blood, in addition to CSF analysis, especially in conditions like Nipah. So that has come as one of the investigation modalities that have come up in the Kerala guidelines also. So the role of brain biopsy, it is mainly reserved for patients in whom CSF, PCR, and serological testing for both infectious and immune-mediated encephalitis fail to detect them in etiology. That is one of the most important indications. Plus, there is presence of focal abnormalities on MRI and presence of clinical deterioration is present. If 3 of these criteria are met alone, the brain biopsy can be considered. So coming to the treatment, the important part of treatment is for monitoring, that is neuromonitoring, hemodynamic monitoring, and respiratory monitoring, then general management and specific management. So under specific management, you have antimicrobial therapy, seizure management, and raised ICP management. And under microbial therapy for viral, that is, if it is varicella zoster or HSV, you can go with acyclovir therapy. If it is cytomegalovirus, you have to go with ganciclovir plus foscarnet therapy. The goal of therapy is to continue treatment till the CMV DNA is found to be negative. And if it is HHV6, usually antivirals are not very effective, but ganciclovir can be tried in the subset of patients. In influenza, oseltamivir 75 milligrams 12th hourly can be given. If it is measles, ID ribavirin can be considered at a dose of 15 to 25 milligrams per kg in 3 divided doses. Whereas if it is Nipah, you go with 2 grams of stat, 2 grams stat of ribavirin, then you give 1 gram every 6th hourly for 4 days and 500 milligrams every 6th hourly for the next 5 days. So it goes for a period of 10 days. So ribavirin is currently available in oral tablet formulation in most of the states in India. So in Nipah, they recommend it to be given as in via enteral route. And for EBV and other viruses, there are no specific treatment. So that needs to be kept in mind. So for bacterial, as we already have seen in meningitis, for rickettsial, you go with the doxycycline. And if it is mycoplasma, you can either go for azithromycin as a 500 OD or doxycycline. And if it is TB, you go with ATT, the dosing you had mentioned in the meningitis PPT. Whereas if it is fungal, you see if it is cryptococcal or histoplasma. If it is cryptococcal, you go with the liposomal amphotericin B plus flucytosine. Whereas if it is histoplasma, you manage with liposomal amphotericin alone. Whereas if it is protozoal, if it is Plasmodium falciparum, you go with artesunate, that is at a dose of 2.4 to 2.5 milligrams per kg at 0, 12, and 24 hours. Following that, you give it for every 24 hours for 7 days. For tinea solia, that is neurocystic sarcosis, you go with albendazole, praziquantel, and dexamethasone. And if it is acanthamoeba, you manage it with pentamidine plus fluconazole plus miltefosine plus or minus metronidazole. I mentioned specifically acanthamoeba because there have been a lot of outbreaks of amoebic encephalitis in Kerala. So just for completion purposes, I have mentioned it as one of the treatment modalities. So we have covered infectious, but we need to know what's the differences between infectious and post-infectious encephalitis. So for infectious, the primary infection is characterized by invasion of the CNS that we already know. The neuronal involvement can often be identified on histological examination, though it is not commonly done. And it can be cultured from the brain tissue, that is via an histological exam. Whereas in post-infectious, the organism cannot be detected or recovered. That is especially in cases of disseminated encephalomyelitis, that is post-infectious myelitis. In these scenarios, if at all there is a biopsy done, there will be perivascular inflammation and demyelination. The demyelination can also be seen on MRI. The important thing to note is it is an immune-mediated entity. So the next thing is about autoimmune encephalitis. We would have heard about this term very frequently, but many articles in relation to this have given a very complex diagnostic workup and treatment. So I may to understand that we need to know something about the pathophysiology. So I just emphasized on that. So the pathophysiology part consists of the neuronal antibodies are produced in response to antigens released by viruses, vaccines, tumor cells, or unknown mechanisms. The immune-mediated encephalitis-associated neuronal antibodies can be roughly divided into two categories. One is the antibodies targeting the cell surface or the synaptic antigens, which can be AMPA or GABA B receptors. The next one can be antibodies targeting intracellular antigens that can be within the cell, that is like nuclei, ribosomes, Golgi apparatus, etc. And the most common antigens that are associated are the WHO, MA2, and the GAD antibodies. So the pathogenic effects can manifest as functional blockade of the receptor function, that is GABA receptors, cross-link and internalization of receptors, that is, the internalization means that is from the cell surface, that is the plasma membrane, the receptors that are present move into the cell, that is, they get attached to the Golgi apparatus or to the nuclear membrane. So because of that, the density of receptors that are available on the plasma membrane reduces, and because of it, the efficacy of neural function comes down. And along with this, there can be interference with protein-protein interactions impairing neuronal function. So for diagnostic evaluation, the ideal way to go ahead is with neuroimaging. The MRI is the ideal modality. You go the EEG assessment, lumbar puncture, and serological markers. So for diagnostic criteria, all three must be present. That is subacute onset, that is rapid progression of less than 3 months of memory loss, altered mental status, and psychiatric symptoms. Plus one of the following, that is new onset CNS findings, focal deficits, seizures not explained by previous disorder, CSF pleocytosis, and MRI suggestive of encephalitis. And other causes, that is alternate causes of encephalopathy or encephalitis must be ruled out. So the types of autoimmune encephalitis are limbic, ADAM, anti-NMDA, Bickerstaff, and Hashimoto's. So if you know these five, then you can assess how you can assess for these conditions and come to a diagnosis. So the diagnostic criteria for possible autoimmune encephalitis is met, is what we need to check. So as I mentioned, the diagnostic criteria, all three must be present. So for limbic encephalitis, in addition to this diagnostic criteria, you have to assess for any flare restriction in the medial temporal lobe. So that is where you have a suspicion of herpes viridae infections also. So if at all the criteria for limbic encephalitis is met, there is a probable autoimmune disease that is present. So then you assess for antibodies. So limbic encephalitis is most commonly associated with oncological disorders. So this you assess for WHO, MAR2 or GAD antibodies that are antibodies against intracellular antigens. The significance is it comes in the treatment part. And you assess for AMPA and GABA that are antibodies against synaptic receptors. So if any of these antibodies turn out positive, that is on your CSF autoimmune panel, then there is definitive autoimmune encephalitis. Whereas if it is not there, then you need to go with more research-based testing, which is now not in the active phase, at least in India. So if limbic encephalitis is ruled out, you next need to look for ADAM. So the important thing for ADAM is the patient should have had a previous infective or an inflammatory disorder. And after that, there is a multifocal clinical CNS event with inflammatory demyelinating cause. So that is very important to be kept in mind. And there will be encephalopathy that cannot be explained by fever alone. And in MRA, there will be no new clinical or MRA findings after 3 months of symptom onset. That is 3 months at the maximum. So one is the patient's condition, patient had a previous infection, after which these features had occurred. Encephalopathy cannot be explained by fever alone, and MRA shows no new findings. So if all three features satisfy, you do an MRA and there is features of demyelination, there is a possibility of an autoimmune process. then you need to assess for antibodies for aquaporin 4 and myelin oligodendrocyte glycoprotein, that is MOG. So if it is present, there is a definitive autoimmune encephalitis. So there is no improvement on MRI in the subsequent imaging, then we will have to reconsider the diagnosis. So if both limbic and ADAM is not satisfied or the criteria is not met, you need to check for NMDA encephalitis. So for that, if the criteria is met, that is the criteria for autoimmune encephalitis that was there in the previous slide is met, then there is a probable autoimmune. Then you check for NMDA receptor antibody. If it is present, yes, there is a definite encephalitis. Whereas if 3 of the disease criteria is not met, then you need to check for Bickerstaff. That is one of the variants of your GBS. That is, there will be presence of decreased level of consciousness, bilateral external ophthalmoplegia, and ataxia. All 3 should be present and other conditions should be ruled out. So if at all it is there, it is probable that an autoimmune process is there. You need to check for a GQ1B antibody. If it is present, there is a definitive Bickerstaff encephalitis. Whereas if that is also not met, then you have to check for thyroid antibodies, that is antithyroid peroxidase or thyroglobulin antibodies. If it is present, you need to assess for Hashimoto's encephalopathy. That should be 6 criteria: encephalopathy, thyroid disease, normal MRI, presence of thyroid antibodies in serum, absence of other neuronal antibodies, that is CSF autoimmune panel is negative, and other causes should be ruled out. If it is yes, there is a probable autoimmune process that can be related to Hashimoto's. Whereas if it is not that, then you need to assess for autoantibody negative but probable encephalitis. So I'm not going into this. This is little complicated at this point of time, but I think when you read through the slides, I think you can look into this because there's already too much content that I had spoken about in the previous slides. So if this autoantibody negative but probable encephalitis is negative, then you need to reconsider the diagnosis. So you had 5 conditions that you need to check: limbic, NMDA, ADAM, then Bickerstaff, and Hashimoto's. If at all you have suspected for limbic, then a full body CT needs to be assessed for presence of tumors. If it is not detected but there is a high suspicion, then you need to go with a PET scan. So the treatment mainly is immunotherapy and plus or minus removal of any underlying tumor like testicular tumor or ovarian teratoma resection. So the mainstay is to go with IV methylprednisolone 1 gram daily for 5 to 7 days and slowly taper it. And you'll also have to consider plasma exchange over 5 to 7 days. So ASFA guidelines has definitely shown its use in weak voltage-gated potassium channel encephalitis, Hashimoto's, NMDA, MOG, that's neuromyelitis optica spectrum, that is MOG antibody positive related to ADAM, paraneoplastic encephalitis, or ADAM per se itself. So after giving therapeutic plasma exchange, if the patient does not improve, then IVIG can be given as a other modality. So it can be given at a dose of 2 grams per kg in 5 divided doses, and it can be used after plasma exchange if the persistent of symptoms. The important thing is it should not be used concomitantly with therapeutic plasma exchange because there will be removal of IgG antibodies in plasma exchange. And if there is no improvement in 7 to 10 days, you need to go with rituximab therapy. Now, rituximab therapy is preferred in patients in whom you are targeting antibodies against the cell surface antigens or synaptic antigens that I mentioned previously. And cyclophosphamide for intracellular antigens like MAG or GAD. So once clinical stability has been achieved, therapy can be stopped in most patients. However, in 20 to 25 cases, relapse can occur with the need for longer duration of immunosuppression. So the last topic will be on status epilepticus. So status epilepticus is very important because there has been a lot of questions that have been asked in the FNB exams related to status epilepticus management. It was asked in FAT 2020 and in practicals in relation to any case, whether it is short case or long case, they will definitely go into status epilepticus management, at least the basics of it. So the important things I want to emphasize is on the definitions here. So seizure is a sudden change in behavior caused by electrical hypersynchronization of neural networks in the cerebral cortex. Epilepsy is defined when the following exist. That is, there is at least 2 unprovoked seizures occurring more than 24 hours apart, diagnosis of an epilepsy syndrome, or 1 unprovoked seizure plus probability of further seizures similar to the general recurrence rate occurring over the next 10 years. So this is the main definition for an epilepsy. Status epilepticus is defined as per the Neurocritical Care Society, 5 or more minutes of continuous seizures or 2 or more discrete seizures between which there is incomplete recovery of consciousness. And International League Against Epilepsy definition has T1 and T2 definitions. So T1 is the time at which ongoing seizure activity should be regarded as abnormally long and unlikely to stop spontaneously. So that is the time when treatment for status epilepticus should be started. For tonic-clonic status epilepticus is 5 minutes, and for NCSE is 10 to 15 minutes. And T2 is a time after which ongoing seizure activity poses a significant risk of long-term complications. For tonic-clonic, it is 30 minutes, and non-convulsive, it is unknown. So refractory status epilepticus is either clinical or EEG seizures that process after adequate dosing of initial benzodiazepine plus a second-line anti-seizure drug, irrespective of time. That is very important. And malignant or super refractory status epilepticus is that which passes despite 24 hours of treatment with an intravenous anesthetic plus recurs with weaning of the anti-epileptic drug. And prolonged refractory status epilepticus is that which persists for 7 days despite appropriate management, but without use of anesthetic agents. So that is the point, that is the catch that needs to be noted. And prolonged super refractory status epilepticus is that which persists for at least 7 days with ongoing need for IV anesthetic medications. So classification is generalized convulsive status epilepticus, simple partial status epilepticus, and non-convulsive status epilepticus. So the difference between generalized and simple is about the consciousness, where in generalized convulsive, the patient does not regain consciousness, but in simple partial, there will be preservation of consciousness. And myoclonic SC usually comes under the classification of generalized convulsive status epilepticus. So etiology, there are 12 etiologies that are identified. One is low anti-epileptic drug levels, that is because of poor compliance or concomitant enzyme-induced intake. Metabolic, that can be because of hypoglycemia, hyponatremia, or hypercalcemia. CNS tumors, thrombotic microangiopathies, traumatic brain injury, toxins like cocaine or amphetamines, withdrawal states due to alcohol, opioid, or benzodiazepines, stroke, that can be ischemic or hemorrhagic, CNS infections manifesting as meningoencephalitis, which I discussed previously, drugs like tramadol, imipenem, cilastin, tranexamic acid, or fluoroquinolones, fever, especially in children, hypoxic or anoxic brain injury, eclampsia. So pathophysiology, because of the etiological trigger, seizures occur. The GABA receptor apoptosis occurs within minutes of onset, and there will be eventual loss of GABA receptors on the neuronal surface, thereby causing an imbalance between inhibitory and excitatory neurotransmitters, leading to increased glutamate and NMDA levels, leading to neuronal death. So when the seizure occurs less than 30 minutes, it is a compensated phase where there will be catecholamine overactivity and hyperglycemia. Once it goes more than 30 minutes, it becomes a decompensated phase where there will be failure of autoregulation. Eventual risk of rhabdomyolysis goes up, ventilator dysfunction occurs, and hypoglycemia can occur. The important thing about this slide is there are scoring systems in relation to status epilepticus. There are 2 important scores. One is the test score or the status epilepticus severity score, which has 4 parameters: the level of consciousness, the type of status epilepticus, age, and past history of seizures. So if the score is 0 to 2, it has favorable outcomes. If it is 3 to 6, it has unfavorable outcomes. Whereas the next one is the epidemiology-based mortality score in status epilepticus, whereby the variables are etiology, age, comorbidities, and EEG. So coming to the management, you first assess and protect the airway in the event of a seizure event. You monitor the vitals, that is the oxygenation, ECG, and BP, check the blood glucose, ABG, and obtain IV access through peripheral lines preferably in the initial phase. So if hypoglycemia is present, you give thiamine 100 milligrams IV first, and then give 25% dextrose of 100 ml, or if 50% dextrose is there, 50 ml has to be given. Then you give injection IV lorazepam 0.1 milligram per kg to a that is maximum dose of 4 milligrams, slow IV push at the rate of 2 milligrams per minute. Alternate medications that can be used are midazolam and diazepam. Then after this seizures is initially managed, you have to send for basic blood investigations like complete blood count, RFT, LFT, toxicology if applicable, and anti-seizure drug levels if previously on therapy. If the seizure does not stop in 5 minutes, then you can consider it as an initial status epilepticus. So then you can repeat another dose of IV lorazepam of 4 milligrams slow IV push and see. So if the seizure does not stop in 5 to 10 minutes after you've given that also, then there is an established status epilepticus. So then you have to investigate the underlying etiology with neuroimaging, that is either CT or MRI, that once the seizure is controlled, manage any metabolic imbalances or hypertension. If there is no return of consciousness, EEG has to be initiated at that point itself to look for NCSE. So the first line drugs that can be used are fosphenytoin, that is given at a dose of 30 milligram per kg or 20 milligram per kg phenytoin equivalents to a maximum rate at 150 milligrams per minute. So it is contraindicated if the patient already has an AV block or the patient is in severe hypertension, because it can exacerbate both of them. And the maintenance dosage is 450 milligrams per day. That is usually given as 150 milligrams every 8 hourly. Or phenytoin can be given. The dose of 20 milligrams per kg, but the rate of infusion has to be much lower, that is 50 milligrams per minute. And the maintenance is 300 milligrams per day in 3 divided doses. The important thing is to note that if it is given very fast or there is extravasation, there is a condition called purple glove syndrome which can occur. That can be extravasation and eventual ischemia of the limb which can occur. Sodium valproate is another drug that can be considered, that is dose of 30 to 40 milligrams per kg, that is maximum of 3 grams, and maintenance of 10 to 15, that is 15 milligram per kg per day in 3 to 4 divided doses. Or levetiracetam can be given, that is at a dose of 60 milligram per kg, that is maximum of 4.5 grams, that is as a loading dose. Whereas the maintenance dose can be given at a range of 50 to 1.5 grams IV 12th hourly. So one of these 4 drugs can be used as the first line drugs, most preferably levetiracetam or fosphenytoin are used. Sodium valproate is not considered because of a high side effect profile and high interactions with other medications. So if at all the seizures persist even after administration of these drugs, then second line drugs like lacosamide, that is a dose of 200 to 400 milligrams can be given, and or phenobarbital can be given. Previously, phenobarbital was considered as an IV anesthetic agent, but now it is considered as a second line drug itself from the latest guidelines. So it can be given at the dose of 10 to 50 milligrams per kg and kept at a maintenance of 1 to 3 milligram per kg per hour. So if seizures persist for 30 minutes from the first seizure, that is failure of initial treatment, it is referred to as refractory status epilepticus. So at this point, the patient needs to be intubated if it is not yet done. The patient's hypothermia needs to be treated. Continuous EEG monitoring is a must, and with the goal of seizure suppression and new onset refractory status epilepticus workup has to be done. The components of it I will discuss subsequently. And the drugs that are to be used in this scenario are midazolam, propofol, and or thiopentol. Any one of these 3 drugs can be used. The important consideration is hypotension is anticipated with all of the 3 agents. So a low dose vasopressor agent can also be initiated if needed. So if the seizure stops, you go ahead with neuroimaging, preferably MRI. Then you also continue with continuous EEG monitoring, CSF analysis if there is no contraindication, and workup for new onset refractory status epilepticus. The indications for continuous EEG monitoring are if recent clinical seizure or status epilepticus without return to baseline for baseline consciousness more than 10 minutes, presence of coma, especially in post-cardiac arrest scenario, or epileptiform activity or periodic discharges on the initial 30-minute ECG, suspected NCC in patients with altered mental status and patients with intracranial hemorrhage. So the endpoints is cessation of NCSC, diffuse beta activity, burst suppression of 8 to 20 seconds interval, or complete suppression of EEG, especially with use of especially use of anesthetic agents. But if the seizure persists for 24 hours, it comes under the definition of super refractory status epilepticus. So the management goes as, you can go with injection ketamine. You can go ahead with induced hypothermia, especially in post-cardiac arrest seizures. That is keeping at a temperature of 32 to 35 degrees Celsius. But there are newer trials in relation to this, but we will discuss about that later. Or alternative anti-seizure medications like topiramate, perampanel, or pregabalin can be given. Inhalational anesthetic agents like sevoflurane or isoflurane can be considered. If the etiology is autoimmune, then we'll have to go with immunomodulation. That is how we had mentioned when autoimmune encephalitis. The first line is to go with IV methylprednisolone as pulse steroids, 1 gram over 3 to 5 days, then taper it to 1 milligram per kg per day. Then either go for plasma exchange or IVIG. Then second line therapy, you can go with rituximab or cyclosporin. Anankira, that is a interleukin 1 antagonist, or tocilizumab, interleukin 6 antagonist can be tried. Then neurosurgery or neurostimulation, that is resection of a well-localized seizure onset zone, vagal nerve stimulation, electroconvulsive therapy, or deep brain stimulation can be tried. And ketogenic tried. The important thing I want to emphasize in this slide is all therapies that have been mentioned for a super refractory status epilepticus are only based on case series and case reports. There has not been any randomized control trials in relation to this. So ketogenic diet is likely to be a short note which can be asked because it is having a lot of implications currently, and it is very commonly asked in vivas also. So I just wanted to put a slide on this. So the mechanism of action is a ketogenic diet is a high-fat, low-carb, normal protein diet. Ketone bodies created in the liver from long and medium-chain fatty acids are directly anticonvulsant when crossing the blood-brain barrier. So ketogenic diet is associated with increased mitochondrial biogenesis, oxidative phosphorylation, enhanced GABA levels, reduced neuronal excitability and firing, and stabilized synaptic function. But it is contraindicated in patients with the inability to initiate enteral nutrition, concurrent use of propofol, whereby it increases the risk of propofol-related infusion syndrome, porphyria, and congenital fatty acid enzyme deficiencies. That is most in the pediatric populations. So the composition is the classical ketogenic diet. So what they do is the dietitians match the calories to the pre-ketogenic diet baseline. It consists of 4 parts of fat to 1 part of protein and carbohydrates. That is 4:1 ratio. So fat comes primarily from the long chain triglycerides obtained through the standard foods, and protein intake is based on that required for growth. This is also calculated based on the pediatrics, this specific point. The important thing is you need to supplement trace elements, especially like selenium, chromium, and also other vitamins like multivitamins B and C. There are other modifications to this classical ketogenic diet, like the modified Atkins diet or modified ketogenic diet. Like instead of 4:1 ratio, 3:1 is used for better tolerability. So the duration is between 2 to 3 months, and the discontinuation should be gradual. That is decreasing the ratio of fat to protein and carbs from 4:1 to 3:1 to 2:1 to 1:1, then change over to the normal diet. So the side effects are predominantly gastrointestinal, where they can manifest with nausea, vomiting, diarrhea, constipation, which are all managed symptomatically, but discontinuation should not be done. The other complications are dyslipidemia, which is usually mild, hypoglycemia, metabolic acidosis, hyponatremia, and hypomagnesemia. So coming to the workup for NORS, so important, you need to look at the metabolic factors like serum LDH, serum ammonia, vitamin B12 levels, and mitochondrial diseases. That is, you have to assess for the CSF lactate pyruvate ratio. Next, you have to assess for neoplasms, that is cancer biomarkers, CT, chest, abdomen, pelvis, and CSF cytology. Then autoimmune, serum autoimmune, you have to assess ANA, ANCA, anti-TPO, ESR, CRP, and SLE antibodies. And in CSF, you have an autoimmune panel, which will consist of NMDA, AMPA, VGKC, GPQ1B, that is for beta stuff. MOG is for MOG is for ADAM variants, or aquaporin 4 is also for ADAM variants. And infectious, that is blood cultures, viral serology, CSF analysis, and CSF PCR, that is for meningoencephalitis. So the important thing is, in patients who present with status epilepticus, you'll have multiple complications you need to anticipate. From cerebral perspective, there is likely to be cytotoxic edema or cortical necrosis, which is associated with poor outcomes. Cardiovascular, they can manifest with stress cardiomyopathy, cardiac arrhythmias, or cardiac troponin elevation. From respiratory, that can be atelectasis, because patients will be invariably sedated and paralyzed. So that because of mucus plugging, that can be atelectasis. Increased risk of ventilator-associated pneumonia, neurogenic pulmonary edema. From skeletal perspective, there can be skull fractures, clavicular fractures, or shoulder dislocations, especially if the falls occur because of the seizures. Neuromuscular, there can be rhabdomyolysis, and because of prolonged sedation and paralysis, there can be ICU-acquired weakness. Gastrointestinal, because of invariably use of broad spectrums in suspicion of infectious etiology, there is going to be an increased risk of C. difficile colitis. And infections, because of various invasive lines, there can be risk of CRBSA or RT. Because of an immobile state, the risk of DVT and pulmonary embolism also goes up. And drug-related complications like pancytopenia attributable to valproate or levetiracetam can be there. Propofol-related risk can be there. Polyethylene glycol toxicity, especially associated with lorazepam, can be there. Thank you. So I think this has covered most of the topics. So I'll hand over to Niharika madam for the last topic.
Thank you, Srihari. So, able to see my slides?
Yes, bro.
Okay. We are so sorry. I think after this 6 hours of continuous lectures, I think we are all are in delirium. Just bear with me for the next 20 minutes. I'll try to finish it fast. So the outline of my topic would be introduction, definition, the risk factors, causes, pathophysiology, the subtypes, diagnosis, assessment, management, prevention, the PAD guidelines, and the trials. So previously, this has been asked many times in your FNB exams and also recently in the DRNB December 2022. So how is delirium assessed, prevented, and what is the management in the ICU? So before going to the actual topic, we'll just discuss a case because this delirium we'll be facing on a daily basis. So a 67-year-old gentleman who is a known case of diabetes came with a history of fever, cough, and breathlessness for 5 days. His COVID rapid antigen was positive. He was initially initiated on NIV and later he was intubated in view of severe respiratory distress and he was on mechanical ventilation. Initially, he required high levels of sedation, but at present, his sedation has been decreased. And we were assessing him and he was awake, but he was agitated, grimacing, trashing, and trying to sit up in the bed. He is unable to meet the spontaneous awakening and breathing trials. He makes eye contact, but is not following commands. So, coming to the introduction, delirium is the most common cause of agitation in the hospital, particularly in the ICU, which is nothing but a neuropsychiatric manifestation of a systemic disturbance. The incidence is around 20 to 50% in less severe ICU patients, whereas patients receiving mechanical ventilation, the incidence goes up to 60 to 80%. There is no diagnostic blood electrophysiological or imaging test to diagnose the delirium. Therefore, it actually remains as a clinical diagnosis. Coming to the definition, this was given by the American Psychiatric Association in the DSM-5 edition, and it has basically 5 features. One is there is disturbance in attention and awareness. And this disturbance actually develops over a short period of time and it fluctuates during the course of the day. The third one, there could be an additional disturbance in cognition. And the disturbances are not better explained by another pre-existing, evolving, or established neurocognitive disorder. And this disturbance is caused by a medical condition, either substance intoxication or withdrawal or a medication side effect. So these are the 5 diagnostic criteria to define a delirium. Additionally, there could be any psychomotor behavioral disturbances or emotional disturbances also. Now coming to the risk factors for delirium. So it is divided into a broad headlines as any baseline or a predisposing risk factor, acute illness or illness related factors, and the third one is ICU environmental or treatment related factors. It can be subdivided into non-modifiable and modifiable causes. So in any baseline risk factors, you have non-modifiable risk factors like advanced age, history of any cognitive impairment, or a number of comorbidities. In modifiable, you have alcohol misuse, use of any psychoactive drugs, benzodiazepine dependence, and smoking. Coming to illness-related factors, any high severity of illness score, especially the Apache score is high, then they are more at a risk for delirium, and patients at coma are at risk for delirium. Modifiable causes include hypotension, hypoxia, sepsis, metabolic disturbances, and post-op delirium. ICU environmental causes are mostly modifiable, and these include medication-induced coma, pain, immobility, the physical restraints which we use regularly, disorientation, sleep deprivation, isolation, and any indwelling catheter. Now, coming to this graph, this tells that the severity of the illness, that is Apache 2 score, and the age are independent risk factors for delirium. Also, the dose of lorazepam is also independent risk factor for delirium. Also, the other drugs like other types of benzodiazepines, opiates, propofol, anticholinergics, any psychiatric medications, all are at independent risk factor for delirium. Coming to the pathophysiology, there are 4 pathophysiological mechanisms. The main one is altered neurotransmitters. So an excess of dopamine or depletion of acetylcholine, which is a major contributor, and less commonly any alterations in GABA, serotonin, endorphins, and glutamate are the main pathophysiological mechanisms causing delirium. Other thing is systemic inflammation, which we usually see in sepsis. So this leads to systemic hypotension and hypoxemia, leading to impaired cerebral perfusion pressure, oxidative metabolism, and ischemia. In certain metabolic disorders, there is an availability of a large number of neutral amino acids, which leads to elevated levels of dopamine and norepinephrine, and the abnormal stress response leading to cortisol-related decline in cognition. As you see, so delirium can be caused due to any abnormality in a lot of neurotransmitters which are present in the brain. Now coming to the classification. So basically it is classified into 3 types: the hyperactive type, the hypoactive, and the mixed type. So hyperactive type is basically characterized by agitation, hypervigilance, irritability, lack of concentration, and attempting to remove any medical equipments. Hypoactive, they usually present as decreased responsiveness, withdrawal, hypokinesia, absence of or slowed speech, and apathy. Mixed is basically periods of hyperactivity and lethargy. So the most common type is the mixed type, which is around 64%, followed by the hypoactive type, which is around 35%. The hyperactive subtype actually contributes to less than 1%. Older age is a strong predictor of hypoactive delirium. The onset is usually on day 2, and it might prolong for around day 4. So this is a study which was done in 2007. So this shows that delirium is more common in age more than or equal to 65 years. And the most common type of form of delirium in older patients is hypoactive. So coming to the differential diagnosis of agitation, so we have to differentiate between delirium, dementia, depression, and schizophrenia. Coming to the delirium, it is an acute onset, and dementia is insidious, whereas depression and schizophrenia has a variable onset. And importantly, the course is fluctuating in delirium, whereas it is progressive and variable in the other forms. And delirium is usually reversible, whereas dementia is not reversible. The level of consciousness is impaired in delirium, depression, and schizophrenia, whereas in dementia, it is unimpaired until the late stages. And hallucinations are usually common in all the 4 types of differential diagnosis. Now, coming to the diagnosis, so why are we doing all these tests? Are just to rule out other underlying causes which leads to mimic as delirium. So we do the basic lab profile, the neuroimaging, the CSF analysis, EEG, toxicological screen, and ABG. Sometimes the biomarkers can be increased in cases of other CNS related infections or CNS related conditions. So even that has to be done to rule out the same. Now coming to the EEG, three landmark electrographic findings in delirious patients include: one is generalized slowing, and consistency of this slowing despite there is a wide range of underlying conditions. And the third is resumption of a normal rhythm with the treatment. So as I told, generalized slowing will be seen in the delta theta range. There is poor organization of the background rhythm, and there is loss of reactive changes to eye opening and closing, which are considered diagnostic for delirium. And the most important step in delirium management is the early recognition, which can be done with the assessment tools. So this is very important for you people, how to assess for delirium. So basically, delirium assessment is nothing but consciousness assessment. So consciousness is basically defined in 2 parts. One is the arousal level, one is the content of consciousness. This arousal level can be assessed by using the RAS score, the Richmond Agitation Sedation score, whereas the content of consciousness can be assessed by the CAM-ICU score. So at a deeper level of consciousness, that is RAS of -4 and -5, the patient is not responsive. So this is referred as either coma or stupor. And in those situations, we cannot do a CAM-ICU score, thus referring these patients as unable to assess. But at a lighter levels of consciousness, we can assess the CAM-ICU score. So this is the RAS. So we have 0 where the patient is alert and calm. So any positive numbers tells that the patient is restless, agitated, or combative. And any negative numbers show that the patient is drowsy, there is light sedation, moderate sedation. So as I told, if the RAS is more than or equal to -3, you can proceed with the CAM-ICU score. But in cases of -4 and -5, where the patient is deeply sedated or unarousable, we can't do a CAM-ICU, and hence you can label it as cannot be assessed. So this is about the first one is the level of consciousness, which is assessed by RAS. Second is about the content of consciousness, which is assessed by the CAM-ICU score, or there is one more score, the intensive care delirium screening checklist. But the most commonly used tool is the CAM-ICU in our ICUs. Now, this is the CAM-ICU. So it was created in 1990 and was intended to be a bedside assessment tool to assess for delirium. So it has 4 features. The first feature is if there is an acute change or a fluctuating course of mental status. And there should be a feature of inattention. So 1 and 2 should be present, and either an altered level of consciousness or a disorganized thinking should be present. So the diagnostic criteria is positive 1 + 2 and either 3 or 4. Now, anyways, we'll come to know if there is any acute change or a fluctuating course of mental status. Okay, so if it is present, then we see for an inattention. So how do we check for inattention? So you have to tell the patient to squeeze your hand when you say the letter A. Okay, so you have to spell some word, like if you spell save a heart, Okay, so ideally the patient should squeeze your hand 4 times. Okay, so if the patient either doesn't squeeze your hand with A or squeezes with other alphabet, then it is considered as an error. So if there is 0 to 2 errors, then the CAM ICU is negative, so there is no delirium. But if there are more than 2 errors, then you have to go for the third step, that you have to check the for any altered level of consciousness by the RAS score. If the RAS score is 0, okay, you have to go to the next level, that is a disorganized thinking. But if the RAS score is other than 0, so you have already the 3 criteria which are present. So the CAM ICU is positive, that is the patient has delirium. So suppose, as I told, if the RAS score is 0, you have to think, you have to go for the next step. You have to see whether the patient has a disorganized thinking. So you need to ask certain questions. The best is to ask, hold up these many fingers, like hold 2 fingers or hold 3 fingers. And if it doesn't, then it is well and good. If it doesn't, then the patient might be in delirium. So this is one more score, the intensive care delirium screening checklist. So it has a list of features, and each feature will take up a point of 1. And if a score of more than or equal to 4 is there, it is positive for delirium. Coming to the management. So what are the treatment goals? First is we have to look for it. Second is there should be a good communication between the nurses and the physicians. The third is you need to identify and treat the correctable risk factors. Fourth is you have to optimize the non-pharmacological interventions. And fifth is the pharmacological interventions. And the last and not the least is the goal-oriented sedation with daily wake-ups. So as I told, first you have to look for it. So we need to assess. As I told, assessment we have already seen. So you have to know something about the ICU triad for the patient comfort. So in order to keep a patient comfort, 3 things has to be addressed. One is the pain, the other one is the sedation, third one is the delirium. So as we see, this is a vicious cycle, the pain, delirium, and the sedation. Okay, so coming to the treatment, as I told, first you have to treat the underlying cause. So just to remember, there is a mnemonic whip into 2 times. So Wernicke's encephalopathy, withdrawal; hypertensive encephalopathy, hypoglycemia, or any metabolic or endocrine causes; I for infection and intracranial diseases; and P for poisons or porphyrias. So we have to rule out or treat the underlying cause. Second is the pharmacological management. So the most common drug which is used for delirium is the haloperidol, which is a butyrophenone typical antipsychotic that is recommended by the Society of Critical Care Medicine for delirium. The recommended starting dose is around 2 to 5 mg every 6 to 12 hours, either IV or perorally, with a maximum effective dose around 20 mg per day. What are the adverse effects which can be seen with this is the seizures or any electrophysiological seizures, neuroleptic malignant syndrome, tardive dyskinesia, prolonged QT interval leading to increased risk for torsades de pointes. You can also use atypical antipsychotics like vitapin, risperidone, and olanzapine. So some non-specific pharmacological treatment include thiamine if you have a suspected alcohol consumption or poor nutrition, adequate analgesia, opioid use should be minimized. There should be protocolized sedation or daily interrupted sedation, and dexmedetomidine and propofol can also be used. So dexmedetomidine is basically a selective alpha-2 adrenergic receptor agonist, which is used as a sedative as well as analgesia in the ICU. There are a number of RCTs which have demonstrated a significantly lower incidence of delirium when dexmedetomidine is used as a sedative agent compared to the remaining like midazolam, loraz, propofol, morphine, and even haloperidol. Whereas if you want for an acute chemical restraint, lorazepam or midazolam can be used. Coming to non-pharmacological management, so orientation like visual and hearing aids should be provided to them if they are using it before. You have to communicate and reorient frequently with the patient. You have to show them familiar objects, and a familiar patient people like relatives should be familiar enough to meet the patient. There should be consistent nursing staff, and if possible any music during the day would be helpful for these patients. Coming to the environmental factors, like sleep hygiene should be maintained, like during the night times light should be off and during day it should be on, and sleeping aids like earplugs or iPads can be given if required. There should be control of excessive noises at night. There should be optimization of the ambient temperature and early mobilization as soon as possible. Coming to the prevention. So prevention, you have pain management, early mobilization, improving sleep, pharmacological interventions, and the important thing is the ABCDE approach. So what is this ABCDE? So basically, AB is nothing but the awakening and the breathing trial, which should be coordinated. C is the choice of sedatives and analgesics. D is daily delirium monitoring. And E is early mobility and exercise. So when you follow these protocol, it helps in the early liberation from the ventilator, early ICU and hospital discharge, early return to the normal brain function, improved survival, and improved independent functional status. So as I told, the choice of sedative agents, better to avoid benzodiazepines, and you have to daily monitor the delirium by frequently addressing the modifiable or preventable risk factors and provide some non-pharmacological and pharmacological interventions. So as I told, what is this coordinated SAT and SBT protocol? SAT is spontaneous awakening trial and SBT is a spontaneous breathing trial. So this is a flow chart which is given. I'm not going to go in detail, just the headings I'll be mentioning. So first you need to see whether the patient is responsive to verbal commands. If yes, then you directly go to a spontaneous breathing trial. If not, you have to go for a spontaneous, that is SAT safety screen. So you have to rule out a lot of things, whether the patient is receiving sedatives, or whether the patient was receiving any neuromuscular blockades in the last 24 hours, or whether the patient is having any evidence of MI or any raise in intracranial pressure. If there is any of these is present, then you have to start from the beginning. Means you have to give a break, go for the next morning and assess again. If nothing is there in this, then you have to go for a spontaneous awakening trial after ruling out all of these things. So after the spontaneous awakening trial, so everything is good here. So you have to go for a spontaneous breathing trial safety screen, where you have to see a lot of ventilator as oxygenation, as well as the underlying vasopressor support, whether the patient is agitated. So if nothing is there, then if he meets all these criteria and everything is negative, you go to a spontaneous breathing trial. So there is something known as liberation and animation strategy, which showed that there is it decreases the incidence and duration of delirium. So what is liberation? Liberation uses target-based sedation protocols, which links SAT with SBT, and proper sedation regimes to reduce the harmful effects of sedative exposure. And what is animation? It refers to early mobilization of ICU patients, and this has been shown to reduce delirium and improve the neurocognitive outcomes. Now, as I told, initially there was this PAD guidelines, okay, which is basically the prevention of pain, analgesia, or agitation, and D is for delirium. This was in 2013. Later, the updated PAD guidelines have changed to PADIS guidelines, which involved the other two components. One is the immobility and one is the sleep disruption. So basically, the use of valid and reliable bedside tools for assessing pain, agitation, sedation, and delirium in ICU is the main goal of these guidelines. And to avoid a random polypharmaceutical approach to treating agitation of underlying unclear etiology, which frequently leads to oversedation in these patients, focusing more on evidence-based strategies for optimally managing critically ill patients, and achieving pain management first, then sedating as needed, that is known as Anglo sedation, and use of both pharmacological as well as non-pharmacological patient management strategies are the goals of this guidelines. So what are the statements and recommendations? I'll not be going in detail. You can later pause it and see as required. So these are the guidelines which are given for pain, agitation, and delirium. And coming to the ICU PAD care bundle. So how to assess pain, how to assess agitation, delirium, and how to treat and prevent the same. So please go through this when you have time. So coming to the trials and studies, so basically you have some 4 to 5 trials which are important for management of delirium. So one is the MENTS, which was um, basically done in 2007. Basically, it was evaluating dexmedetomidine and lorazepam infusions, and this has shown that dexmedetomidine infusion resulted in more days alive without delirium or coma. And the next one is the SEDCOM, that is safety and efficacy of dexmedetomidine compared with midazolam. So here they told that with the use of dexmed, there is an increased delirium-free days and decreased time to extubation and ICU length of days. The next trial is the MIND trial or MIND trial in 2010, which shows the use of haloperidol or ziprasidone as compared to placebo. And it showed that hypoactive or hyperactive delirium ICU did not significantly alter the duration of delirium. Next, the MIDEX and the PRODEX trial, which was in 2012. So they also told that the duration of this is basically MIDEX and PRODEX is with dexmedetomidine and midazolam. So they told that the duration of mechanical ventilation was significantly shorter for dexmed, and also the length of stay in ICU and assessment of patient arousal, cooperation, and communication was better with dexmed group. So this is a recent trial, the AID ICU trial, which was done in 2022 December. So here they have actually done a multicentric placebo-controlled trial where they used haloperidol, intravenous haloperidol, 2.5 mg 3 times a day, and placebo, and they showed that treatment with haloperidol did not lead a significantly greater number of days alive and out of hospital at 90 days than the placebo. And this is the same, the efficacy of haloperidol to decrease the burden of delirium in adult critically ill patients. This was published in 2023, the Eurydice trial, this is known as. So they compared haloperidol with the placebo, and they showed that haloperidol does not reduce the delirium in critically ill delirious adults. Now going to our case, Vignet, so we had so much thing. So now coming to the assessment. So as we told that the patient here is agitated, grimacing, trashing, and trying to sit up. So first we have to see the RAS score here. So if you see, the patient falls into a RAS 2. Okay. And then since the patient has RAS 2, we will go for the next step, the CAM ICU score. So we imagine that he squeezes hands on A once out of 4 times. Okay. So there will be 3 errors. As I told, if there are more than 3 errors, then patient might have delirium. So we have to go to the step 3 and 4. So step 3 is because his level of consciousness is altered, that is RAS is +2. Okay, there is already an inattentiveness present. So already 3 criteria are met. So need not to go for step 4. So here the patient is delirious. So basically coming to the last slide, the delirium protocol. So when you do the CAM ICU and the patient is delirious, you have to consider the other differential diagnosis. You have to remove any deliriogenic drugs and then go to some non-pharmacological protocols. If the patient falls into a RAS +2 to +4, see whether the patient has pain. If the patient has pain, you need to give analgesics. If the patient has no pain, then you have to give adequate sedation and then consider typical or atypical antipsychotics. If the patient falls with a RAS of 0 to +1, you have to ensure there is adequate pain control and you need to consider any typical and atypical antipsychotics. But if the patient falls into a negative, okay, that the patient is a lot of already sedated, you have to reassess the target sedation goal and perform the spontaneous awakening trial. And if he passes that, then you have to perform the spontaneous breathing trial. Thank you. So this completes your major topics in neurology and neurosurgery. So next week, we will be dealing with the cardiovascular system. So see you all on next Sunday. If you have any doubts, you can post it in the group. We will try to answer all your questions. Thank you.
Thank you for all the participants for staying up till that. I think so others can look into all the recorded session, and if any doubts are there, please feel free to call us back or text your particular the mentor. Thank you.
Thank you. Good night.